हल्ला क्यों मचा रहे हो तुम लोग? बॉस आ गए तो।
अरे यार तू चिल करना। वैसे भी 2-3 हफ्ते से पहले बॉस कहाँ आने वाले हैं।
अच्छा।
तो एक काम कर, आ बैठ। अरे बैठ ना यार, समोसा खा और मैच देख। अब आ।
बोल क्या हुआ?
इंडिया 105 को नो लॉस ब्रो।
ओके
गुड मॉर्निंग सर।
गुड आफ्टरनून।
गुड आफ्टरनून सर।
You guys are not happy I'm back?
नो सर, ओ मेरा मतलब है यस सर, लेकिन आप तो हॉस्पिटलाइज होने वाले थे ना सर, वो स्पाइन सर्जरी के लिए।
You're right. Hospitalized होने वाला था और शायद स्पाइन सर्जरी करा भी लेता, पर थैंक गॉड मैं हिंदुजा हॉस्पिटल पहुंच गया, जहां बाकी हॉस्पिटल स्पाइन सर्जरी के लिए सलाह दे रहे थे,
टेस्ट।
वहीं पर हिंदुजा हॉस्पिटल के हाईली एक्सपीरियंस्ड डॉक्टर्स ने मुझे कुछ
हेलो माइक चेक। हेलो माइक चेक। हेलो
स्पाइन सर्जरी की
हेलो
जरूरत
हाँ, वैसे मैंने भी सुना है हिंदुजा हॉस्पिटल में सर्जरी तभी करते हैं जब जरूरत हो।
बिल्कुल सही सुना।
का यूट्यूब है, उस पे लाइव है।
They do best.
तो वी आर लाइव।
बेटा महेंद्र नीड्स टू बी हॉस्पिटलाइज्ड इमीडिएटली। चलो बेटा घर चलते हैं।
पापा, डॉक्टर अंकल, आप 20 साल से पापा का ट्रीटमेंट कर रहे हैं, आप यहीं पे कुछ ट्रीटमेंट दे दीजिए ना।
बेटा ट्रीट तो कर रहा हूँ, लेकिन अब इनका ट्रीटमेंट क्लिनिक में
हेलो टेस्ट।
पॉसिबल
हेलो हेलो
इन्हें हॉस्पिटल में एडमिट करना बहुत जरूरी है। महेश भाई, हॉस्पिटल से क्या प्रॉब्लम है? डॉक्टर हॉस्पिटल से डर लगता है।
आजकल हॉस्पिटल्स के बारे में कैसी कैसी बातें सुनने को मिलती है।
देखो बेटा, तुम एक काम करो, महेश भाई को हिंदुजा हॉस्पिटल ले जाओ। They have the best of doctors care and best of medical infrastructure in the country. महेश भाई चिंता मत करो, जरूरत पड़ने पर मैं भी अपनी फैमिली को हिंदुजा हॉस्पिटल ही लेके जाता हूँ। वहाँ के डॉक्टर्स वही करते हैं जो पेशेंट्स के लिए सही है। अब तो ठीक है ना महेश भाई?
संजीव, अश्विन, हाय। कैसा है? मैं एकदम ठीक हूँ यार, लेकिन तू यहाँ कैसे? तूने तो नई हॉस्पिटल ज्वाइन कर ली थी। डोंट टेल मी तूने वहां से छोड़ के फिर से यहाँ ज्वाइन किया।
अरे नहीं यार, वैसी बात नहीं है। आई जस्ट केम हियर टू गेट डैड एडमिटेड।
क्या हो गया अंकल को?
यार कैंसर डिटेक्ट हुआ है।
But then why not a new hospital?
अब हाँ, मतलब मैं काम दूसरे हॉस्पिटल में करता हूँ, बट डैड के जैसे
हेलो,
कॉम्प्लेक्स केस के लिए मुझे
इधर ही
सिर्फ
है,
हिंदुजा हॉस्पिटल पे ही भरोसा है।
यार तू अब टेंशन मत ले, तेरे डैड अब हिंदुजा हॉस्पिटल की रिस्पॉन्सिबिलिटी है। हाँ तो तू जानता ही है, हिंदुजा हॉस्पिटल वही करेगा जो अंकल के लिए सही और बेस्ट होगा।
यार तुम लोगों की प्रेजेंटेशन कैसी थी? जस्ट 1 सेकेंड, मॉम इज कॉलिंग। हेलो, या मॉम?
बेटा, तेरे पापा का कल एक्सीडेंट हो गया है।
क्या? तुमने मुझे कल बताया क्यों नहीं?
सुन बेटा, तू घबरा जाती इसलिए नहीं बताया, पर अब वो स्टेबल है, लेकिन डॉक्टर का कहना है ब्रेन इंजरी है।
ब्रेन इंजरी?
और उन्हें सर्जरी के लिए किसी बड़े हॉस्पिटल लेके जाना पड़ेगा।
तो मॉम आप प्लीज जल्दी से उनको कानपुर से दिल्ली लेकर आओ।
दिल्ली नहीं बेटा, हम मुंबई के हिंदुजा हॉस्पिटल जाएंगे।
हिंदुजा हॉस्पिटल? वहीं जहाँ फूफा जी की सर्जरी हुई थी?
हाँ, याद है उनको कैसे बचा लिया था वहां के डॉक्टरों ने, और कितनी स्पेशल केयर की थी।
हाँ मॉम, पर
मुंबई के हिंदुजा हॉस्पिटल में ब्रेन सर्जरी के लिए बेस्ट डॉक्टर्स है और एडवांस्ड इक्विपमेंट्स भी है। हम वहीं जाएंगे।
सही कहा मॉम।
और तेरे फूफा जी का केस देखने के बाद तो मुझे सिर्फ हिंदुजा हॉस्पिटल पर ही भरोसा है। हल्ला क्यों मचा रहे हो तुम लोग? बॉस आ गए तो।
अरे यार तू चिल करना। वैसे भी 2-3 हफ्ते से पहले बॉस कहाँ आने वाले हैं।
अच्छा।
तो एक काम कर, आ बैठ। अरे बैठ ना यार, समोसा खा और मैच देख। अब आ।
बोल क्या हुआ?
India 105 for no loss, bro.
Okay. Okay.
Oh no. Good morning, sir.
Good afternoon.
Good afternoon, sir.
You guys are not happy I'm back?
No, sir. Oh, मेरा मतलब है, yes, sir. लेकिन आप तो हॉस्पिटलाइज होने वाले थे ना सर, वो स्पाइन सर्जरी के लिए।
You're right. Hospitalized होने वाला था और शायद स्पाइन सर्जरी करा भी लेता, पर थैंक गॉड मैं हिंदुजा हॉस्पिटल पहुंच गया। जहां बाकी हॉस्पिटल स्पाइन सर्जरी के लिए सलाह दे रहे थे, वहीं पर हिंदुजा हॉस्पिटल के हाईली एक्सपीरियंस्ड डॉक्टर्स ने मुझे कुछ मेडिसिन प्रिस्क्राइब की, फिजियोथेरेपी के लिए कहा और ये भी बताया कि मुझे इस वक्त स्पाइन सर्जरी की जरूरत ही नहीं।
हाँ सर, वैसे मैंने भी सुना है हिंदुजा हॉस्पिटल में सर्जरी तभी करते हैं जब जरूरत हो।
बिल्कुल सही सुना है। They do what is best for you.
बेटा, my boy needs to be hospitalized immediately. चलो बेटा, घर चलते हैं।
पापा, डॉक्टर अंकल, आप 20 साल से पापा का ट्रीटमेंट कर रहे हैं, आप यहीं पे कुछ ट्रीटमेंट दे दीजिए ना।
बेटा, ट्रीट तो कर रहा हूँ, लेकिन अब इनका ट्रीटमेंट क्लिनिक में पॉसिबल नहीं है। इन्हें हॉस्पिटल में एडमिट करना बहुत जरूरी है। महेश भाई, हॉस्पिटल से क्या प्रॉब्लम है? डॉक्टर, हॉस्पिटल से डर लगता है।
आजकल हॉस्पिटल्स के बारे में कैसी कैसी बातें सुनने को मिलती है।
देखो बेटा, तुम एक काम करो, महेश भाई को हिंदुजा हॉस्पिटल ले जाओ। दे हैव द बेस्ट ऑफ डॉक्टर्स केयर एंड बेस्ट ऑफ मेडिकल इंफ्रास्ट्रक्चर इन द कंट्री। महेश भाई, चिंता मत करो, जरूरत पड़ने पर मैं भी अपनी फैमिली को हिंदुजा हॉस्पिटल ही लेके जाता हूँ। वहां के डॉक्टर्स वही करते हैं जो पेशेंट्स के लिए सही है। अब तो ठीक है ना महेश भाई? बेटा my boy needs to be hospitalized immediately. चलो बेटा घर चलते हैं।
पापा, डॉक्टर अंकल, आप 20 साल से पापा का ट्रीटमेंट कर रहे हैं, आप यहीं पे कुछ ट्रीटमेंट दे दीजिए ना।
बेटा ट्रीट तो कर रहा हूँ, लेकिन अब इनका ट्रीटमेंट क्लिनिक में पॉसिबल नहीं है। इन्हें हॉस्पिटल में एडमिट करना बहुत जरूरी है। महेश भाई, हॉस्पिटल से क्या प्रॉब्लम है? डॉक्टर, हॉस्पिटल से डर लगता है।
आजकल हॉस्पिटल्स के बारे में कैसी कैसी बातें सुनने को मिलती है।
देखो बेटा, तुम एक काम करो, महेश भाई को हिंदुजा हॉस्पिटल ले जाओ। दे हैव द बेस्ट ऑफ डॉक्टर्स केयर एंड बेस्ट ऑफ मेडिकल इंफ्रास्ट्रक्चर इन द कंट्री। महेश भाई चिंता मत करो, जरूरत पड़ने पर मैं भी अपनी फैमिली को हिंदुजा हॉस्पिटल ही लेके जाता हूँ। वहां के डॉक्टर्स वही करते हैं जो पेशेंट्स के लिए सही है। अब तो ठीक है ना महेश भाई?
हे संजीव।
अश्विन हाय, कैसा है यार?
मैं एकदम ठीक हूँ यार, लेकिन तू यहाँ कैसे? तूने तो नई हॉस्पिटल ज्वाइन कर ली थी। डोंट टेल मी तूने वहां से छोड़ के फिर से यहाँ ज्वाइन।
अरे नहीं नहीं यार, वैसे बात नहीं है। आई जस्ट केम हियर टू गेट डैड एडमिटेड।
क्या हो गया अंकल को?
यार कैंसर डिटेक्ट हुआ है।
देन व्हाई नॉट योर न्यू हॉस्पिटल?
अब हाँ, मतलब मैं काम दूसरे हॉस्पिटल में करता हूँ, बट डैड के जैसे कॉम्प्लेक्स केस के लिए मुझे सिर्फ हिंदुजा हॉस्पिटल पे ही भरोसा है।
यार तू अब टेंशन मत ले, तेरे डैड अब हिंदुजा हॉस्पिटल की रिस्पॉन्सिबिलिटी है। हाँ तो तू जानता ही है, हिंदुजा हॉस्पिटल वही करेगा जो अंकल के लिए सही और बेस्ट होगा।
यार तुम लोगों की प्रेजेंटेशन कैसी थी? जस्ट 1 सेकेंड, मॉम इज कॉलिंग। हेलो, या मॉम?
बेटा, तेरे पापा का कल एक्सीडेंट हो गया है।
क्या? तुमने मुझे कल बताया क्यों नहीं?
सुन बेटा, तू घबरा जाती इसलिए नहीं बताया, पर अब वो स्टेबल है। लेकिन डॉक्टर का कहना है ब्रेन इंजरी है
ब्रेन इंजरी?
और उन्हें सर्जरी के लिए किसी बड़े हॉस्पिटल लेके जाना पड़ेगा।
तो मॉम आप प्लीज जल्दी से उनको कानपुर से दिल्ली लेकर आओ।
दिल्ली नहीं बेटा, हम मुंबई के हिंदुजा हॉस्पिटल जाएंगे।
हिंदुजा हॉस्पिटल? वहीं जहाँ फूफा जी की सर्जरी हुई थी?
हाँ, याद है उनको कैसे बचा लिया था वहां के डॉक्टरों ने, और कितनी स्पेशल केयर की थी।
हाँ मॉम, पर
मुंबई के हिंदुजा हॉस्पिटल में ब्रेन सर्जरी के लिए बेस्ट डॉक्टर्स है और एडवांस्ड इक्विपमेंट्स भी है। हम वहीं जाएंगे।
सही कहा मॉम।
और तेरे फूफा जी का केस देखने के बाद तो मुझे सिर्फ हिंदुजा हॉस्पिटल पर ही भरोसा है।
हल्ला क्यों मचा रहे हो तुम लोग? बॉस आ गए तो।
अरे यार तू चिल करना, वैसे भी 2-3 हफ्ते से पहले बॉस कहाँ आने वाले हैं। तू एक काम कर, आ बैठ। अरे बैठ ना यार, समोसा खा और मैच देख।
बोल क्या हुआ?
इंडिया 105 पर नो लॉस ब्रो।
Okay.
Oh no.
गुड मॉर्निंग सर।
Good afternoon.
गुड आफ्टरनून सर।
You guys are not happy I'm back?
नो सर, ओ मेरा मतलब है, यस सर, लेकिन आप तो हॉस्पिटलाइज होने वाले थे ना सर, वो स्पाइन सर्जरी के लिए।
You're right. Hospitalized होने वाला था और शायद स्पाइन सर्जरी करा भी लेता, पर थैंक गॉड मैं हिंदुजा हॉस्पिटल पहुंच गया। जहां बाकी हॉस्पिटल स्पाइन सर्जरी के लिए सलाह दे रहे थे, वहीं पर हिंदुजा हॉस्पिटल के हाईली एक्सपीरियंस्ड डॉक्टर्स ने मुझे कुछ मेडिसिन प्रिस्क्राइब की, फिजियोथेरेपी के लिए कहा और ये भी बताया कि मुझे इस वक्त स्पाइन सर्जरी की जरूरत ही नहीं।
हाँ सर, वैसे मैंने भी सुना है हिंदुजा हॉस्पिटल में सर्जरी तभी करते हैं जब जरूरत हो।
बिल्कुल सही सुना है। They do what is best for you.
बेटा my boy needs to be hospitalized immediately. चलो बेटा घर चलते हैं।
पापा, डॉक्टर अंकल, आप 20 साल से पापा का ट्रीटमेंट कर रहे हैं, आप यहीं पे कुछ ट्रीटमेंट दे दीजिए ना।
बेटा ट्रीट तो कर रहा हूँ, लेकिन अब इनका ट्रीटमेंट क्लिनिक में पॉसिबल नहीं है। इन्हें हॉस्पिटल में एडमिट करना बहुत जरूरी है। महेश भाई, हॉस्पिटल से क्या प्रॉब्लम है? डॉक्टर, हॉस्पिटल से डर लगता है।
आजकल हॉस्पिटल्स के बारे में कैसी कैसी बातें सुनने को मिलती है।
देखो बेटा, तुम एक काम करो, महेश भाई को हिंदुजा हॉस्पिटल ले जाओ। दे हैव द बेस्ट ऑफ डॉक्टर्स केयर एंड बेस्ट ऑफ मेडिकल इंफ्रास्ट्रक्चर इन द कंट्री। महेश भाई, चिंता मत करो, जरूरत पड़ने पर मैं भी अपनी फैमिली को हिंदुजा हॉस्पिटल ही लेके जाता हूँ। वहाँ के डॉक्टर्स वही करते हैं जो पेशेंट्स के लिए सही है। अब तो ठीक है ना महेश भाई?
हे संजीव।
अश्विन, हाय। कैसा है यार?
मैं एकदम ठीक हूँ यार, लेकिन तू यहाँ कैसे? तूने तो नहीं हॉस्पिटल ज्वाइन कर ली थी। डोंट टेल मी तूने वहां से छोड़ के फिर से यहाँ ज्वाइन।
अरे नहीं नहीं यार, वैसे बात नहीं है। आई जस्ट केम हियर टू गेट डैड एडमिटेड।
क्या हो गया अंकल को?
यार, कैंसर डिटेक्ट हुआ है।
देन व्हाई नॉट योर न्यू हॉस्पिटल?
अब हाँ, मतलब मैं काम दूसरे हॉस्पिटल में करता हूँ, बट डैड के जैसे कॉम्प्लेक्स केस के लिए मुझे सिर्फ हिंदुजा हॉस्पिटल पे ही भरोसा है।
यार तू अब टेंशन मत ले, तेरे डैड अब हिंदुजा हॉस्पिटल की रिस्पॉन्सिबिलिटी है। हाँ तो तू जानता ही है, हिंदुजा हॉस्पिटल वही करेगा जो अंकल के लिए सही और बेस्ट होगा।
यार तुम लोगों की प्रेजेंटेशन कैसी थी? जस्ट 1 सेकंड, मॉम इज कॉलिंग। हेलो, या मॉम।
बेटा, तेरे पापा का कल एक्सीडेंट हो गया है।
क्या? तुमने मुझे कल बताया क्यों नहीं?
सुन बेटा, तू घबरा जाती इसलिए नहीं बताया, पर अब वो स्टेबल है। लेकिन डॉक्टर का कहना है ब्रेन इंजरी है
ब्रेन इंजरी?
और उन्हें सर्जरी के लिए किसी बड़े हॉस्पिटल लेके जाना पड़ेगा।
तो मॉम आप प्लीज जल्दी से उनको कानपुर से दिल्ली लेकर आओ।
दिल्ली नहीं बेटा, हम मुंबई के हिंदुजा हॉस्पिटल जाएंगे।
हिंदुजा हॉस्पिटल? वहीं जहाँ फूफा जी की सर्जरी हुई थी?
हाँ, याद है उनको कैसे बचा लिया था वहां के डॉक्टरों ने, और कितनी स्पेशल केयर की थी।
हाँ मॉम, पर
मुंबई के हिंदुजा हॉस्पिटल में ब्रेन सर्जरी के लिए बेस्ट डॉक्टर्स है और एडवांस्ड इक्विपमेंट्स भी है। हम वहीं जाएंगे।
सही कहा मॉम।
और तेरे फूफा जी का केस देखने के बाद तो मुझे सिर्फ हिंदुजा हॉस्पिटल पर ही भरोसा है।
हल्ला क्यों मचा रहे हो तुम लोग? बॉस आ गए तो।
अरे यार तू चिल करना, वैसे भी 2-3 हफ्ते से पहले बॉस कहाँ आने वाले हैं। तू एक काम कर, आ बैठ। अरे बैठ ना यार, समोसा खा और मैच देख।
बोल क्या हुआ?
इंडिया 105 पर नो लॉस ब्रो।
Okay.
Good morning. Sorry. So, on behalf of Hinduja Hospital and Caho, I'd like to welcome you to today's one-day regional conclave, patient engagement, patient first. As you all know, Caho and Hinduja Hospital both actually champion quality initiatives to, improve patient care. So, for this, to further this, we have several power pack sessions. You can see the agenda behind your badge. There's a QR code there. So, I hope you enjoy the session. So, let us start. Bhavisha.
So thank you, Preeti, and a very warm welcome to everyone. I'm Bhavisha, Assistant Director of IPD and Special Projects at Hinduja Hospital, and extremely honored to start the first panel discussion of this beautiful morning today. To give a brief introduction, gathering here would agree with me that with evolving healthcare delivery, patient experience is the buzzword, which has taken significant significance. What used to matter covertly to patients now matters quite obviously to the provider, the payer, and all the stakeholders. To understand the nuances, let's start the first panel on PREM, Patient Experience Matters. I invite Mr. Joy Chakraborty, Regional Head Western Region Caho, and COO PD Hinduja Hospital to take the proceeding ahead. Welcome, sir.
Good morning, everyone. On behalf of Caho and Hinduja Hospital, my personal behalf, I want to welcome all of you in this morning, and nice to see that all of you have taken time out and come here to attend these power-packed sessions throughout the day. I'm sure that our endeavor to showcase some of the initiatives, discussion, and deliberations on patient experience and patient engagement is going to take you through some of the areas from where we can learn. All of us we can learn, and I have three eminent panelists, and though I had the fourth one, Dr. Lalu Joseph, the secretary for Caho, she couldn't able to make it. And the reason I want to share, because we have several Caho governing council and members present here. Caho is like a family, and we have lost one of our very important member of the family. And you can see that Dr. who is popularly known as Dr. Dr. Joseph, uh, who was preparing for his marathon, and at the age of 39, during that preparation, he suddenly passed away, and we feel deeply sorrow for this loss, and our thoughts and our support we extend to the family. And I request all of you to stand up for a minute of silence. Thank you. So with this, we are going to start our first session, which is PREMS, the patient experience matters. And all of us are, familiar with these PROMs, that patient reported outcome measures, and which has become part of the NABH accreditation since the 5th standard have come, and many of us are struggling to, work on that front and comply with this. But at the same time, I think much more focused method of PREMS, that is patient reported experience measures, which is taking the center stage today, as on today, for the healthcare delivery. So we are going to have a deliberation for next 50-55 minutes. So I want to welcome on the stage my esteemed panelist, Colonel Dr. Sujit Chatterjee, CEO, Hiranandani Hospital. Dr. Santosh Shetty, Executive Director and CEO, Kokilaben Dhirubhai Ambani Hospital. I have Dr. Milind Khatke, the Medical Director of Jupiter Hospital. Joslok Hospital, sorry. I hope it is not matter.
Hello, mic check. Hello, mic check. Hello, mic check. Hello, 1, 2, 3. Hello, mic check. Hello.
So, I think it is not a bad sound, because any good auspicious event can start with the sound of conch. So it was a sound of conch, how it has come. So patient reported experience measures. If some of you are not aware, I'm going to little bit extend, and then I'll come to the panelist. We have seen traditionally in any sector, any industry, it started with, quality checks. We looked at the quality after the production of certain things, the quality checking have taken place, things got rejected. Then we have seen over a period of time, total quality management. Then in healthcare, NABH like accreditation came. Just before that, JCI was there. So we have constantly worked towards improving quality. We started looking at what are the different frameworks in which we should work and how we can improve it further. Recently, as I told in NABH 5th edition, we got PROMs, patient-related outcome measures. We started looking at after the patient discharge that whatever outcome has come, that those outcomes, how it is giving satisfaction, how those outcomes are meeting your patient treatment parameters, how satisfactory outcomes are this. But today, the other part, which is patient satisfaction, when we measure soon after discharge, we come across certain results and we conclude in this way that patient during the stay, they are happy with this, not happy with that. But the most recent trend and this kind of project has been taken in few hospitals in the country so far, and CMC Vellore was one of the leading one, and that is the reason Dr. Ladulu Joseph, who heads and leads the program, we thought of getting her here. They have done projects on PREMS, and like that, some of the hospitals have done. And what is PREMS? It is like a perception study during the patient stay about regarding what kind of experience they have, good and bad. You get something like a life kind of thing, and mostly you correlate that with your inputs, that is what kind of care services what you are extending. You compare with that, and then you can study the both and look at where all you have opportunity to improve your services. So with this background, I'm going to start this panel, and first I'm going to go to Colonel Dr. Sujit Chatterjee. And see, we have, just to save the time, we have not made a elaborate introduction of the panelists, and he's there probably for more than a couple of decades with Hiranandani Hospital and in this city. If I'm not wrong, the first hospital to get NABH accreditation. And when they got it, at that time exactly landed in Mumbai, and it was a major, I should say, landmark for the private hospitals in Mumbai when they achieved it. So the question to you, that when patient experience is becoming one of the buzzwords and everybody is working towards that, what do you think? Is it that patient satisfaction, what the traditional way we measure post discharge, versus conducting and trying to identify their expectations during the stay? What is going to work, and what do you see as a future, how it is going to evolve? So over to Dr. Chatterjee.
Thank you, Joy. Thank you very much. Thank you, Gautam, for being here, and my esteemed panelists, Santosh, as well as Dr. Milind. I have a question actually, and let me start with the question to the audience. How can you even deny prem is important? Can anyone say that there should be no love? Prem is important. So therefore, this is a very important topic. Now, Joy, you mentioned experience and satisfaction. I think I want to differentiate between the two. I think experience and satisfaction, sometimes we use it, simultaneously. So, I mean, interchangeable. It is not so. Experience is what I have when, I lay down policies, procedures, etc., and we deliver the same to the patient, and the patient says, "Ha, theek hai, okay, whatever you promised, you got." So that is my experience. But satisfaction ki man ki kamana. I wanted to get this, but I didn't get this, and so therefore that little difference comes in. So you've got your experience and you've got your satisfaction. And Joy, what happens typically, and Santosh and Milind will agree with me, that unfortunately, it is not only one interaction, it is also care of continuum. So therefore, at every touch point, this has got to be adhered to. So therefore, it is very linked to your culture. So I think that, trying to get these things sort of sorted, what we started doing in our hospital was we started focusing on culture, the culture of patient first, patient, as I said, experience, satisfaction. I don't know, I mean, मेरे माँ ने सोचा था कि ऐसा होगा, आपने वो किया ही नहीं. So ठीक है भाई, वो किया नहीं, हमें थप्पड़ मारो और क्या. So therefore that is something that we focused on, the culture. The culture is, if you can make it patient-centric, and at the same time, what you do is you get every staff to endorse the fact that I will follow this culture. Now, if you can do that, I mean, it's a Herculean task, but if you can do that, then I think the satisfaction levels might start definitely rising. And you've got to measure it. I mean, there are various methods, there are various tools which have been organized by which you measure. So therefore, I think as my opening comment, Joy, like you asked me, and I think I would like to, close it over here and give my panelists a chance, because Chatterjee with a mic, it's a disaster. So I think, Joy, you could.
Thank you. And Colonel Chatterjee, as you started in a very, so you have mentioned about prems. I think it has been told in a very lighter way, but I think days are not far when we have to be very careful. I'm sure some of you who are in the senior level, you are seeing there is a huge fight is going on with Supreme Court directions in terms of regularizing price, regularizing tariff for hospital, what we should charge. I don't know what will be the outcome finally, but it has been already seen in some of the Western world countries where the patient bills reimbursement from insurance happens only against patient satisfaction score or their experience scores, what has been submitted through an independent party to the insurance companies. I think the time has come when we need to gear up for that. So with this, I move on to Dr. Shetty. He is the executive director, CEO, and again, I think more than 15, 16 years with Kokilaben Hospital, one of the first hospitals in the city who got NABH plus JCI together. Am I right? So they have imbibed the culture of quality, safety, and I'm sure during the process, they got the patient experience, patient quality, all these aspects under, they have framed and they have created that kind of situation, the ambience, the environment. So the question to you is going to be that when you work for the national and international accreditation, when you try to bring up the culture, you get a segment of patients in your hospital, what importance you give to this patient experience, how do you engage with them, and what do you think is the future of the patient experience, patient engagement kind of models in Indian healthcare?
Yeah, thank you, Joy, for the question, and good morning to all. And at the outset, I'd like to compliment Caho and Hinduja Hospital for putting this together, the focus on patient experience and prems. And I was chatting with Dr. Suganti, and she said, first best thing is patient se prem karo. I think that is the that is the way forward, and I'm sure that will make her life more easier. If you end up with definitely much less litigation. So when you talk of patient engagement, like you rightly said, we all use these words: patient satisfaction, patient experience, patient engagement very loosely, but each one of them is very, very closely interlinked. Patient engagement is one of the key pillars towards patient experience and patient satisfaction. And when you talk of patient engagement, it has to happen at all levels. Every patient touch point is an opportunity for engagement. And when you talk of engagement, there are various steps in the patient engagement process. I mean, first and foremost is awareness. I mean, how do you make the patient aware of, what his condition is, what is he suffering from? Does he understand, what he's going through, what is going to be the likely course forward? That's what I call as awareness. And sometimes, especially in our Indian context, it's not just the patient, but also the family who have to be part of this whole patient engagement process. After awareness, I would say the next step is what I call as shared decision making. So how do you engage with the patient? Let him know that, okay, these are your medical issues. These are the various treatment options. And what is it that would be option one? What is it that it would be option two? So shared decision making is again a very, very important element in this whole process. And very often we end up making it a one-way thing. Okay, the clinician comes and says, okay, this is what I'm going to do, without really explaining to him that these are the 1, 2, 3 options. These are the benefits of 1, 2, 3. I mean, so that I would say is the second phase of patient engagement. The third phase, which I think is the most ideal, which I'm sure more educated populations look at, is self-management. So, when we move towards chronic conditions, self-management becomes a very, very important part. So if you talk of diabetes, if you talk of asthma, if you talk of hypertension, how does the patient take charge of his own health? And how does the institution or the doctor assist him or her in that process? So, you use technological aids to monitor patients so that patients know that, okay, this is the level of sugar that I have to maintain. This is the level of blood pressure that I have to maintain. And beyond this, this is what I need to seek out to. We saw some experiences of this in COVID because patients started taking more control of their health using devices. Everyone was checking their oxygen saturation or temperature. This is nothing else but a way of patient engagement where patient is involved and taking a more active part in his care. Like what Joy rightly mentioned, we are slowly moving to an era of higher regulation towards pricing, higher regulation towards patient experience. And when we look at the Western world, we are talking of fixed reimbursement models where independent of the stay in hospital, independent of whatever have been the complications, you will get a fixed reimbursement for a patient. So hospitals will be under more and more pressure to ensure that they are able to provide ideal care with optimum resources. And that is where patient engagement will have a very, very key role to play. How do you engage with patients to make sure they understand everything, they stay compliant to their medications, they follow whatever are the protocols, so that this will help in reducing the length of stay, will be able to send out patients quicker, and will reduce cost to hospitals, cost to patients. So patient engagement, I would say, is a much larger picture towards not just quality of care, but also costs. And like I say, patient engagement is the best pill that very often doctors and hospitals don't use.
Thank you, Dr. Shetty. And you have touched upon a very important point, and I feel that is patient in terms of engagement, making them to part or shared in the decision-making process. So in my panel, I have one person who is from the clinical side, so Dr. Milind. He looks at it from a different, perspective as a head of medical services for a big hospital like Jaslok. So when you involve your clinicians or you get your patients in the treatment process to ensure they are engaged or they are part of the shared decision making, you might have taken certain steps. So my question is, how important it is, and what kind of steps do you advise a healthcare provider to undertake to ensure patient satisfaction, they are engaged patient with you from clinical point of view?
Right. Good morning, all. And first, let us understand we are in a business of serving patients. We are basically treating patients. So the 90% of the experience component comes from the medical and the nursing team. And that is the reason why these teams have to be more involved in providing the experience that the patient is looking at. So for any touch point in the hospital, as multiple things have been said about multiple touch points. So the clinical services also have multiple touch points, and at any point of time, if there is a uh, experience that happens, it can either lead to uh, a magic, or it can either be a misery, a moment of magic or moment of misery. So that is the reason why everybody in the hospital, right from the front desk or even uh, the reception to the clinical care people, personnel, should be involved in giving that particular experience to the patient. So when we talk of clinicians in getting involved in the uh, 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 judgment or the treatment and giving that particular experience. So this can be done in a particular way, in the sense that they are always talking one sided. They are one sided. They have to be they have to involve the other side, the patient and the patient relatives. They have to talk to them. So basically what the patient wants is five things: hear me, know me, explain to me, then coordinate for me, and then make things easier for me. And these are the five principles that everybody in the hospital should follow. And doctor is also part of it. The nurses are also part of it. When the patient is getting admitted, the patient has to have a level of before admission, he should have information about the hospital. There should be ease of appointment, ease of getting the appointments, the ease of coming inside. Even the clear signages are very important when they come to the hospital. And when they reach the hospital, inside the hospital, they have to uh, they have to have that kind of security that I will be taken care of appropriately. So the prior communication, the doctors and the nurses have to appropriately communicate clearly and compassionately about the diagnosis, the treatment, the options of the options available, the alternatives available, as well as the complications that may occur. So many times, I must not say, but when I'm sitting in the committee for local authorization committee, the patient for transplant, the donor is told nothing will happen to you. Now, nothing will happen to you is good, very good, compassionately, but it does percentage, there is still 1 or 2% chance that the donor may have complications, and it can be it can be told to them in a very different way that there is a chance, but most of the time nothing happens. So this is how the patient also feels comfortable, but he still knows that there is a chance. So the communication in a compassionate way is very important. And secondly, when in the hospital, uh, we talk of patient safety. There is a component called, there are sometimes the patient suddenly has emergencies when in the ward, etc. So a rapid response team has to be implemented. Like what in our hospital we have before the code blue team, there's a rapid response team. So rapid response team will immediately look at the early warning signs. The nurses, or based on the early warning signs, involve the rapid response team, and the decision of whether shifting the patient to ICU or treating the patient and stabilizing in the ward is taken. So in that case, what we did was the early warning signs we have, as per our requirement, we have modified the early warning signs. So the rapid response team has comes up early. It involves some ICU intensivist, it involves a physician, etc. And that is the experience that a patient is coming for. Not, I mean, this has really helped us save the code blues. I mean, the code blue numbers have reduced to half after we have introduced the rapid response team. And in fact, we have modified the criteria of rapid response team. So these are some ways we can look at giving a experience from the clinical point of view.
Thank you, Dr. Khatke. And you touched upon the example, and I'm taking the example of local authorization committee, where I understand the recipient has not been, donor has not been briefed about the possible complexities, and at the same time, You told about some of the minor actions, what can completely change the, perspective of a patient towards the healthcare provider or the clinicians. And I must tell you that one of the big four consulting firms, they did same survey in a gap of 4 years. And I'm just taking only two questions, what they asked and their answers, that how much do you trust your the hospital and how much you trust your clinicians. And you'll be surprised to know that 53% of them in the second survey told they don't trust the hospital, and 57% they said they don't trust the clinicians. So that is the kind of scenario within these four walls. All of us are in the one side, the other side of the team is not here present. So we can talk about it. So if that is the scenario, I think many of us, including in our hospital, we try to get into multiple level, like patient complaint escalation. How do you mitigate that? How do you do that on live basis? So things doesn't get, escalated, and things doesn't go out of your hand, doesn't go out of your control, whether taking, your so-called consent form in language. How do you explain? How much do you don't explain? All these have been taken through a huge rigid manner to ensure those kind of compliances. So with this, I want to come to the second round to Colonel Dr. Sujit Chatterjee. The question is, in Hiranandani Hospital, whatever best practices you have inculcated so far to involve, engage patients, improve patient experience, if you can share with the audience.
Yes, sure. I will give two examples before I dilate further. Two examples, and these are live examples. Suganti had mentioned that love your patient. So therefore, isn't that what you said, Santosh? Yeah, right. Patient se prem karo, to वही तो हो गया ना. Patient se prem karo. So therefore, let's understand this. Now, way back, I'm talking about now, in the 90s, when I was in the armed forces. At that time, staying in a place which was just opposite the Holy Family Cathedral in Colaba. And one of my neighbors had fallen sick, and they said, we have a family doctor. So this family doctor's name was Toprani, and he came there, and I was there, and the way he handled the whole family. I mean, he came in and asked, how the children. He seemed to know the children's name. He said, you have a pet. He never asked about the patient straight away. He was talking about how's the mother, how's this, how's that. And then very gradually he approached the patient. By that time, I could actually see, complete transformation in the lady who was very anxious. And he prescribed, I think I had put a patient on Augmentin, and he just changed that around to Ciplox. And the next day, the girl said that I'm fine. I said that, it's not the medicine, but it was Toprani. The way he handled the situation, look at the amount of confidence he generated. I was reading Farooq Udwadia's book, The Tabiyat. In Tabiyat, he mentions that you're practicing science, but learn the art of practicing science. Now, let me come down to my hospital. And again, as Santosh alluded to COVID, I had a father and a son who were admitted with COVID. And the son wasn't doing well. And the father was getting better. And the son was going down. And I contacted the family, and there were some sisters. And I told them that, look, we're in trouble. So they said, no, try your best, etc. Then the day came for the father to be discharged. And this is the question that he asked me. Please hurry up with my son's discharge, as we need to go home. How do you tell a father that your son is in the morgue? That was my challenge. But I had these girls with me. And we jointly approached the father. We jointly approached the father. I mentioned about what we had done by way of medicine, what we had given, etc., what his conditions were. But the daughters hugged the father and he was crying and saying, "What will I tell your mother?" Love your patient. Love your patient. So we told him that we tried to, I couldn't, the girls did. And then he went home. 2 weeks later, I got a letter. And it was handwritten and it was on a small piece of paper. He says, when you were saying that patients don't trust the doctor and patients don't trust hospitals, 53, 57%. The letter clearly stated this. He says, thank you for looking after me and thank you for looking after my son and being the family away from the family. So I thank you so much. So now, Joy, coming down to what are the things that we've set up. There are certain things that I was very influenced when the Tabiat first came out, the book first came out. I mean, I was there at Breach Candy and Dr. Farooq Udwadia had given me, he said, "I've written this book." And, I said, "Thank you very much, sir." And some of the things that we have tried to do is try to get the doctor on time, In the OPD, the doctor should be on time. Now, suppose I have 4 consultants. All 4 consultants don't have to start their OPD on the same time. One starts early and the others can take their rounds, whatever, and then come and start their OPDs also. The second part of it is that I've tried to tell all the people that, please try and engage in a little bit of conversation. Don't look at your screen. I mean, sometimes it goes down very well. Sometimes they said, "Who the hell are you to tell me?" I mean, I've had 25 years of medicine behind me. So I tell them I've had 47 years of medicine behind me and I'm telling you this. Don't look at your screen, damn it. Look at the patient, at least give a smile. So if you smile at a patient, it makes the world of difference. Thereafter, please talk in simple terms. Now, there was a patient who had thyroiditis. And the thyroiditis was detected, clinically, and he had, had a test done, the thyroid profile, and it goes to show extremely low TSHs, and so therefore the diagnosis of thyroiditis. Now the physician turned around and told him that you have tachycardia. So he came to my office, just knew him. मेरा इसमें टैची कुछ था. सर टैची कौन था? He said, टैची. So I said, टैची यानी कि क्या? He said, no, मेरा हाथ पकड़ के मेरे बोले टैची है. So I said, हाँ, correct. आपकी जो नस की रफ्तार है ना वो तेज है. So that's another thing that, I thought that it is extremely important to understand this. Please understand that if you want your patient to come back to you, there is going to be care continuum. And if you do not, at the first visit, when a patient comes to visit you, it can always start with the front office. ठीक है ना, वो आप वहाँ जाके बैठो. Why don't you please sit there? Another culture that I have tried to develop, Joy, is that if somebody asks me for directions, I would take them there. Now, if I'm walking in the passage and somebody says, "Where is pathology?" and my head of pathology is sitting over here, I bring them to the pathology lab. He says, "This is pathology." I mean, I know that your distances are huge, but my distances are not very huge. And why can't I take this thing? Why do I have to be vainglorious and just, oh, it's there? Take him there. So this is a huge confidence building measure that you have. Please understand that all the records of the patient don't keep on asking them time and time again, because you can always, give a side glance at the screen and say, yeah, last time you had come with, a little pain in your headache. So I think the headache has settled down. Now, how are you feeling? Doctor remembers me. Doctor remembers me. So, these are the forms of engagement that we are trying to do. So we're trying to set up many processes by which people have to toe this line to win the confidence of the patient. Now, your processes in the hospital. What are the 3 pain points? My father was a doctor. He's taught me only 3 things. The first thing as a doctor, he's told me, Agarwal Sahab will also agree, that my job as a doctor is to relieve pain. Whether it is physical, emotional, mental, spiritual, though I don't know, I can't handle it also. But all the other, this thing we have to relieve pain. That's the only job that I have. I have nothing else. But what irritates? Where your admission is concerned, where your discharge is concerned, and when you become officious at death. This is it. If you can sort all this out, you're a terrific hospital. Everyone will win your confidence. I'm so sure Santosh will agree to it, because we'd worked on many such schemes way back. We go way back. So therefore, we worked on these sort of schemes and have found it very fruitful that you try and do these processes. You ensure that people are focused on the patient, not that I'm the doctor and you're the patient. My job is to treat you. Your job is not to treat them. Your job is to put your arm around that. And part of that putting your arm around is also treatment, therapy. Thank you, John.
I think very nicely, well explained, and he has taken 5 to 6 examples. And those 5 to 6 examples can take you through the entire patient journey and what we call in the Western world, how do you show your empathy towards your patient? These are all the stories of empathy, what he has practiced in his hospital. I think very well articulated, Sarah. I think those who are here from different hospitals can go back and can inculcate that. So with this, I move on to again Dr. Shetty, and as already we have heard that the culture what has been inculcated in KDA, I'm sure there will be few more success stories, or some of the steps have been taken by the hospital, and I'll be very happy to hear about those cases from you. Over to Dr. Santosh.
Thanks. I think Sujit has already kind of touched on most of the pain points and what hospitals are doing. I think two important words that I always, when I speak to my team members and I talk to them about patient experience, patient engagement, two important words. One is communication, the other is access. I think, how do you communicate effectively to the patients and family members? That is the most critical aspect of patient engagement. And each patient or his family member has a different level of expectation as far as communication goes. So very important is to understand what is the level of understanding of the patient or the family members, and come down to that level or come up to that level to communicate. So if it's a doctor who's a patient or family member is a doctor, is a different level of communication. If it's just a very general person, it's a very different level of communication. So communication is very critical. We have instances where patient relatives will come to us and tell us, I did a OPD consult, but I didn't understand anything. There were so many technical words that were spoken. I'm not a doctor. I don't understand what he's saying. And that is where I think all along our endeavor has been to talk to our clinicians, to talk to our nursing staff, to talk to our front office staff that understand the needs of the patient and the relative. And let's come or bring down our level of communication to that level. And at the end of it, a simple thing is, at the end of every conversation, let's ask the patient or the family member, is there anything else that you want to know? Is there anything else that you've not understood? Very important to close on that level. Very important to open at the right level. In the sense, you come in, please introduce yourself, whether you're a doctor, a nurse, a tech. very important, which doesn't happen, in most instances, despite all the training. Put the patient at ease, let them know that, I'm Dr. So and so. This is what I'm here for. This is what I'm going to do. This is the plan of action. Doesn't happen most instances. I mean, I have issues where patients come and tell us that, I didn't even realize that there was a doctor who came. There was someone who came in a t-shirt and jeans, and this is despite, all protocols about, wearing aprons at all times and wearing shoes and all that. But despite all these are instances that happen. So important is to create that culture of communication. Let them know what you're doing, what you are planning to do. This communication also aids us in a very big way to prevent errors. I mean, we have instances where, if a nurse is going to explain to the patient that, okay, this is medicine so and so, and I'm giving this for your blood pressure, and I'm going to be giving this 2 or 3 times a day. We've had instances where patients have come back and said, but I've already gotten this dose. So, you're maybe giving me another dose. We've had instances where patients have said that, okay, you're giving me this medicine. He looks at it, he says, no, but this is a similar sounding medicine. This is not for blood pressure. This is for depression. You've indented a wrong medicine. I mean, these are instances, live examples that I'm talking of, which are happening in hospitals, where if you involve the patient, you involve the family member in the care, at least there is one more level of check that comes in. Today patients, especially people who are coming to our hospitals in Mumbai, they are well educated, well read, well aware of everything that's going on. So that information asymmetry, that one-way communication that we were talking of, does not exist so much now. So make them part of the process. So communication, according to me, is one critical aspect which is across all levels that we need to take care of. Second is access. Very important is to have access to your caregivers, to your technician, to your nurse, to your doctor, to your physiotherapy. So in case you have any doubts, any information that you seek, you should be able to access them very, very easily. And today, patients expect that doctors should respond to WhatsApps, to SMSs, to emails. I know that there was a phase then where clinicians used to get very upset and irritated with all this. But honestly, we are reaching a level where we will have to engage more with patients, because it is in everyone's interest to do that. And this is the way the world is moving. So communication and access, I think, are two areas that we as an institution have taken a lot of focus on. And there are multiple examples of this. I mean, we've set up patient groups, support groups across various specialties, whether it is cancer, orthopedics, asthma, blood pressure, where we encourage patients, caregivers to come together to discuss issues in terms of what are the things to be taken care of, what are the early warning signs, when do they seek out treatment, when should they come to hospital. I mean, with video consult, teleconsult, there are so many things that can be managed telephonically or over a video consult. You don't have to come necessarily to hospital. So patient support groups is a very big area that we've been working on. Second area that we've just set up now is a drug information center. So very often patients don't know about drugs. What are the kind of side effects that can happen? What are the kind of food to drug interactions, drug to drug interactions? So we've set up a helpline for drug information. We've also set up a drug information center in the hospital, so that patients, after they've seen the doctor, can actually go to the drug information center, get more information about what are the kind of, what these drugs mean, what they need to be aware of when they are taking these drugs. So again, these are more and more examples of patient engagement. Of course, we are using technology a lot. So WhatsApp for Business is something we use extensively. We categorize our patients based on their ailments and the doctors that they have seen. And regular basis, we send out information, customized information to these patients. So if there are orthopedic patients who've undergone knee replacements, we send them WhatsApp messages on what are the things they need to watch out for, when do they need to come back for follow-up. Similarly, for hypertension, for diabetes, a lot of chronic conditions, we do disease-wise engagement using WhatsApp and other tools. Various other touch points is an ongoing thing, whether it is rightly what Sujit mentioned about admission and discharge and all of those touch points. It's a constant endeavor to see what steps we take to ensure that patients get in early and get out early. But again, I'll just end by saying that communication and access are the two critical elements that we try and stress on as an institution, and culture. patient centricity culture is a very, very important aspect that all of us are trying to push. And with the kind of attrition that we have amongst nurses, it's a huge challenge. It's a ongoing challenge that we as administrators face, because the patient expectations are going higher and higher. They are comparing you with hotels and hospitality industries. But the fact of the matter is, we have a different subset of individuals who are delivering care. We have nurses who sometimes are coming from interiors of Kerala and other states who have not seen a facility like this, who have language barriers. So how do we engage with them? How do we empower them? And how do we assist them rather than constantly complaining? I think we as management have to also take those additional steps to empower them, engage them, train them to build that culture of patient centricity. Thanks.
Thank you, and very well said. And some of the points I have just picked up. You told about access, you told about communication, and we heard from Dr. Chatterjee that the case, death case, where he explained and he managed the family, even after a few days, they came back to him and acknowledged the kind of communication he had with the family. And I'll take a couple of examples and why it is so important to have your patient family engaged in the treatment process. So there was a very famous Harvard Business School case study where one of the hospitals in Boston who were expert in cancer care, I'm not taking the name, and they injected a wrong injection to a small kid who had a cancer, and he died within 3 hours. And because of that, it led to a situation when Joint Commission landed up in the hospital. Their accreditation was suspended for a few days. Then the state licensing agency, they came and they were thinking about banning that hospital. So it can be so much. And why I'm giving this example, because when the patient, that kid's mother was interviewed, she told about that I told nurse that this is not the injection what he takes, it has to be something different, but it was ignored and still it was administered. Coming back to your communication part, the Cleveland Clinic Patient Experience Department, they have come out with a model of communication called REDE. So they have structured the entire communication for all the employees in that format, whatever you do. And one of the small example I'll give and then I'll stop, that they have trained all the doctors that if they go to see a pediatric patient kid, if they're sitting in the bed, patient bed, the doctor need to sit down and come in the eye to eye level, not from the top, because if they stand and they talk, it looks like they are coming with a much more power and authority. So to give that kind of comfort, they have inculcated this kind of culture. I think there are many of these examples what can be discussed and shared here. But with this, I move on to Dr. Milind, and I'll ask you specifically for the clinical area, some of the interventions have been made by Jaslok Hospital in this endeavor to improve patient engagement, which results into better patient experience. But before we start, we'll allow 2-3 questions after this answer. So be prepared. Whoever raise the hand first or second will get the chance, and then we'll close the session. Over to Dr. Milind.
See, before that, I would like to tell you, my personal experience that when I started my practice way back in 1999, I used to have no patients. That time, 1 or 2 hours sitting in an OPD, I used to say, tell the receptionist, please call me whenever I stay nearby. One of my seniors advised me, sit in the OPD. That is going to create an experience for the patient. The doctor was available. And I followed it all the time whenever I was in practice. So this also happened where one of the patients was referred to Vocard Hospital, then for now Fortis. That time, one of the patients was sent by GP, and the GP called me. I reached before the patient. So it was a big thing about it. The doctor was already available in the casualty, the emergency department. So by this, what I mean to say is reduce the wait time of the patient. That is one of the best experiences the patient has. Right from the appointment system to the caregiving. If the patient wait time is reduced, even inside the hospital when the medicines are being indented, if they come on time, the medicines are given on time, issued on time, everything. That creates an experience as well as, of course, the clinical safety for the patient. So reducing the wait time, we're looking at creating that environment where, as Dr. Shetty already said, the patient information has to be, hospital information has to be available handy to the patient at any given point of time. So we creating an app where, of course, we have a website, but an app which is more handy. A patient can access all the information about the hospital, doctors, the clinical conditions that can be treated, and his particular clinical condition, of course. So that is one thing that we're looking at and now. And secondly, engaging the physicians in this. Consultants is a it's a bit difficult to handle senior consultants. But what we have in hand is training the junior doctors. 200 junior doctors in my hospital, they are not just trained for their clinical things, but also for communication and soft skills. And the same thing, I mean, if the consultant is not available, at least they are able to provide part of the uh, care, the treatment in a particular uh, decent way that is expected from a doctor, so that the patient experience still does not go down. They have they can be explained that the doctor is busy in something, but junior doctors can take a play a bigger role here in the absence of the consultants. I think this is must be the situation in every hospital, that consultants are busy. They're traveling multiple hospitals in a small area, but uh, Bombay traffic, they get delayed. So uh, uh, junior doctors can deliver that care. And as far as feedback is concerned, it is most important. I mean, it is not the feedback from only during the discharge, but ongoing feedback on daily basis can be taken, or is to be taken on daily basis, so that service recovery can happen as and when there is a chance, there is a problem. So that creates another wow factor for the hospital. Rather than taking a bad impression about the hospital, the doctor, the patient, the relatives would take a positive impression about it. So I think that is what we can do, and we are doing, and we're trying to create an wow factor for the patient in every aspect, right from the admission to right from the walk-in to the discharge, and also post-discharge follow-ups, where we can keep in touch with the patient by multiple means, and uh, uh, engage them for a longer period.
Thank you. And before I open up for the question, I think three of them have touched upon some of the important thing. And if I talk about Dr. Milind, he told about waiting period. I think along with that waiting period, two more aspects from a clinician's point of view needs to be taken care of. How much time you're spending for the interaction, because a couple of years back in Times of India, the front page has written that there was a survey which has shown on an average Indian consultation takes 2.5 minutes. I don't think that 2.5 minutes is going to make them happy in any way. The second example what Dr. Chatterjee was mentioning about tachy, I don't know how many of you have understood that one consultant have told that you have tachycardia, so they didn't understand tachycardia, and he was telling tachy, and asking the doctor to check. But probably we are also losing, and we are also missing that culture of getting the patient in the room, touching them, getting the pulse, which is, still the characteristics of Indian medical healthcare, and people expect that to happen. The conversion into online virtual is good, but I think we are yet to reach that level when it becomes a norm. So with this, I stop here, and if there is any question, please raise your hand, and you can mention your question, whom you are going to direct. So is there anyone? Yeah, please.
Hello, sir. My question is to Dr. Sujit Chatterjee, sir. So my question is, how does the hospital balance the use of PREM with other quality indicators and the performance indicators in evaluating the hospital performance?
There are 4 of us sitting over here. You asked me that question. You ask the rest of them. The point is that the quality indicators, we have this continuous quality indicator, which is it is a core group which is monitoring this. So therefore, there will be representations from across the hospital. So they act like internal auditors, which most people have. But they have been given specific chapters of the NABH 6th edition. And in that, they have to ensure that they have understood this. So therefore, classes are taken regularly. So did you follow what is written? You're going to ask somebody a question, but have you followed? So therefore, that has to be done. And thereafter that, they are tested. So now, if you don't come up to scratch, then in that case, we'll have to tell you that, look, you study a little more and let somebody else be an internal auditor till you come into speed. So this part of it is evaluated extremely well. Then after that, there are also the clinical audits. These clinical audits have become an antenna for our hospital, because you identify a problem, you start addressing that problem, and then you solve that problem, and then you monitor it for a period of time to see that it really doesn't come up again, and you move on. But you revisit that problem at a given point in time, and that given point in time can be decided by the clinicians themselves. So therefore, you revisit, did it occur again? There is always this fear that there's going to be complacency. We have got over this. If, for example, I had a problem as far as the neonatal intensive care unit was concerned. We started getting babies who were getting infected, right? Now, we did everything possible, changed everything around, this, that, examined the doctors, nurses, every damn thing. We changed the equipment, and it came at a cost. We changed everything in the department. Then we started examining the drugs. And my pathologist who's sitting over here will tell you that it was an impure drug that was being given. So that means you trace it. Don't leave it. Trace the damn thing. Go after it, go after it, go after it. Dig down, find out. Right from the toenail to the haircut. I don't have any hair, so therefore, not for me, but for you, it will be right from your toenail to go through the problem in detail, microscopically, and you will find out that, yes, there is a problem. And after that, no more problems. You understand? So no more problem. So if you are going to want, or if you want to get quality, then please understand that your target should be perfection, which is in the horizon. It is a mirage. On the way, you will meet excellence. So therefore, if you're really thinking in terms of quality, then it is a 24/7 continuous method of evaluation. You slip and somebody will pay, not you, somebody else. Yeah.
We can hear you. Perfect. I'm loud enough. I'll specifically ask this question. Okay, perfect. I'll make you rest. So I'm specifically asking this question wearing a patient's hat. I usually don't wear that hat, but since all of you are here, all of you mentioned about the fact that there's a requirement for patient engagement, right? But given the fact that there's a lot of hue and cry in the country for rising cost of healthcare, unaffordability. How are all of you trying to manage? And this is specifically directed to Dr. Shetty, because you mentioned it, sir, that there's there are like a lot of curves coming in terms of how much you can charge a patient. Patient engagement requires time. Engagement requires time from everybody in the hospital, and time is of essence because time costs you. Like you pay people by the hour, you pay people by the day. One thing, how all of you are trying to manage that as like the stalwarts and the leaders of your particular organizations, in terms of ensuring that the time is given to the patient. Secondly, and since we are running short of time, and I see Joy Saab looking at the watch, I would also like to understand that how the curbs that are coming, or the the cappings that are coming on the cost of healthcare will affect new technologies being adopted, will affect because since the affordability was increasing in the country, we were thinking that we're going to get the same treatment what we get in the West, and how are you going to manage that as a group over here?
So I think both the points that you mentioned are ongoing challenges. I mean, I don't think there's a ready answer for what is an ideal environment, but clearly, listening to the voice of the patient and ensuring a good patient experience goes a long way in not just brand building, but also getting patients and their relatives to keep coming back again and again, because nothing is better than what we call as word of mouth publicity. You have a good experience, you go out, you speak to 10 other people, and they come back. Now, at our place, of course, because we have a full-time consultant model, so we are able to kind of try and build that culture where doctors are told that, okay, give at least 15 to 20 minutes per consult. We actually have slots of 20 minutes each per consult. There is pressure very often from consultants to reduce that to 10 minutes or 15 minutes so that they are in a position to see more patients. So that's the balance between patient experience and economics that one needs to build in. And there are ways we are trying to do that. Certain areas where doctors are busy, we are trying to give assistance to them so that they do a first level screening and ensure that at least the basic information is captured, and the consultant then gives only the required information. And so his time is curtailed to that extent. Secondly, using online consult is also something that we encourage. Like Joy said, it's still work in progress. That's something that's going on. Third thing is listening to the voice of the patient. I keep saying this because as administrators, we keep getting complaints periodically that, my patient's been in the ICU for 10 days or 15 days, and this happens with long stay patients. We don't know what's going on. And it's very, very odd because, every doctor is seeing the patient and talking to the relative, but at the end of the day, there's this common grouse that we don't understand what's going on. And that's where we encourage that if more than one doctor is seeing a patient, we encourage then that every 3 to 4 days, you have a multidisciplinary team meeting with the patient and family members. All the treating doctors sit together with the family members and clarify that so that they are not looking after, just their respective organ space. So maintaining a balance between time as well as ensuring a good patient experience is an ongoing journey. Secondly, when you talk of is new technology now not going to come in, we are all hoping that I'm sure everyone who's going to come out with a decision is going to be logical about it, because in terms of standardizing costs, there are lots of challenges, and these have been discussed ad nauseum in terms of the kind of location the hospital is, the kind of technology, the doctor model. Obviously, you can't pay for a robotic surgery the same as for a laparoscopic surgery or for an open surgery. I mean, these are three different types of surgeries done by surgeons of different levels in different locations with different seniority, using different consumables. I mean, there are lots of variables involved. So I'm sure that these are things which will have to be discussed. In the same breath, I would like to say that we are slowly moving towards a fixed reimbursement model, the way that it's there in the US. Now, at what stage does it come in? Will it involve grading of hospitals, staging, location-wise, whether all those variables are taken into consideration? I think, those will have to be done before we get there. So in the interim, I'm sure hospitals will have to ensure that they stay updated, they get new technologies. Patients are going to keep demanding the new technologies and newer procedures, because as they say, with the use of technology, with the World Wide Web, everyone has access to what are the best practices. And as aspirational Indians, we would like that our patients get the best that the world is offering.
Thank you. And Dr. Chatterjee wants to have a comment.
It's to you, sir. What's good for Peter is good for Paul. So therefore, sir, if a lawyer has an indefinite fee that he would charge you, why can't my consultants also charge well? I would like to see a doctor come in an Armani suit. So therefore, I would like to see my doctors coming in an Armani suit and driving up in a Lamborghini. So therefore, technology reduce cost, etc. But my payment is only this much. So therefore, ultimately, I can give you patient satisfaction in a jiffy. Don't have to wait for anything. Treat him. Don't give the bill. So, I mean, this is ridiculous. This comparison is ridiculous, sir. That if you want something and you want it at a particular level, then please be ready to pay for it. If you don't want, we can also give you something which suits your pocket. The lawyers also tell you the same thing. The judges tell you the same thing, sir. And if you're talking in terms of me and a patient, I am also human. Patient is also human. Hotels will charge whatever they want. So why not circuit house charges, sir? You can go to any circuit house. They will pay you. You have to pay them government rates, including food. But go and tell them at Taj, no, in the circuit house, I got this. So what's going to happen? No, I'm sorry. I tend to disagree with you very vociferously when you say that in medical part of it, what are the, measures we are taking to reduce costs? We are profit making. We are not profiteering.
Joy, sir, I'll just take 30 seconds.
And I want you to stop after 30 seconds.
So, sir, I never intended to know why if we are reducing cost or not. I was more concerned about the fact, will I get quality healthcare? Keeping money aside. You will get quality healthcare. Oh, let me assure you. Perfect, that is it.
So I think considering the time constraint, we have to stop here. And it was a very, first session, lot of discussion, and he made the debate further, very hot topic. And I think different associations are going to fight now and going to put forward their views to Supreme Court to convince. I think we need not to have a millionaire lawyer to be appointed. Colonel Sujit Chatterjee can be there, and he can talk about that example of Armani Suites, and he can fight on behalf of all the private hospitals. So I want to thank all the esteemed panelists and, sharing their thoughts, and great audience, great participation. And with this, I want to close this session. And one important announcement. There was a tea break, and I have taken the authority in my hand. I have stopped the tea break considering time again. If anybody wants to get that energy back, I think next session we'll have a lot of energy packed discussion you can take. If you still further need to take it, then you can step out, but it is not a tea break officially. Thank you very much.
Thank you so much to our esteemed panel. I would now request our moderator to felicitate and thank the panel members with a memento and a book. Okay. Starting with Colonel Sujit, Dr. Sujit Chatterjee. Dr. Santosh Shetty. Dr. Milind Khadke. Now I request our CEO, Mr. Gautam Khanna, to please felicitate Mr. Joy Chakrabarty. Yeah, okay. Sir, after Mr. Joy. Request panel for a group photograph. Thank you so much, sir. Thank you so much once again. We are starting with the second session right away, so please don't move out. Be with us, and we will take a maybe short break after the second session. Thank you so much.
Good morning. So as you all know, quality and safety are an integral part of healthcare. So next session, next panel. Yeah. So our next panel is patient-centered care, driving quality and safety culture. So I'd like to request our moderator, Dr. Hardik Ajmera, Medical Director, Saifi Hospital, to please be on the dais. Panelist, Dr. Parag Nindani, CEO, Wakad Hospitals Group. Dr. D.S. Chakravarti, Global CEO for Human Care Worldwide. Dr. Avinash Supe, Director, Clinical Governance, PD Hinduja Hospital and MRC. Edward D'Souza, Chief Operating Officer, Rare Hospitality and Service Private Limited. Over to Dr. Ajmera.
Hello.
So we request all the members to please settle down. We are starting the next panel.
Yeah, we are good to go. Yeah. Okay. A very good morning to everyone. First of all, thank you to Caho and PD Hinja Hospital for inviting me for this panel discussion. And I will try my best with my expert panelists to do maximum justice to the audience here. And we will try to make it as engaging as possible and as fruitful a discussion. Okay, so let us decode the theme for this session. Okay, it says patient-centered care, driving quality and safety culture. So there are three very trending buzzwords or keywords of the current healthcare scenario which are mentioned here. One is patient-centered care, one is quality, and one is a safety, patient safety or a safety culture. So to set the theme, let us first understand how do these three words interrelate with each other. Quality, as we all know, as a student of quality and as a practitioner of quality, we all know the Institute of Medicine definition of quality, which says the degree to which a particular healthcare service will bring about desirable outcomes for an individual or for a population in consonance with the current clinical knowledge. Okay, so it focuses on the outcome. However, in the same breath, the IOM definition says that there are 6 domains of any good healthcare quality. What are those 6 domains? Efficiency, effectiveness, equity, timeliness, and the last 2 are patient safety and patient-centered care. So, patient safety culture and patient-centered care are the 2 domains under the broader umbrella of quality, and they play a pivotal role in improving the quality of healthcare delivery. Okay, so we are discussing patient safety and culture and quality here. So why all this buzz about patient safety? Why such a power-packed panel to spend time on patient safety? Okay, let me start with this. I'm sharing some data released by WHO in September 23. 10 patients out of every 100 patients have some kind of harm done to them during their hospital stay. 4 out of 10 patients, sorry, 4 out of 100 patients in lower and middle income countries die because of some sort of harm done to them. Now, let's relate this to another very safety intensive industry, which is aviation. Imagine every time a Indigo or a Vistara takes off from Mumbai and lands in Delhi, 10 patients out of 100, sorry, 10 passengers out of 100 are having fractures and 4 die because they were thrown from the plane mid-air because the pilots and the crew were too busy to take care of them. Okay? Would you like to travel by that flight? At least not me. Would you send your relatives? No. Yet, in the healthcare industry, we are admitting ourselves and our relatives in a situation where so many patient safety errors are happening. Okay. So we realize there's a real problem at hand here. Fortunately, I have a very eminent panel of well experienced leaders, stalwarts from the industry, who will, during this session, help us navigate this problem. Okay, so starting with Dr. Parag Nani, Group CEO, Vocard Hospitals, patient-centered care. What does the term patient-centered care really mean to you in your perspective? What are the different components that constitute this care, patient-centered care? And in your experience at your hospital, what are the benefits you have seen to be accrued as a result of implementing this care, which eventually leads to patient safety and quality? Over to you, Doctor.
Well, good afternoon, and thank you very much for this invitation. Thank you very much, Dr. Ajmera, for this lovely question. Patient-centered care essentially means that everybody really is focusing on the patient, which means that we are not so worried about whether registered are filled in. We are not so worried whether a duplicate report has to be generated. We are not really worried about whether a broken medication has to be indented, because otherwise that will come out of our salary. We are essentially focusing on the care of the patient. We are focusing on the outcomes that the patient has come to us for. And if I were to speak in the parlance of Lean and Six Sigma, we are ensuring that the cost of the non-value added activities that we are bearing, typically there are in any hospital, including mine, that these are not passed on to the patient. But I think most important is that the patient gets what he's coming for. What exactly are the things that a patient would look for if he were to truly qualify a hospital? You know, we are nowadays giving out lots of awards, on an average around 35, 40 categories of awards given in every conference. There is a fee occasionally to be paid for it. There's some audits and all of that. And then you get this great award called the Patient-Centric Hospital Award. But if you were to go into the deeper recesses of these hospitals, you'd still find registers where things are constantly written. Now, since my background is laboratory medicine, I've often asked this question: how much does it really cost to issue a duplicate report versus actually getting Alayama's signature on that register and then having a cost of maintaining those registers? Because when the patient comes to ask for that report at the front desk after discharge or as an outpatient, we invariably tell him, but you've taken it, when he or she actually hasn't. So I think patient-centered care is essentially respecting the patient, ensuring that the dignity of the patient is there is this oft flouted cartoon where they say that, the patient's behind is naked, and everybody talks about the fact that this is why they say that it's in an ICU. And, there's this standard cartoon which goes on very often. I think the most important thing is not to forget why the patient comes to the hospital. The patient comes to a hospital, your hospital, my hospital, because we have put out a particular promise. Okay? And I know the lights are blinking behind me, but try and focus on what I'm trying to tell you. I loved Disco Divani as a movie. It was in my 10th standard, Yeah, thanks, Joy. Joy is a very good friend. So, it's and typically this is reflected in the way that we ourselves are not confident about our hospitals, because when somebody is admitted in a hospital, we invariably put it on the WhatsApp group VIP alert. We invariably get calls every day, wo mera patient hai, ab zara dekh lena. Now, what's there to dekh lena? Patient hai, Raja or Rank, he or she should get the similar quality of care. That's what accreditation is all about. And we are at a Caho forum. But I think apart from respect and dignity, I think it is sharing of the right information at the right time. Santosh spoke about it, communication. And I think what's most important is acknowledging where we've screwed up. And let's accept. How many of you say that we don't screw up in our hospital? Everybody does screw up in the hospital, right? And at least to ourselves, we have started acknowledging thanks to accreditation, but it's important that we move on. What are the benefits? I moved on from a role as a laboratorian to a medical director to a CEO. And therefore, whether I like it or not, I must acknowledge the fact, and this is to continue the answer to the question about costs. We must acknowledge the fact that while we will always try to reduce costs and enhance profitability, at the same time, there is a particular responsibility to the patient. And that responsibility is to get him home faster, safer. And that also adds to your profitability. You have a patient with a wound infection post-bypass surgery, and that patient occupies 8 days of your ICU bed. He's not really adding to your bottom line. Let's understand finance also. Okay, let's not be stupid about certain things and say hospitals have this great responsibility towards humankind and all. Hey, hum hi bach gaye kya? Why aren't the rest also focusing on that responsibility? So when we look at those 8 days in an ICU, we could have turned around at least 4 more patients of a bypass surgery, thereby adding at least 12 to 15 lakh rupees to the top line, and therefore something at least to the bottom line, even in a CGHS or a Pradhan Mantri Jan Arogya Yojana case. What is important, however, that the patient has been given a promise. We are sporting the logo of National Accreditation, Joint Commission International. The promise is that we are here to do you no harm. And therefore, that is the main thing that I would like to give as an output. If I were to look back into my hospital, I don't like those days when a patient has to stay extra because of an infection, because of a fall, because of a medication error. These are the things that we need to look at. However, today what we are doing, I'd also like to acknowledge, I think most of us are still at the stage of correctly monitoring in a good way and discussing that. We've still not reached the stage where we actually invest in quality improvement projects to actually show a discernible bottom line impact of these quality improvement measures. But the stage, the infrastructure is set. Now that we are monitoring, now that we know that we're supposed to improve on these outcomes, I think we will. And I think what's excellent is that under the umbrella of Caho, at least we are meeting, we're talking to each other, and we're acknowledging the fact that there is scope for improvement. So when we were starting my unit hospital that is in South Mumbai in 2014, I unfortunately went through the receiving end of patient care. My father was admitted in a hospital for close to 6 months, ICU for close to 2 months. And I actually understood how crappy it is to be a patient relative. Not that the hospital people were bad to me. I was the VIP doctor, CEO of a hospital. It helped. But still there were things that crept in. Still there were things that, and I didn't complain about it because they were all friends around. Nobody was charging me for many things. And you do feel kind of obligated. But let me tell you one thing. That taught me a lot. Till you really don't put yourselves in the shoes of your patients, till you don't experience the crap that you dole out day in and day out, that I dole out day in and day out, I don't think we can improve. If we don't taste our patients' food, if we don't take that crappy medication ourselves for the headache that we have, which has got a better margin, I think we're in trouble. And I think only when we start experiencing, when PREM becomes HREM also, healthcare, related experience measures or healthcare reported experience measures, I think that's when the twain shall meet, and that's when we'll have a little better outcome. I hope I've answered your question, Hardik.
Very well said. So, Dr. Indani has told us that what is patient-centered care and what are the benefits that accrued out of it. I also like the corollary he gave that we all should be patient sometime to realize what they are going through. And in my previous this thing, I gave one example about the aviation industry. The only difference between the aviation industry and in a hospital is the pilot is himself in the same plane. So he has to be very, very careful not to crash. Here, we tend to be complacent. Our staff tend to be complacent just because we are not in the same shoes as of the patient. So yes, we agree that patient-centered care is very important. if I can sum your entire narration in one line, it would be nothing about me without me. Nothing about me without me being involved as a patient. So now, yes, we all need to go towards patient-centered care. We are going towards it in a phased manner. But my question to Mr. Chakravarti is, what are the policy level drivers? What are the factors which you think will act as a catalyst so that this procedure or this phase-wise journey of entering into patient-centered care is expedited?
Thank you, Hardik. This question is more of a theoretical than a practical based question because it's policy related, which is practically not possible in our country, which is due to the diverse population we have, and there is a diversity of A class, B class, tier 1, tier 2, tier 3 cities. But in fact, we need to follow certain standards to make the policy get implemented in our country. And so the policy drivers include the National Quality Framework, which is already there in place through agencies like NABH, JCI, and of course, Government of India. And of course, we have some certain policy drivers like patient legislation, which is very important, where this patient legislation plays a robust role in declaring the things. What patient requires means the hospital, what we're displaying is now the charter, patient charter, what we call it as. But now it goes in depth in the patient-centered care, which is a combination of patient experience and patient satisfaction. Now, patient-centered care has a definition now. It is not, it is a combination of patient experience and a patient satisfaction. So now we have to redefine our charters of, now the patient legislation means the patient demands increases. Now, we have to define the policies, how we should approach that depending on the tier cities. We cannot combine every city, every hospital into this single policy making, which is happening in our country as of now, which is not at all practically possible. Now, the third one is the health information technology policy. Now, you see so many policies coming up with just a simple word of patient-centered care. The maximum number of policies are affected towards the hospitals only in our country, unfortunately. So every segment has 1, 2, 3 policies, but our hospital has so many policies: quality, patient satisfaction, patient experience, no patient-centered care. Now, coming into that, now again, you are talking about health information policy. Now, health information policy, data privacy, data policy, blockchain policy, so many policies. Now, again, this policy is very much important because the patient data plays a core role in patient-centered care. Now, you capture the patient data, keep the patient data centralized, accessible to all. And now you see, again, 3 policies are in picture. Again, you have the government quality improvement policies, which are being forced upon hospitals now. Like the value-based care, again a policy which is not practically possible in our country. Now, how shall we go about this? How shall the patient-centered care will vice versa with the policies that are going to come up? We should be facing it. How shall we be prepared to this? How shall we lobby with this? And how shall we prepare ourselves to go with these policies that are going to come up due to this patient-centered care concept? And patient-centered care concept came into our country through, in fact, the NHS policy of AHRQ. And we know NHS is today struggling a lot with all these policies. But we are coming into that extent of patient-centered care, which is going to be made a mandate in the coming future by government as well as ourselves to sustain in this competitive atmosphere of the healthcare industry. Now, patient safety laws, patient advocacy groups, all are going to come up because of this. Now, patient safety laws and patient safety groups are coming up with, again, a liability and a legality where patients are involved in every step of our hospital, internal aspects also. Because of this patient-centered care, we are forced to make patient involved in every step. Yeah, that is a good sign as well as a bad sign. Now, patient is well aware about what is happening internally into the hospital. Now, we should define a patient safety law where the hospital are secured, the doctors are secured, and in fact, patient experience is not compromised parallelly, which is the core concept of patient-centered care. And another law is coming up with a value-based payment model. Is it possible with so much of expenses in patient-centered care happening? Is value-based payment models possible in our country? No, I don't think so. Now, the policy should come up in such a way that this value-based care should consider A class, B class, C class cities, tier 1, tier 2, tier 3 hospitals, depending on their expenditure, depending on the quality of care, depending on the involvement with the patient levels, they are doing it. So is it possible to have such policies in our country with patient-centered care becoming the center of demand in our country as of now? Because we, hospitals are forced to follow that aspect of patient-centered care because everybody are doing it. Now, healthcare workforce training. Yes, of course, Caho like institutes truly concentrating on patient-centered care with so many initiatives like patient safety officer courses, infection control courses, and patient advocacy groups, which are, yes, are in limelight and which are in tandem with the demand of the patient-centered care. But how much trainings we need to change now? We need to evolve from patient satisfaction to patient experience to patient-centered care. It is not easy. It is a very tiresome job for the trainers and well as ourselves to get trained in such aspects in a continuous model. Now, again, training initiatives and public reporting mechanism. Now, this is again a very big concept of patient-centered care because everything should be should be transparent to the patient. Then only the patient-centered care concept is successful. Now, is it possible to have a public reporting mechanism? Are we ready? Now the government is demanding that to happen it. But are we ready for openly disclosing every aspect of what is happening related to patient-centered care? Now, how should we devise that policy? Now, community engagement and patient advocacy. Of course, this is a very good aspect that is happening where patient advocacy groups are created. As such, already the very good big hospitals had in practice of this. Now, coming to these policy initiatives, are these all policies are much required to be adapted now in patient-centered care? And is it possible is the biggest policy that we have to devise in between us and go ahead with this patient-centered care concept?
Thank you, Mr. Chakravarti. So if I may sum up your narration, I would like to segregate all the policy drivers, what you just mentioned, into three categories. One is a financial incentive model. Okay. Although we are yet not getting into it in a big way, already there has been beginning in terms of GIPSA offering different rates for hospitals which are NIBH accredited. Same is the story with CGHS. They are also giving financial incentives to hospitals who are paying attention to quality and safety. The second would be the legal framework, which you just mentioned about is difficult to implement in our country, like other countries, unlike other countries. However, we are having voluntary accreditations, which there is more and more penetration with every passing day, so that in most of the hospitals in tier 1 and tier 2 cities, at least, the quality of care has improved. However, third and most important driver of, though not a policy driver, but a driver where we will have to go for patient-centered care would be the consumer demand, the patient demand. Patient nowadays is becoming more and more aware, is aware of safety and quality norms, and is demanding care of that level. So, okay, in other countries, they are also publishing the data of patient feedback, in on platforms accessible to everyone. Imagine that situation coming in India, though I don't see it in near future, but every patient coming of the hospital will put his feedback on certain parameters of the hospital that will drive your business either northwards or southwards. So it's a very unpredictable thing which will happen. However, one thing is predictable, it will definitely put pressure on hospital staff and management to improve patient safety and quality. Okay, coming to Dr. Supe, sir. Dr. Supe is the Director Clinical Governance at PD Hinduja Hospital. Sir, my question to you is that you are a leader here. How do you devise strategies to implement patient-centered care at the hospital? And would you like to give an example of a strategy implemented in patient-centric care which has given you very positive outcomes?
Sure. I think probably I'm the one who has seen from practically there was no patient-centered care to now we are all talking about patient-centered care. In last 50 years of my health journey, I think we saw that. Yes, and I think over a period of time, what all we have realized that two or three things have mattered is the patient's autonomy as well as the social media, whatever you say, public data, but social media posts have definitely influenced the kind of patient decisions. Now, what really matters actually, if you want to really develop the culture of patient-centered care, I think what matters in an institution is that the institution should have that culture. And how do you bring that culture in an institution? I think it comes from the top. I think the first thing is the leader has to have that commitment.
Whether he's a CEO, CO, he has to have that commitment. And he has to have that time and he has to have that continuity of taking follow-up. If he's not interested, patient-centered culture will not come. And that's the first thing you should really realize, that leadership is the one who brings it from the top. The second is the way you train your staff and all level of staff. Now, I'm sure there are staff training courses are done, exercises are done. Now, unfortunately, our kind of clinicians or the doctors were so many years were never taught into attitudes and communication in a sincere way. I mean, let me tell you, we are all by doing it by role model or by looking at it. It's only in last few years, I think we have been all concentrating on these kind of aspects. And in fact, even talking about the patient-centered care, we are not. But of course, now I find there are so many kind of programs are being done where we are talking about patient centricity and we are trying to touch the patients. So actually, this should be done at 3 levels. One, the students and the MBBS and the MD doctors, juniors, should be taught during their course about all these attitude, ethics, and communications. Then every time they get induced into an organization, they should be introduced to this culture and they should be told that, okay, these are the norms, these are the kind of expectations from us, we are going to be there. And the last but not the important least is what we call as a continuity of care. Because what I have really seen in organizations as they grow, there's something called as a compassion fatigue. People assume things, and as somebody asked the question, in our top line and bottom line and other quality indicators, many times we forget about sometimes these patient-centered care parameters, because as you said, they are not today linked to the performance-based payments, they are not linked to your other things. So this is today, unless the leadership and the whole team is committed, I don't think this will really come in a big way. It is many times, as you rightly said, we are talking. But I must tell you, under the Joy and our quality team, what I've seen in last 3-4 years here since I've come, I think they do an excellent job in terms of quality and safety and patient training. We have regular patient centricity workshops done every 2 or 3 months by HR as well as by our team, and SEED program, Latika does it so well. So I personally feel these are the touch points. If you really start doing it, it brings the culture. Now you will say, will one program change the culture? Probably not. But it takes few years before such kind of a culture seeps into an organization. And the third thing where it really helps you is the data feedback. How seriously you look at the patient feedbacks data. And I mean, you look at every month, you look at data. And then even if these are discussed into your high level MT meetings or executive meetings or patient feedback meetings, and even if there are few comments, and if those comments are started disturbing the leaders and the executives, I think that's the time you find the patient centricity cultures will start coming up. And these are something which we should really start looking at these aspects, As I said, the biggest block is our sometimes clinician. I'm a clinician, but I'm sure clinicians are the biggest block for this today. And we need to make them realize that unless we are talking about patient-centered care, about 4 or 5 years ago, I gave a talk in Mumbai Surgical Society on shared decision making. And people looked at me, why is talking about shared decision making? I mean, these are the things which have become so now accepted all over the world. But today, our surgeons don't sometimes really believe. About 50 years ago, I used to take a patient and I used to do endoscopy and I find the ulcer is bleeding. I would take him into the operation theater, operate him, and then tell later on the patient that I have operated. Patient would not say anything. Today, even if I am in operation theater, I am doing Whipples and I have to do little more addition. I have to go out, take his consent. I think everybody how the cases happen. 3 operations done, 1 operation, consent is not taken. They are charged so much of money, Supreme Court cases. So I think today, if the patients are not informed well and patients are not taken into consideration, I think it is going to make. So these people have to realize in your institution. If your institution realizes this, that so leadership, your staff training at every stage, then data analyzation, then you have a continuous kind of a commitment which you are going to do, the culture which you need to bring, and a proper kind of a control from the whole organization and awareness. I mean, ultimately, see, empathy doesn't come by only creating some films or doing that. It has to come from within. I think it has to come from within from an individual. So the overall, how do you make your staff happy, comfortable, and you bring that culture, and how the leader behaves. I mean, I think Dr. Chatterjee was talking about that you are going to show him the pathology way. I mean, I'm sure every time it is not possible, but the way the leader talks, I'm sure everybody is going to really follow that. And I think these are all culture, if you are able to develop into patient-centered culture. And of course, I mean, I realized the ethics committees when people started. I was in ethics committee of Tata and KM for almost 25 years. And I realized when they started, we were not even knowing the words of patient autonomy, do no harm, beneficence and all. But when you start understanding patient's autonomy, I think that's the time you realize, okay, patient-centered care is one of the most important care. And if today patients know Google, they have full access of Lumen, they know what are our goof ups, they know our errors. And if you don't take concentration into them, probably they will not. And as I think we are talking about quality and safety, patient-centered care, there's enough evidence in the literature today that patient-centered care has definitely improved. Like in airline, you said, it has improved the quality and safety of a human care. So I think we should all adopt it. Many times it may not be cost efficient, but over a period of time, if you bring that culture, these strategies will definitely help you.
So Dr. Supe sir has very beautifully outlined the strategies to achieve patient-centered care. And I was listening to all the points he mentioned. He actually covered all the top 3 points mentioned in the study done by Pickers Institute Europe, wherein they said the first point to achieve patient-centered care is patient-centered consultancy, spend time with the patient, talk to them. Second point is training in communication of your staff. He mentioned that, okay, train your doctors at junior level, at resident level to spend time with the staff. And third, he mentioned about is feedback. Take feedback from the patients. So these 3 points are also labeled as best buy strategy by Pickers Institute when you want to achieve patient-centered care. Coming to feedback, my question for Mr. Edward D'Souza, COO Rare Hospitality, is on feedback only. Mr. Edward, you are in the hospitality industry and you have to deal with a lot of patient feedback and preferences. Have you developed a mechanism to capture these feedbacks and these preferences, and how do you incorporate it into your day-to-day operations so that the patient satisfaction experience and of course patient-centered care is enhanced? And if you can support it one example of a specific maybe assignment what you have taken up on this mechanism, it would be great. Thank you.
Sure. Thank you, Dr. Hardik. First of all, I would like to thank Mr. Joy and Caho for including me in this panel, which is from the non-clinical side. I think a lot of people on this panel, in the previous panel and the other panels, are all going to be all clinical teams, and most of the people here are probably clinical and non-clinical into the services of patient. So I'm going to bring in a different perspective here. We probably partner with over 250 hospitals across India, and eventually what happens is a lot of people in this trade of maybe a service provider providing service to the hospitals end up only providing people, maybe material, machinery, and end up becoming a contractor. And the hospital in turn ends up running the show, correct? They drive the program, they drive a lot of these concepts, and eventually you still pay for all those people as a payroll. So we developed, we over a period of time realized the need of bringing some value, as a service provider. And it is just not about providing people, material, machinery, and taking some management fees from the hospital. So when you say about feedback, I think, first of all, let's touch upon when will the feedback happen if there is engagement. If there is no engagement, a lot of times I've been a patient myself 2 years back. I have seen my mom's treatment happen at one of the hospitals for over 2 years. And what I realize is a lot of time we don't know who treats us, who serves us. They don't create an impact, right? And we realized the need of even the non-clinical team. I'm sure everybody will agree here. Apart from the clinical team that moves in the hospital, the largest team is the cleaning service teams or the patient care service teams. They're the largest piece of people that moves in the hospital. And they are rightly, earlier my panelist said, they are touch points, right? A cleaning company or a service provider company can, a patient can encounter in many, aspects, right from when the patient comes in to the OPD, from the wheelchair to the patient from the ER to the OPD to the rooms, and then to be sent to multiple diagnostic setup, and the cleaning piece, whether the 3 or 4 is an average length of a patient. So all of this time, there's such an opportunity for our patient engagement. So we curated a concept called aided. We said acknowledge. Basically, this was derived by the ex-JCI members, and they said, how do a non-clinical team, a housekeeping team, or a patient care services team engage with the patient, so the patient remembers, हाँ मैं Edward में आया था, मैं 4 दिन लगातार आया, and I communicate to the patient, my name is Edward, and I'm going to clean your room, and I'm going to do it in a more scientific manner. We have a concept called SSDP, that surface disinfection program, smart surface disinfection program. So we start with educating the patient. We engage the patient. The patient knows my name. The patient knows how I'm going to clean the room. With this, when you then take a feedback, there is a specific feedback that you receive. Yes, because sometimes a patient can get very confused with whether the nurse was good, whether the doctor was good, whether the food was bad, whether the linen was smelly. All of those experiences sometimes, gets a little mulled. People, you don't get the clarity about what was the experience of the patient. So coming to that, it takes me back to a few years back when COVID happened, and Seminole Hospital was a prime focused attention hospital, 1,500 beds, and the commissioner team came to us and said, "Can you manage this hospital?" Because that time in March 2020, the peak, nobody was willing to want to service a COVID hospital. And that is the time we mobilized around 700 people. We managed the entire operations. And what we realized was that patient, that time when he was being treated, and there was scarcity of the clinical teams from doctors and nurses, they hardly could give any time to the patient. And the patient had no phone. Patient could not communicate with the outside world. Who were they dependent on? People like us. And we were on ground, and we had to connect and engage and give a sense of confidence. Don't worry, aap theek ho jayenge. Hum hain aapke paas. So I realized the engagement level is so important. And I think most of the panelists maybe they miss out maybe how much important or how much impact can a non-clinical services team can add value on impact the entire healthcare operations in environment. So looking at that, we also curated a concept called IQMS, Intelligent Quality Management App, a tool where we're able to now take a feedback from every discharge room. So technically what we have is the HRMS system gives us number of discharges per day, and then we have a set team that will do the discharge room protocol and then exactly meet that patient and take the feedback. So when the feedback is taken, it is specifically to the hygiene, specifically to the cleanliness, because I think when the patient is in the hospital and the relatives, they are so observant, right? They can 24/7 smell and actually analyze and, say, yes, the hospital is clean or no, right? Doctors and nurses will come for a fraction of, for a couple of minutes, treat them and go. But 24/7, they are surrounded by the environment. And that's what I think we play a very important role by ensuring that we do it scientifically, ensuring that we educate the customer, the patient, and then engage and then take the feedback. So these are my experiences, and I think that's the value that we can bring to the table in the healthcare fraternity.
Very important point by Mr. Edward, and my take home message from him is that before you take the feedback, please engage. If you don't engage, the feedback is not going to be good. Okay. Coming in the second round again to Dr. Parag Rindani, we all know that we want to have a culture of patient safety, of quality, of engagement in the hospital. However, there are challenges. Challenges will come from all quarters. Your nurse, your paramedic, your resident doctor, they all will come to you and say, "Sir, hum form bhare, format bhare, checklist bhare, ki patient ka dhyan rakhe." So they all will come and complain. We know when we started NABH journey, we were written off कि तुम लोग तो कर ही नहीं पाओगे क्योंकि तुम इतने सारे पेपर वर्क बढ़ा रहे हो, इतने सारे चेकलिस्ट ला रहे हो, तुम इतने सारे फॉर्म्स एंड फॉर्मेट्स बना रहे हो कि तो हमको पेशेंट को छोड़ के ये सब काम करना है क्या? We had a tough time explaining them that once this culture is established. So anyway, my experience I will share later, but up to Dr. Parag Rindani to share his experience, how he manages such tantrums from his staff.
I first of all, I don't have tantrums from my teams, and therefore I don't have the opportunity to throw tantrums back at them. Challenges are common across the industry. I think one of the biggest challenges is attrition, the ability to retain trained workforce. And I think this leads to the second, but which is actually the largest challenge, and that is of communication. I have my colleague here, Dr. Clive Fernandez, who is our group clinical director and our chief operating officer. One of the things that I have learned over the last decade from Dr. Clive is that communication is the key to most problems that happen, poor communication that is. And I think that's the other thing that we've always looked at is that if you do the root cause analysis of any near miss or sentinel event or any accident that happens, a medication error or fall, bulk of it will land back at communication. The third challenge that I'd like to probably point out is resource constraints. There is actually a standard now in NABH which talks about nursing units having adequate nursing sort of equipment, like enough pulse oximeters, enough BP apparatuses, enough stethoscopes. Any nurses in the room? Well, that itself is a resource constraint, that nurses don't attend such things adequately. I think for some reason, administrators need to really buck up on this front. We can't have 3 and 4 nurses in an industry which is essentially backed by, we keep saying backbone is nursing, backbone is nursing. We are spineless right now, technically, So, well, but we could have the managers, right? We could have the leaders right here. I think, but the crux is the second C, is the complexity of our systems. W. Edwards Deming very clearly says that all mistakes belong to the system and the system belongs to management. Indians are beautifully prone to constantly being system hi kharab hai. But you realize that when I started the Wokat Hospital, or when you started Hinduja Hospital maybe 60, 70 years ago, over time these systems and processes have got evolved by us. Hum hi system hai. Until we decide that we are not, supposing, for example, if a nurse has broken some medication, we decide we're going to waive the charge, then we will really empower our nurses, our technologists. If, for example, there's a test that has been run twice for some reason, or something has gone wrong, and we keep penalizing our people, we're really not getting into the non-punitive culture. So I think there are multiple solutions to this. But I think the crux to this is education. There is this famous joke where the HR manager and the CEO are talking, and the CEO says, why do you need to train them? They're anyway going to leave. And the HR manager says, what if we don't train them and they stay? So that's our standard problem in healthcare. On an average, across, so we run hospitals in tier 1 and tier 2 cities. So we know the problems of India and we know the problems of Bharat. And let me tell you, the problems of Bharat are very different. There you have nurses who don't leave. So even the bad ones don't leave, And in India, we have the good nurses who are constantly leaving. Qatar, Oman, UK, US, Philippines, you name it, they're all going. Okay. In fact, we should probably start charging nurses now for the training that we give them, because they really benefit from the training we give. But jokes apart, I mean, on the lighter side, whatever years that they stay with you, they do fantastic service. So a big round of applause for all the nurses in the room and those not in the room today. I think the crux is also that to have standardized, dedicated programs for training, we invariably tend to focus, and I know that Vijay Agarwal sir is here, I know we're at a Caho conference, but we have to acknowledge that many of us work for accreditation only around wo 5 din. And the reason we have chosen to do this is because we believe it's okay to just show. We have to understand that accreditation is a profit center. You can save money. You can add to your bottom line. You can add to your patient satisfaction. You can add to your patient coming back. Because at the end of the day, the CEO, CXO's role is essentially this: to enhance the patients coming back to the hospital, to ensure that the patient goes home safe, to ensure that we don't hit Times of India front page with a negative headline. You'd rather hit it with a positive headline of some complex transplant done, some complex surgery done. And I think to that end, every member of the hospital has to be clued in, has to understand, and I'm here again reiterating the point why accreditation was started. It was never intended to be this document heavy, uh, person dependent sort of exercise. It was meant to be a system setting up exercise. You're expected to set up systems, not just 5 din ka tamasha. And I think that's why Caho has also got into it. I think the capacity building that, we at Caho have been jointly working on, Lalu's unfortunately not here, but I think that is the other thing which is the backbone and is supporting accreditation. Healthcare Skills Sector Council is another major body that's been supporting. I know Hinduja is a major hub for a lot of training. And I think all of us need to contribute to that. We cannot afford to be complex system driven. We have to simplify our systems. Do not blame it on accreditation. I think Hardik said it very well. I don't think accreditations demand their pound of flesh in terms of paper. Welcome technology. More and more technology will mean less and less paper, will mean less and less work. We are ourselves at Work Hard Hospitals working on a lot of checklists, etc., which are now, on tablets and on supported by technology. So think big, think larger than life, and don't think of today. Think of what your patient is going to ask you 10 years from today. And your patient 10 years from today is going to be a Gen Z person who's going to bring his father into the OPD. He or she is not going to wait till you print out a report and give. He expects things online. He expects you to deliver quickly. And he's not going to wait for your complex solutions of writing in a register and then again going behind and say, hey, Devu ka hai na, hey, patient nahi. So I think it's very important to recognize who we are dealing with, to understand what truly is the voice of a customer telling us. Thanks, Hardik.
Hello. Yeah, thank you, Dr. Parag. So you summed it up all very well, that to overcome the challenges of maintaining the safety and quality culture, all we need is constant communication, persistent training, and use of technology. Now, talking of technology, I will shoot my next question at Mr. Chakravarti. Why? Because you are now the COO of Human Care Worldwide. You deal with a lot of technology and gadgets in terms of air ambulance, in terms of ground ambulance, in terms of maybe remote monitoring. So are there any technologies which can help us to take care of, the patient as a center without constraining our already scarce resources more?
Yeah. Now technology in a healthcare setting is totally different, and in a patient-centered care is totally different. Patient-centered care starts from the patient coming in before coming to the hospital, in the hospital, and post-hospitalization also. So that is a totally patient-centered care. So in fact, the patient-centered care worldwide is measured after 11 days of the discharge, where they feel a patient is totally recovered and he is now ready to report us exactly what is his experience and his satisfaction levels are. So now coming to the technology, yes, technology is much needed, and it is, of course, even though it is not so cost effective, but we have to adapt it to make our life easier, everybody's life easier. That's where the total patient-centered care concept is coming into around. Now the CDSS is the first technology that's being adapted, and now the technologies like 5Gs are coming up, where we monitor the patient live with the IoTs and in the ambulances. And now we are tying up with ISRO also to get the satellite phones active and the cameras active in the airline industry also, where the treating doctor who is shifting and who is accepting are going to monitor the patient right from the shift, before the shift, during the shift, and post shift also. So now technology is going to become more easier when ISRO is ready to dedicate their satellites to healthcare industry. Now they are almost dedicating some 14 satellites to healthcare industry, which is coming up in the next government order in 2025. And with one of the SDG also that's available. And apart from this, in the patient-centered care, informed decision-making is there, and health information exchange is easier. No need to carry any physical records, and EMR has become more active now. Everybody are becoming digital. So apps are there, mobile health are there, remote monitoring, IoT devices. Technology is now unlimited. Artificial intelligence ruling us. Yes, we have to also become intelligent more than artificial intelligence and go ahead with the technology. So technology is mandatory, and we are in tandem with the technology. Probably it should be cost effective. That's it.
Thank you. Thank you for that. My next question in round two is to Dr. Supe, sir. We are talking about patient quality, patient safety, patient-centric care, a lot of it. Now, as already discussed, do you think this is time consuming, and in the constrained manpower resources, would it lead to time and cost overrun and at the same time decrease efficiency and productivity? There is I can use the word myth, or maybe it's a truth. Some people say that it will decrease your productivity and efficiency, and proponents of quality like me believe yes, that no, it's the other way around. So your take on it?
I think you only said, I think Parag said, when you start with NABH, how much resistance you see from the people. So if you really see the world across today, the world is fairly divided on this. If you really see, many of the European hospitals probably don't want now accreditation because they feel we are spending too much of time on accreditation. And so people are talking about trying to improve the culture and trying to see it. So then it's non-measurable so much except for the patient experience feedbacks. While many of the countries continue to do all kinds of accreditations and documentation so that you have a parameters and KPI and everything, you work on this. So the question is, how do you really balance the amount of effort we put in all this and the output you get it? So ultimately you find the leadership is most important. And how do you look at this whole problem as a leader? I personally feel you would draw it into a typical format, typical, management format, which are the easy things to do, easy to implement. You would do it very quickly. Where there is a little difficult people to really do it, you may put it on hold or something like that. And with a lot of cost involved, then you have to really take decision. But I think the first important thing is that, are you conceptually agree that patient-centered care is needed and it improves quality and safety? If you're convinced about this, then I'm sure you will start talking steps towards it. How much to really go ahead, how much of stakeholder analysis and metrics you do and how much you implement depends upon individual leaders and individual capability of an organization. I have a feeling most of us have started walking this pathway. We are now believing accreditation brings some of these changes directly or indirectly. The question is, there are some last mile kind of an activities which we still are not doing. And I personally feel these are because of the cost constraints. There are too much of cost, too much of time which is there. So many of the things which we are not able to implement are because of we feel that they'll bring down our efficiency. So I think every institution takes that call. But I think balance to begin with is absolutely fine. As a higher you go, I think you have to really look at the culture of organ, because there may be unions coming in, they may not be able to do it at a lower end. But if you are able to bring that culture that the patient is the most important person in the hospital, and you have to be around the patient, whatever you do around. I think if you understand this and follow this, I think half of the job is done. Then you don't have to really worry whether it is efficient or not.
Yeah, truly said. So as if I interpret your answer right, some of it is in white, some is in black, and most of it is in gray, and is for a particular institute to find its own way. Yeah. This is the last question of this round and of the panel, directed to Mr. Edward. Because you handle a very large force, manpower force, how do you, train them for measures in quality, safety, patient centricity, and more than that, how do you measure the impact this training makes on actual quality and safety?
Yeah, that's a nice question. Let me take from what Dr. Supe just said. This takes me 12 years back when I first, I went to US and I was working with a multinational company who were the healthcare experts, and I learned the word culture. I mean, the culture change, and I learned the word patient outcome, and I didn't really knew what it was really, unless I visited a couple of the hospitals. I realized the programs that they develop to the ex-JCI members, which is the last mile program where the service providers do, right? Whether the housekeeping or the patient care, they're the last mile team that finally drops the patient in a wheelchair to be in a car. culture change was so important. And I realized the impact later when I came back to India. And I realized our scenarios and how, our contractors or service providers are managing all of these. There is no culture. It is just, it's like rosemary tala kon rade. That was a concept in Mumbai that I learned. Like patients come every day, go, patients come every day, go, and nobody bothers about it. So what we developed over a period of time, I realized what's important is to do a culture change. So when we pick up a hospital into the operations, so we take a 90 days challenge to bring in a culture change. And what is that culture change? We have a concept called I Impact. Again, this was developed by ex-JCI members, and we learned from that. How do I impact? If I am a janitor, if I'm a patient, care, associate or a GDA, how does my work impact a patient's outcome? These are the questions nobody asks, and I started asking these questions to myself and to my team members. I said, let's develop a program. In that sense, when I tell my, a female janitor, and she puts up a board saying, I'm not a doctor, but I'm here to help you. My guy who mops the floor, he said, I am not a clinician, but I can help your stay make your stay more safer. Now, how do we do that? And that's when we came to a program called Smart Surface Disinfection Program, whereby we have formulated a program where our janitor, when he comes, would knock and would engage with the patient and say कि मेरा नाम एडवर्ड है, मेरे पास 3 color coded dusters है, ये वॉशरूम के लिए है, ये आपका पेशेंट बेड के लिए है, ये टेबल्स और चेयर के लिए है, और ये मैं करके इसको वापस बैग में डाल के लॉन्ड्री में भेजूंगा. And I take one kind of a mop, do the entire room, put it in the bag and go to the laundry. So when we do these kind of a communication engagement with the patient, so we're technically educating patient about a safe environment that we are creating. I mean, as service providers creating. It's so important. Otherwise, a patient will never know कि मेरे रूम में कौन आया था, कौन गया था. And 4 days के बाद में, if you take a feedback, it doesn't know कि Edward आया था कि भोला आया था. So with that engagement and education that how I do my job so scientifically that I'm taking care of your safety. I'm ensuring that I am helping you recover faster. So that's the kind of knowledge and the program that we brought in, and the I Impact program, which is a culture change program that we try and make our team connect with the patient's outcome. कि भाई तू एक भी गलती करेगा, if you dilute it incorrectly, if you use the wrong mop, if you're using a very unhygienic method of doing it, you can cause the patient to stay more longer or get hospital-acquired infection. So all of these things that we train our teams much in advance, and the feedback that we receive when we engage with the patient knows that I became all right, and then my team only takes him right till the last mile, drop him off in the discharge room. So all of this is so connected. That's why we use the word, call it's all connected. So program, culture, safety, and it's all connected is a theme that we drive in a service provider business.
So the connected dots here are engagement, impact, and feedback. So you first engage, create an impact, and then feedback to measure the impact. That's how you do it. Very, very nice. So I will conclude very quickly because I remember Dr. Joy Chakravarti using his authority to waive off the tea break, to forfeit the tea break. I don't want the lunch to be forfeited. Okay. So I will conclude very quickly that what we need to do is create a culture of patient safety. We have started, but we need to further strengthen it. How do we do that? So what is a culture safety? Is the belief, the norms and value of each and every staff in the hospital which govern their actions and behavior. So those norms, those values should be aligned with patient safety. AHRQ has given a 4-step model where first the staff should know what is acceptable for patient safety. Once that is achieved, you should know what is expected for patient safety, followed by what is promotion when you go beyond the norms, and then reward. This should happen at all levels in your organization with the employees at each level to promote and foster a culture of patient safety. I invite any questions for the panel if the audience may have. Dr. Parag says that panel was so clear, there are no questions. Thank you. Thank you, everyone. Thank you so much.
Please, the mementos, please. Yeah. I would like to request Dr. Hardik Ajmera to please present the mementos to the panelists. Sir, please stay back for a group photograph. Next. Next. Now I request our CEO, Mr. Joy Chakravarti, to please present the memento to Dr. Hardik Ajmera.
Thank you so much. We'll come for a group photo.
Yeah. Next, Dr. Deepak, please come. Next session.
Thank you, Arindam. Good afternoon, one and all. Today, we are thrilled to delve into the critical importance of preventive healthcare, particularly with our next session. The title, The Crucial Role of Preventive Approach to Patient Health with Focus on Adult Vaccination. With our esteemed speaker, Mr. Amit Sharma, Director Lead Strategic Accounts and India Neighboring Markets from Pfizer Limited. Let's warmly welcome Amit Sharma, sir. We begin the sessions now. Thank you, sir.
No, I don't want to point it, but we can move around. Okay, good afternoon, everyone. And first of all, thank you, Team Caho, Hinduja, and particularly Joy. Joy has been one constant person who has been, I am possibly coming from, let me introduce myself. I've spent
almost my entire career in telecom, in transformation of business and services. And just about 2 years back, I joined the healthcare industry for the passion I had for doing something about human lives. And Joy has been a constant force of guiding me in this multiverse of healthcare. And today, my talk or address is more about what is in this industry which is there as a possibility. For I fall into awe every day I spend in this industry whenever I visit a hospital of amazing things which are being done. But my conversation, as I'm still a student, and all of you in the room possibly know much, much more than what I have gathered in last few years. So it's about the needs and the gaps which I have observed and the possibilities which I see. It's about the communication which is missing and which needs to be done. And Dr. Parag has spoken much about the importance of the same. It's about working on the pillars, which I call back, which says, let's be brilliant at basics. Execution will make the difference. Collaboration for it's required to be amongst partners. And communication needs to be the sutradhar of all this to happen. So without wasting further time, let me first of all share a disclaimer which my company says, guys, he has introduced himself. He does not know much about treatment, and Pfizer did not necessarily subscribe to all my thoughts. And with that disclaimer, let me talk about the subject is patient safety healthcare, and we all learned even as children that it starts with the preventive mind, and prevention comes first. And if I just look at as to how WHO defines prevention, it says all approaches and activities which are primarily aimed at reducing the likelihood that a disease or disorder will impact an individual, either interrupting or slowing down the progress of a disorder or reducing disability. But let's forget that. India has very different demographics. For us, a prevention for many of the people living below poverty line to maybe approximately 30% of the population of India might mean a difference between life and death. Prevention might mean not going to a status where there is a huge debt because of healthcare on a person, and going and moving up to the cohort, which is middle class, upper middle class to super rich. It might mean simply healthy aging, eating right, being active even at 90. And that's the maximum burden which a state has of saying how we can age healthily. Now, there are various approaches of preventive healthcare, primary, secondary, tertiary. I did call out brilliant at basics as one of the back pillars. So I'll go to the second and third first, which is secondary. What we call a preventive mind today is one who just goes for possibly a regular blood checkup, mammography, to identify if there are lead indicators of any health issue. And tertiary is when really the disease has been diagnosed, and then there are surgical to chemo to all other interventions which are done. Now, reflecting back onto primary, it's about what do I do as an individual? Eat right, possibly drop the wrong habits of smoking, drinking, or do I even look at vaccination as a preventive mindset? Now, this basic is what generally is missing, and we all know by heart, each of the people sitting out here, though belonging from the healthcare industry, knows that we miss the basics. Now, if I have to talk about how vaccination has gone and driven over the years, it's well established fact that vaccination has been established in countries, particularly developing countries, even developed countries, for children. You have a national immunization policy today for pedia, and almost every child gets vaccinated. But when it comes to adults, here you can see some list of 18 vaccinations which are there, spamming from pneumococcal to shingles to HPV, and you name it. Now, when I said there is a primary part of saying eating right to exercise, may I ask a question? How many in this room did some kind of exercise in last 3 days? So I can see some 10 hands out of all the people. How many of you are pneumococcal vaccinated? So around 3 or 4. Okay, let me say rabies. Now, when I said being brilliant at basics or really thinking primary, and we have been talking about a change and shift in culture, and Edward did speak about it. This is about it. What are we doing, first of all, to avoid the scenario of a huge financial debt or very long stay in ICU, which is even leading to a non-profitability for hospital? Right? How are we calling ourselves a healthcare? Are we a sick care industry, or are we going to do something proactively about it? Just picked up some stats for this talk, and there's 30 to 40,000 mortalities even in a country like US. And the burden of disease, of vaccine preventable disease in US is US $10 billion. Now imagine India having 18% of the population. It's just that numbers don't get reported here. It's just that government or a payer business is only about 30 odd percent. But what this really could mean. This is another study available by CDC in which I looked at various data points. And if we look at influenza and a data period from 2015 to 19, around approximately 127,000 cases and 800 odd fatalities. Of the cases studied for invasive pneumococcal disease, IPD, 60% of them had a pneumonia or pneumococcal septicemia, and 25% had meningitis. And you can go on and to say that hepatitis, out of all the cases tested, close to about 6 lakhs, 7.5% of them were found to be positive. So this may not talk about the burden of disease which is there in India, but really talks about statistically as to what it can be and what needs to be done. This is again a Niti Aayog submission in which they clearly state preventive care immunization is a neglected subject in India. And they clearly realize as well that there are diseases right from pneumonia to influenza to pneumococcal disease to hepatitis, shingles and all, which are vaccine preventable. Here's 4 of the societies mentioned, right from Geriatric Society to Association of Physicians of India, Indian Medical Association, and Occupational Health. And this is just a list of saying what all vaccinations should be done in 60 plus years. That's where they started off from. And that cohort itself is huge in India and it's completely missing. This is by API. And if you just look at the colored ones, which are green, blue, and yellow, which necessarily says advised by global, or the blue one says the people who are adult and have comorbidity, and the yellow one says people of certain age of certain professions, so for example, healthcare professionals. And if you look at the vaccinations which are there, almost pneumococcal, influenza, hepatitis, meningitis clearly stand out. In fact, if you see, it may not be visible, but the healthcare professional vertical, almost all vaccinations are recommended except for typhoid. Now, when I asked, just sampling around in the room, 2 of the vaccinations which have high morbidity rate, I could just see a couple of hands, maybe 4. So even in airlines, they say that in case the pressure drops, first wear the mask so that you are in a position to help somebody else. So this really talks about what we know, but what we really do about it. Now, towards conclusion, I'll just now say why possibly these gaps are, right? We all attend so many trainings and we say, इसमें से एक भी चीज adopt कर ली ना, I can change my life. But another 10 days and we forget about it. Today's my talk, as I said, I no expert, was just to again put you in a direction and a thought of saying what more can be done. And even if just look at revenue numbers, if that excites you, 3,200 crores is kind of the vaccination market of India in terms of private market. Looking at sheer numbers and the vaccinations, it can easily be 1,50,000 crores. And just by being preventive, right? Now, looking at the gaps, what I've experienced, there are 4 cohorts in which the gaps exist. One is the individual or a patient. How many of us are aware? Now, my parent got a message from one of my uncles that why don't you go for a Prevenar and an influenza shot? And he just says, okay, fine. He got aware and he just called me and he got vaccinated. A simple awareness and then a consultation with doctor led to a conversion. Point is, most of the people are not even aware. Second is cognitive bias. It will not happen to me. And for many of the Indians, it is also affordability. But the group of hospitals which are represented in this room, technically, most of the patients who come there will not have this challenge. Now let's talk about doctors. I have not done any quiz or test to say awareness, but I'm pretty sure all of you have practiced over the years and you must be very well aware of what kind of vaccines are there. What's the different challenge which a doctor faces in his OPD? Do I take care of a patient who has come with acute need at that point in time? And then there is a line of patients who are there outside the room, or should I spend 2 more minutes or 5 more minutes in consulting about what preventive healthcare prescription should be given to the patient? This is a real world scenario and not shying off from really putting it out in the front. Then it comes to the hospital itself. Are there any protocols? Now, I'm not going to IPD and OPD and health checkup protocols, but simply saying if there are 5 kind of practices, say a pulmonologist, a nephrologist, cardiologist, possibly a general physician, and a pedia. These are the 5 practices which see the maximum load or burden of all the vaccinations or people have comorbidity. And finally, it's the ecosystem, right? From cost to really, as of now, we don't even have insurance for OPD cases. So if we really take care of these challenges, and my conversation to have it in the hospital is because this is where I see the temple of healthcare, and for 2 reasons, that the kind of hospitals which are there, the top notch, represent and have a reach of close to about 10 to 15% of Indian population, which clearly does not have affordability challenge. And the kind of innovation which these hospitals and you guys are doing in terms of creating the new benchmarks of healthcare. Yes, I did speak about adult vaccination in general, but definitely I come from Pfizer. So let me spend a minute there as well as to why I wanted to have this conversation and why Pfizer possibly. 4 reasons primarily. 1, we have close to about 16 odd vaccinations which are there in the pipeline itself. In phase 1 trials, there are 6, phase 2, another 6 in phase 3, and 2 are there for registration, spanning across the areas of influenza, RSV, HPV, pneumococcal, streptococcal, and you name it. And we have a strong pipeline as we exist. We have 3 vaccinations for COVID, meningitis, and pneumococcal. But that's not important. For it to succeed, it has to be adult vaccination and not limited to any particular company. But we have the will to do it. And hence we are going to set up some 25 center of excellences. We have already done 9 of them. And they are adult vaccination centers. They're not Pfizer vaccination centers. And we want to establish them more. And lastly, a long-term. Now, this is my concluding slide. So I didn't want to really take much time. It was just about saying, as Dr. Parag said, communication. And hence I'm just saying dialogue. Everything starts with a dialogue of the collaborators of doctors, policymakers, and everybody involved, including pharma companies. Let's start that. Second is awareness. That's simply missing. What can we really do about making people aware? Right from using digital media to eyeballing on the digital screens of the hospital, to have so many display things, to even having a patient safety card, which simply says if every OPD a simple card is carried, which is a vaccination card, a patient himself will say, okay, fine, there are 5 or 6 vaccinations which are recommended. Or a doctor will get reminded once he's going through the acute need of the patient, okay, fine, have you taken this vaccination? So what can we do about awareness? Third is the role of the hospital, which is in terms of what we can do in terms of protocol. And I will say easiest to start with are OPD ones, which is the 5 practices which I did mention about. And then going to health checkup where people come with a preventive mindset. And then finally, as a hospital, can we dedicate some facility, digital as well as physical, for making vaccination as a possibility? As I said, this is a talk more for in terms of possibilities, in terms of preventive healthcare and a culture change. So I'm very open, and so should be every other person in the room, of saying, please let us know what more can be done. With that, I'll end my conversation saying, we all know that we need to do it. We know it needs to be done, and together we can do it. First by starting ourselves, then our family members, and then definitely the patients. Thank you so much.
Thank you, sir, for this informative and enriching sessions. I would like to invite Mr. Joy Chakraborty, sir, to felicitate and the thank you to Mr. Amit Mishra with memento and book. Thank you, sir. Now I will call to Dr. Preeti Goraksha to get.
For the next session, we all have heard, first Dr. Parag, Mr. Sharma now, that, we have to have dialogue with the patient. So whatever clinical care we give is excellent, but we need to have dialogue. That actually is our next session, patient engagement for better outcomes. For that, I invite the moderator for the session, Dr. Clive Fernandez. Dr. Clive Fernandez is a Senior Vice President, Group Clinical Director, and Group Chief Operating Officer for Wockhardt Hospitals. Dr. Kunal Punamya, CEO, SI Raheja Fortis Hospital. Dr. Shilpa Tatake, Group Chief Operating Officer, Jupiter Hospital. Dr. Vijay Agarwal, President, Caho. Dr. Sushila Kaude, Chairman, Maharashtra State Chapter, Caho. Over to you, Dr. Clive.
Good afternoon. No, this is wrong, because only Dr. Joy went and had the cup of tea outside. What about the poor audience? So good afternoon. Wonderful. How are you doing? Tired. Right, and I know because, this is the session preceding lunch. All of you are pretty hypoglycemic, right? So we are going to keep it pretty interactive. I know I'll take up from where Mr. Amit Sharma left. You know what he said? What were the last three lines he said? We all know we need to do it. We all know it needs to be done. And do we do it? And now I'm talking about patient engagement. So we are talking about, I'm just taking the baton from there. So first of all, I'd like to thank Mr. Joy and Caho for this opportunity. It's a very good topic, patient engagement. So I just decided, let me do a Google and look at what exactly patient engagement means. And that was the wrong thing I did. How many views it gave me, or how many results it gave me when I did only one word, patient engagement, and I said search. It gave me 92.5 crore views. But it's not that much, So when you look at it, and I just went and I saw, it's basically talking involvement of the patient, participation of the patient to achieve patient-centric care. So today what we are going to do is, we are going to be talking about who does this. Audience, I am going to keep you interacted in all of this. Who's supposed to do patient care? All. When are you supposed to do? Every time. Why are you supposed to do? So that you don't come on the first page of Times of India, like Dr. Parag said. Okay. So basically it's about empowering individuals, to drive their care. Today, if you look at my panel, we have very seasoned and very experienced panelists here. Do we have a patient? I was thinking, Joy, do we have a patient or a visitor on this panel? We didn't keep purposefully. So do we have a visitor or a patient in the audience? Okay. So who has not been a patient? But sir, we have to keep those biases aside. So now we have a very seasoned clinician, Dr. Vijay. We have a CEO, we have COOs on the stage. So every question that I'm going to be putting to them, they are going to answer in their capacity as an administrator, as a CEO, as a clinician, and I'm going to play the patient's role. I'm going to play the moderator's role. Okay, and so that we keep it interactive, remember that hypoglycemic clock. So it's not going to be one question for the next 60 minutes. We are going to keep it short. We have some ground rules, and we are going to have multiple questions. And I want you to interact also. My panelist, or I may ask a question. We can't ask you to answer. We may tell you, raise your hand. And we are watching, those who don't raise your hands, you're sleeping with your eyes open. Okay, so to begin with, I would like to understand, and this is to all my panelists, we've already discussed the rules. So in your different roles, what is your understanding of patient engagement? And do you think it impacts outcomes?
Good afternoon, everyone. First of all, thank you to Caho and to Mr. Joy Chakravarti for inviting me over here. Patient engagement, I feel, is a very important tool because, like someone said in a movie, what else we here for, right? So I think when you are talking about patient engagement, for us, it really means that your patient should be able to understand what is happening with him. Like everyone feels most safe at home, right? You all feel very safe at home, but still when you are unwell, that's a time you leave your house and come to a hospital. So that means you are not feeling safe at home. You want to leave your place, which according to you is of maximum safety, and come to another place for your own safety. So so the patient is entrusting his life upon us. So over here, you need to tell the patient that he's safe. He needs not to worry and just abide by whatever treatment that the doctor is giving. It cannot be that the doctor comes, prescribes something and doesn't talk to him. It's not just about history taking. It is about understanding his pain and understanding what he's going through. And it is again not restricted to the doctor. It is even for the nurse who would render the care to him in terms of giving him tablets, in terms of giving him the injections, in terms of the ward boys and any other people who will attend to that patient for anything, you need to talk, you need to communicate. Even at the time of admission, you need to communicate. That's very important. And it's very important to just take to say that don't worry, things will be fine. So patient engagement for us is extremely important. It starts right from the entry point, and it has to be maintained till the time the patient exits the hospital.
Thank you, Dr. Kunal. Yeah, Dr. Shilpa. Your understanding of the term patient engagement, not the theoretical one, the practical
Understood.
one.
Any which was, I would have spoken practically only. So, first of all, thank you, Mr. Joy Chakravarti. Thanks, Caho, for giving me this opportunity to be here with you all. So, any which ways, I'm not referring anything textbook and I'm not even referring jargons today. For me, patient engagement means the crux of the healthcare because what Sir rightly had said, who had not been patient over here, we all had been patient or we all had seen our near and dear ones as patients sometime in our life. So what do we expect that time? Most of us expect a kind of, just because we had the fortune of becoming a part of healthcare industry, we expect that there should be red carpet, there shouldn't be any waiting lines, there shouldn't be any queues for us. The doctor should immediately be waiting for us and they should see us or our relatives immediately. The nurses should be standing over there to take care of all of us. We expect it. Just imagine the patient who is paying, won't he or she expect the same thing? Yeah. So when we discuss, when we talk about healthcare, the jargons and everything, we neglect the basic part and the basic foundation of the healthcare. The whole delivery system stands on only one foundation, and that is a patient. We are not obliging patients by engaging them. Mind us. So it is a basic right of patient, and it is our responsibility that we engage patient, we involve patient, and we empower patients at every touch point of the care setting. And if we don't do that, today's patients are also so demanding, they will make us do that forcefully. So it is our choice whether do we do it willingly or are we going to get forced to deliver our responsibilities, which ways we are supposed to do. So I feel patient engagement is a kind of essence without which none of us should exist. And in the coming days, as in the last session, somebody has said that coming 10 years, the patients are going to be more aware, more demanding, especially Gen Z. My experience is that unfortunately in Indian healthcare settings, we only pay attention to those who are VIPs, who are politicians, or who are the nuisance maker. The other common people who do not have any voice, we try and bulldoze them. That is not definitely a patient engagement. This is what is my take.
Thank you, Dr. Shilpa. So that was very good. It's not about the nuisance maker or the nuisance value patients. It's about the right of the patient. But in one word, do you think it impacts patient outcomes? Yes or no? Sure. Yes, Dr. Vijay.
So thank you, Clive. So my take on the patient engagement, I'll have to go back, first of all, in my time. I am one of the pre-independence era specimens. So the issue is this: the patient engagement has undergone a sea change. I'll give you a scenario, and that scenario, sometime we used to kind of crack joke, but it is to make us understand what has been the situation of patients. So you can imagine I was in the so-called Irvin Hospital, which is now called the Loknayak Jayaprakash Hospital, associated with Maulana Azad Medical College. So a group of the medical students, final year medical students, were passing through the casualty, and they asked the casualty medical officer, boss, any interesting case? So he says, no, nothing interesting. There is an old man who has a large prostate. You want to feel it? So you can imagine that already that person had undergone that examination by the CMO and the ACMO. Now these 5 medical students did his rectal examination to feel the prostate. Then this patient gets shifted to the emergency ward, and there is a whole hierarchy there, right from the lecturer to the other demonstrators, this, that, etc. Because the professor of surgery was very keen that every surgery patient, everybody must do a rectal examination if you have not done it. But nobody is talking anything to this patient. All somebody is doing is to wear a glove and poke it in. So by the time the professor came and he was a hurly-burly, Dr. Jain was a real this thing. So when he was wearing gloves, he held his hand and he said, "Sir, if this is my treatment, I have 5 sons at home." So the issue is that is how we treated our patients. And that is what the patients, unfortunately, at that time, it was only a physician and a patient interaction. It was a game of badminton, you can call it, solo, which was going on. And for years, patients were quite happy accepting whatever we were saying. Over a period of time, the healthcare delivery has changed. This healthcare delivery has now become extremely complex and extremely, I would say, multi-stakeholder, with the result that the patient engagement issue, therefore, has now taken a kind of proportion today, which needs to be understood, for which the clinicians and the people in the hospitals, we need to kind of understand. I think the patient engagement, you truly understand the day you are a patient, you go to a hospital, that you understand what is it that you are wanting. Moment there is a VIP, you give him the kind of engagement that every patient should be receiving. So, I mean, this is an area where we can keep talking, but let's stick to your time.
So, we all agree that we know what patient engagement is, but we have that switch. VIP patient है, कोई important patient है, management को जानता है, switch on. Acha, like he said, now someone said in the previous one, patients come, patient engagement.
First of all, I would like to thank Joy sir, Hinduja Hospital, and Caho for giving me this opportunity. And I'm very fortunate to sit beside my fatherly figure, Agarwal sir. I'm not too big like my fatherly figure personality, but thank you once again for giving me the opportunity to express my view. As per mine, patient engagement is not a one-time activity. The way boy and girl get engaged during the engagement ceremony for the lifetime commitment, like a healthcare practitioner and being a healthcare institution, it is everyone's responsibility and it is patient right that we should get engaged in his or her first visit in the hospital for lifetime commitment. It is not only one time activity. During each and every step, during each and every visit of the patient, we should ensure and we should empower our patient that he or his family should take a part in decision making. Patient engagement is nothing but involve patient, empower patient and family in decision making from admission to discharge. For example, finalizing the clinical care plan, finalizing the nursing care plan, while giving the dietary advice, while giving the any physiotherapy or exercise advice to the patient, we should consider personalized patient engagement. As per mine, patient engagement should be personalized as per the patient perspective. If patient is of Jain community, we should consider like some dietary regimen should be different than other patients. So patient engagement is very, very important step we should consider in day-to-day practice. And when patients are coming to hospital, my dear colleagues, they are very afraid. We are sitting in Mumbai, which is the tier 1 city. But scenario is not same in other cities, especially in the rural hospitals. So in such scenario, we should ensure patient emotional comfort while ensuring the patient engagement. Patient should get feeling of patient is admitted like patient centered medical home. Hospital is nothing but a patient centered medical home wherein he should get feeling of emotional comfort, he should get a feeling of support, wherein all the stakeholders of hospital are taking into consideration patient's emotion, patient view, patient belief. So as per mine, patient engagement should be personalized in nature. Thank
Great.
you.
So now at least all of us on this panel, now we understand the term patient engagement and all of us agree it impacts patient care. Before I go to this next question to my panel, I want to ask the audience a question. It's patient engagement. If you had to choose, is patient engagement a boon or a bane? How many of you say it is a boon? Raise your hands. Okay, I'll give you options again. How many of you say it is a boon? How many of you say it is a bane? How many of you say I don't care?
Now you got option A, option B, and option C. And Joy is looking at all the option C's very specifically, you know. Okay. Yes. So how many of you think patient engagement is a boon? That's about 45%. How many of you are saying it is a bane or a pain, whatever? None of you. So what about others? You all don't care or you don't know? How many of you don't know? See, because you are the real people who are actually going to go out with something new. So how many of you don't know? Anyway, so it's a boon with pain. But haven't you heard of that saying, sir, no gain without pain? Yeah. Okay. So now, now we are all the goody people. We are sitting in a conference, we are a panel discussion, and we are talking on patient engagement. The last thing we can do is talk something bad. Correct? But just like every coin has two sides, if I may. Now I'm going to ask my panelists, if you had to choose, in your opinion, what would be that one flip side, perceived or real? What would be that one flip side? And I'm marking my words because, Dr. Parag also said, we don't believe in doing things wo 5 din or doing things because we attended this panel in discussion today. So we engage our patients. And after 5 days, who's the patient? So that one flip side of, actually implementing patient engagement initiatives. It has to be there. There has to be a flip side, right, audience? Jor se bolo. Wonderful. Now we are influencing them.
So anything that you would do will have a flip side. So the expectations rise, definitely. If you will tell the patient that आप जब admit होगे तो आपका 1 घंटे में discharge हो जाएगा, and it's a TPA and then it takes 4 or 5 hours. So definitely there is a problem. So as far as flip side is concerned, I don't think we can look at that and not engage. Engagement will have to continue.
No, we want to know one flip side. There are people who have written a book, the critics, they've written a book on flip sides. But that one, as a CEO, if I have to ask you one flip side that you have encountered.
So I feel that the expectations go sky high at times they probably become unreal.
Okay, so the flip side actually, according to Dr. Kunal, is actually managing or balancing the expectations. Dr. Shilpa.
How many of you are here from the operations side or who directly
This is
interact with
cheating.
patients?
This is cheating.
No, I need to know because my answer depends on that.
No.
Okay.
No one from operations, no one from nursing, then who's in the room?
So operations on those who directly interact with patients will well understand that it is employee burnout. It is healthcare workers burnout. Because it is not only the patient's skyrocketing demands, but we have to commit ourselves to fulfill and go beyond it. And one neglected side is like when as top management, we keep on pressurizing that every patient experience should be great. We forget that the middle line who deals with the patients many of the times undergo a lot of stress and leads to employee burnout. If we are not sensitive even for our employees, it is definitely a flip side for us.
So actually, Dr. Shilpa is actually, saying that, if we don't want people to be burnt out, all the people in this room, but we still want to have patient engagement, we might need to take in more people. That means more resources. I think an excellent point. Dr. Vijay, sir.
So from my point of view, I think it is the resource constraint, and the resource is even, basic fundamentals are going to be communication and education to the patient. So even communication in today's date, patients are traveling from all over the country, even to understand the dialect, to understand the language. So resource constraint, and even for the nurses, our nurses who are coming from Kerala, and they come to Delhi, they cannot understand even the local language. And again, it has happened, to give you another lighter one, is that in Escorts Hospital, a nurse is calling the doctor in the middle of the night and says कि डॉक्टर साहब बेड नंबर 22 को बच्चा नहीं हो रहा है. उसने कहा वहां तो सरदार जी हैं, जरा बच्चा जी कहाँ से होगा उसको. बड़ी देर में उसको समझ में आ रहा है उसको बेचैनी हो रहा है. So क्या पेशेंट एंगेजमेंट करोगे आप in case that is the issue.
So, I think a very well put point by Dr. Sir. It is not only about the resource constraint, it's the cultural aspects. Badi mushkil say, first of all, we say we want nurses from Kerala. We don't want nurses from here. Then we say, ab dekho, tum ye 4 line learn kar lo. पांचवा सवाल अगर आएगा तो डोंट आंसर इट, क्योंकि बेचैनी हो रही है, को बच्चा हो रहा है कर दोगे तो प्रॉब्लम होगा. Okay, so there is a cultural aspect, there is a resource aspect.
As per mine, flip side of this question is patient expectation, because sky is the limit for patient expectation while ensuring the patient engagement. Because being a healthcare practitioner, it is very difficult to what I would say, fulfill patient expectation while ensuring the patient engagement, because patients are coming from different stratas, different eras, and it is very difficult to fulfill and ensure that all category patients should be engaged in one particular point, having different expectations. So we should understand demand versus need while ensuring the patient engagement.
Audience, you're with me till now? So now we have understood from the panel that there is a flip side, right? It could be resource, it could be cultural, or it could be expectations. Lekin, kintu, parantu, but we are still sitting in a panel discussion on patient engagement. And we have senior leaders here, who are not here only. I don't believe any of us is here only to give a talk on patient engagement. We actually believe in it and we drive that, So my next question is now going to be more to the panelists based on the role that they are doing. So Dr. Shilpa, I would, like to ask you this question. As the COO of your organization, as the group COO, can you enumerate some of the top operational job doon rahe the na, the operations people? Can you enumerate some of the top operational challenges that you have encountered and how you deal?
Yes, as I said, patient engagement is a long journey. The first and foremost challenge, basically, when we talk about patient engagement, what we think doesn't start when the patient gets hospitalized. It starts when patient starts interacting with us right from the call center until the time patient comes and actually physically to the OPD. So right from the call center perspective, how do we receive the calls? How do we answer the calls? How do we get the patient to OPD? How do we guide the patient? Because I mean, hospitals like Hinduja, Lilavati, Jupiter, these are the big hospitals. Sometimes patients feel they are getting lost. So how do we, like in hotels, when we go, there is some scholars, there is some scribe who can take us around. How in hospital we will be able to guide the patient. Right from there, the engagement begins. Patient gets in the OPD, patient gets the consultation done, and then gets confused where the investigations are to be done, which is to be done today, right now. What if there is an admission required for surgery? So all these multiple touch points are there where the engagement or the involvement of the patient is needed. More critical challenge is like when the patient actually gets admitted. So when you ask me about the operational challenge, it is right from changing the culture. And why do I say changing the culture? Why do I not say setting the culture? Because many of us come from a background that this is 9 to 5 job. I mean, I'm not talking about the senior leadership always, but right when we talk about the patient touch points, it begins from the junior most level. Most of them, I mean, as somebody was saying, we require to make them understand why they are here for, what is the importance of the job, what they are contributing exactly for the patient's positive outcomes. So there the difference happens. We will have to make them understand that their contribution is very critical in actually improving the patient's clinical outcome. So right from changing the culture, setting the mindset. And second typical challenge which I face is like we become very impersonal while we talk about our patients or talk to patients. We have a typical tendency, 521 के patient को 431 का cholangitis है, इसका appendectomy. We never address patient with names. That is a major thing. And that creates a lot of difference. Suppose, for example, tomorrow, all of us, somebody might be a successful businessman, somebody might be a good doctor, somebody might be a retired army person. We all have some identity. And suddenly it gets lost when you get entered in a hospital as a patient. And then somebody starts calling you by the numbers. Why? Are we prisoners? So your engagement, the culture change, right from there, it has to start. I believe personally, it has to start from a senior leadership. How much importance we give to our patient engagement, our patient involvement. That is how, I mean, there is a Sanskrit Subhashit, Yatha Raja Tatha Praja. It has to get imbibed from there. That is one thing which is a culture change. Second change, second challenge, what I feel is personally information. I mean, we all know that correct information, accurate information, timely information. Sometimes I feel in the metro cities like us, over information also is a challenge. You know, sometimes we keep on talking to patients and we keep on telling them about the parameters. Do all our patients have that kind of health literacy to understand every parameter ka importance? Just having create so and so, having potassium so and they just feel that okay, kal itna tha, aaj itna hua, matlab aapne treatment properly nahi kiya. They don't understand. I mean, when we talk about over information and health literacy, actually patients who are very well educated also, they do not have the complete understanding, not expected to have also. But then their expectations start building based on that. And if some doctor or some healthcare worker is not good communicative, they perceive there has been some negligence or they are trying to avoid the questions. Now, the challenge over there is ensuring the right communication goes to the patient in a simplified language which they are able to assimilate and digest. So that is a second more important challenge. And third challenge, which universally we all face, is struggling with the time of the clinicians. You know, we talk big that patient has to get engaged, patient has to be involved. So when we have this particular thing right from the engagement of a consultant, now I'm saying, I ensure that the organization's ethos is well imbibed to them. The very first criteria of mine when I ensure that I meet a new consultant who is wanting to be empaneled with us, I ensure they have good communication skill and they are wanting to communicate with the patient. At least I spell out from organization side that communication with the patient is a prerequisite before you enter in my organization. Because you can be a very good doctor, but unless you are an empathized doctor, my patient will never be satisfied with you. He or she will not understand how great clinically, skill wise you are, but they understand whether are you caring for their near and dear ones. So that communication, having time with the clinicians and convincing clinicians to pay their more time, these are the basic operational challenges what we face.
I think well said. You know, we all have this. हमने सुना होगा. You don't hear it on record. You know, पीछे होता है. ये क्यों करना है? आज तक तो ऐसे कर रहे थे और सब अच्छा चल ही रहा था. Have you heard that? That is the mindset ki if it ain't broken, why mend it? Then I think of Vijay Agarwal sir, and he said, you know, once upon a time he was in that hospital, and you know what all happened, that poor prostate thing. I was just thinking, we are still talking about patient engagement today. How many of you have heard the word chat GPT? अरे सवाल वो नहीं है, रुको. How, how many of you have heard SORA? SORA. See, SORA is something which came suddenly new, which has just come where you make videos as good as Hollywood within seconds. और एक हम लोग हैं हेल्थ केयर वाले लोग जो आज भी हिंदुजा हॉस्पिटल में बैठ के कि पेशेंट को इंगेज करना है, बहुत जरूरी है, करना है. We are doing that. A lot to learn, right? But now we spoke about resources, we spoke about time balancing. So now the next question comes to the CEO on the panel. You know, because when we talk about resources, it talks about money. So as a CEO, can you tell me, you know, how do you allocate resources? How would you allocate resources if somebody comes to tell you that, you know, we need more for a successful patient engagement initiative or a program?
Maximum people who are actually dealing with patients are people at the front line. They are the junior staff. So one of the most important thing is that is the staff that you have to ensure that there is adequate manpower over there and they are trained well. So allocation of resources is not just in head count, but it is in appropriate training also. So that is a point where, you know, if you have a counter where you need people to come and probably do their registrations and billing, how can you ease it up? how can you make it more comfortable for them, so that, and probably the touch points for people have to decrease. That is how you could maybe rationalize your resources. But at the same time, it doesn't make sense in cutting down more resources in the front line. You have to keep that optimum. At the same time, you have to constantly keep on training them. And it's not only classroom training, it's also analyzing what is the impact of the training, looking into the gaps, and training them to ascertain that the gaps are also closed. Also, at times, you may want to engage in some tools, IT tools, to ensure that you can engage patients in a better manner. Like, a patient walks to my hospital, he has to do a registration. Why should he be standing in a queue? Maybe I could just give him a QR code, something I saw in Jupiter. It was really good. You can give him a QR code, he fills it up himself, and he gets a registration number. That saves his time also. Probably a patient who is coming for admission, a planned admission, you can already, when you know a patient is coming at 6 o'clock in the evening, you could probably allocate a bed, send him an SMS that, okay, this is his bed. And then he can go directly over there, and you could do the admission formalities at the bedside. So you need to invest in technology. You need to invest in the frontline resources. And most importantly, you need to invest in the training of the resources. That is where probably many a times we lack. We do not invest enough in training. And that is somewhere that we should look into.
I think we got a very good CEO here. Big round of applause for him, because how many people actually talk of investing money. Every time we look at it, it's only cost cutting, idhar bacha lo, udhar bacha lo. Correct? It's right?
Don't pass this message to the promoters, please.
Which one, the former or the latter? Okay. No. So, audience, I just wanted to ask you a question. Today's program is a synergy between which organization? Caho, right? So now I'm going to ask my next question to Dr. Vijay Agarwal, because now see, Dr. Shilpa, Dr. Kunal, myself, we all have our biases. क्योंकि है ना, हम यहाँ कुछ भी बोल दे, this is there behind our designations, right? So हमको याद करना पड़ता है, सोचना पड़ता है. But now to Dr. Vijay, as on the other side of the spectrum, sir, we talked about accreditation. NABH came a long time ago, and so with NABH came the other famous thing, वो 5 दिन. वो 3 दिन कि जब वो है तो कर लो, है जब वो नहीं है तो मत करो. So my question to you is, what can Caho or NABH do, in such a way differently that these initiatives are not only kept for those 5 days or those 3 days?
Okay, so the first thing is to understand the day you get the accreditation is the beginning of your journey to quality and safety, not the end of your quality journey. Unfortunately, most organizations feel, well, that is the day we have now we have achieved quality. Thank you very much. And that's why it is those 5 days. And let's understand that forget about India. In a thing like Joint Commission, where you have been so actively also involved in doing that. So Joint Commission in United States is now more than probably 85 years in existence. And they spend as much in healthcare as the GDP of our country. And ladies and gentlemen, preventable medical errors are the 3rd leading cause of death in United States. Good thing in our country is that we don't have data. So you keep killing and you can feel happy about it, but we know that what is probably the real situation. It is really frightening. And therefore, what Caho understood was very clearly, exactly is what we have been talking, is to understand the limitation of accreditation alone. We have to develop a culture of safety. Unless we do that, all these SOPs, etc., everything will have no value. Now, that is a very big thing to kind of understand and to do that. That's where we realized that in our entire healthcare ecosystem, I would say I have been a clinician in the past, And I must admit that we are the biggest stumbling block for this entire adoption of the quality issues. And this stumbling block from the clinicians is again, as I said, that there has been a transformation of healthcare delivery from being an individual thing between a clinician and a patient to a multi-stakeholder delivery. And the clinician has to learn to be the captain of this ship. A quality manager cannot implement quality in cardiology, in neurology, in orthopedics, in pediatrics, and so on. It has to be the cardiologist who has to understand what are the issues. So even if I do NABH and I do it very, very seriously, ladies and gentlemen, we are only scratching the surface of quality. The main problems are the delayed diagnosis, wrong treatment. I mean, you can go on, and that's where the errors are lying. Besides whatever, nicely you may talk to the patient or you don't talk, etc. So there is a huge issue of capacity building. That's where Caho has come in. Caho has done nothing else but to bring, I would say, good hospitals, good people, accredited hospitals together so that you break your silos, collaborate with each other, reach out to the people who are not accredited. And second thing is, I think accreditation, to my mind, has done wonderful things, but it has done one thing bad. And the bad is the development of this thing that the examination paper is already out. So the thing is that, for example, if it is my emergency department, my good practices will remain good practices no matter who comes and judges me. It could be NABH, it could be Joint Commission, it could be Australian Commission. They can come and judge me. But the emphasis has moved away from good practices to just learning how do I crack this exam. And we must now shift that focus on learning good practices. And that's what Caho is now concentrating on, reaching out to every segment, whether it is nurses, doctors, engineers, housekeeping, physiotherapists, you name every segment. We are making forums, we are reaching out to them. Boss, let us develop, let us understand what are the good practices in our forum. Thank you.
I think very rightly said, sir. And this is time that all organizations and all of you here, understand this. Because, when you go on LinkedIn, you'll have organization posting proud and humbled to achieve NABH today, or proud and humbled to achieve JCI today. And as sir said, it is not the end of your journey. It is supposed to be the beginning of your journey. But what happens? It is, अब क्या है? अब hand hygiene किसका काम है? अब hand hygiene quality वाली का काम है. That is the second syndrome, the quality department's job syndrome. So I think everyone has to take back, that, accreditations can only help us a bit. And sir talked about JCI. I'm working with JCI for 17 years. And there's a reason I'm going to tell you this. I have consulted hospitals across 40 countries, about 140 organizations. The story is the same from the east to the west. And we are much better than most other countries. I can say that with pride, But still there's a long way to go. Yes, you can clap for something we have done right. But that is where now bodies like Caho, independent bodies who have nothing to do with accreditation, they can come in. Because you don't do this for accreditation, you do it because it's the right way and engage your patients. So let's come to Dr. Sushila. Dr. Sushila, can you give us an example of one a patient safety initiative, successful patient safety initiative you implemented, and what were the learnings?
Yes, thank you, sir. First of all, I would like to say that for patient safety, successful patient safety implementation, definitely support from top management is very much required. For any quality movement or quality process, top management support and staff awareness is the integral part. But don't forget to reach to the patient, because this is for patient and this is by patient. So patient safety initiatives, we should reach to the patient. Where are they? Like by all the means and ways, we should reach to the patients by doing the simple phone calls, by sending the email, by video, audio, by social medias. By all means, we should reach to the patient, especially those who are very difficult to reach to the hospital. I would like to give example of my organization where I am working. I am working in one of the community tertiary eye care academic accredited institute called as a PBMH Videsai Eye Hospital. Why I am giving example of this organization? Because I came from University Medical College Hospital and Corporate Hospital to this eye care hospital, which is a 450 bedded tertiary eye care hospital. So here patients from small vision centers, patients from rural areas where there is a population of just 1,000 or 2,000, they are coming to hospital. So how we are reaching to them? So teleophthalmology or telemedicine, teleconsultancy is one of the patient safety initiatives we took long back in our hospital. Because of these patient safety initiatives, definitely our end users or patients, those who are very poor, those who are like don't want to waste their daily wages for to just come for the checkup to the urban cities for their health checkup or eye checkup, it is very difficult to spare their daycare or daily wages. That's why we have implemented this strategy of telemedicine or teleophthalmology. We have a 38 vision centers for this tertiary eye care to hospital. We have a network of 38 vision centers which are located in rural, urban and semi-urban areas, wherein all these vision centers are having facility of teleophthalmology, optometrist, and all these vision centers, telemedicine or teleophthalmology facility is manned by the ophthalmologist who is sitting in the base hospital. So with this telemedicine or teleconsultation facility, all the patients as per their own time and their convenience, without wasting single rupee to reach to the doctor, they are availing the benefits of the eye care sitting at their own house or in their own village. And additional to that, when they are coming to the base hospital, they are getting complimentary service of surgery as well as consultation or on subsidized basis based on the their facilities available. So this is one example of patient safety initiatives which we have taken by way of teleophthalmology. They are reaching to the hospital by this modern technology. And here I would like to quote one challenge. Though we are having different high-tech technology in our hospital for patient safety initiatives, we are having cutting-edge technology. As per my knowledge, healthcare industry is driven by human resource other than machineries. So because of this, 100%, though we are a techno-savvy, we need manpower intervention at least at initial stage or in between the stage. So when manpower or man resource is there, there are chances of lapses or errors. So don't forget to measure, to map and monitor your the patient safety technology initiatives performance. So here we are mapping percentage of teleconsultation consultation done by each vision center on monthly basis, so that we are getting confidence while sitting at the base hospital that this technology is definitely reaching at mass level. So definitely monitoring is very important, though technology is there. Thank you.
Great. Audience, how are you doing? What, push ho gaya, hawa bilkul nikal gaya. Are you still there with us? Because Dr. Sushila put out a very important point on resources. Now I want to ask you a question. We have to talk about patient engagement also, na? So patient engagement needs to be done by who? You said all, right? So I'm giving you choice A, B, C, and D. And you have to give me the answer based on the question I am asking. Who is the biggest defaulter? Who is the biggest defaulter when it comes to patient engagement, or who, or lack of patient engagement? A, consultants. B, nurses. 3, other health. Are sun to lo. 3, I know there's a big that. 3, other healthcare professionals. D, I don't care, I'm waiting for lunch. So who is the biggest defaulter? A, consultant. Because जोर से बोल दो, they are not in the room. अगर if they were in the room तो बात ही कुछ और होती. Correct? So who is the biggest defaulter? So now clinicians are the biggest block. So now we ask Dr. Vijay sir to remove his hat of the Caho head, and we ask him to put on his clinician hat. Sir, as a senior physician, do you think physicians view patient engagement initiatives as a burden, more time, nuisance value type, and why?
See, the journey as a clinician, number one, first of all, understand that when we start our practice, you have to have patience to have patients. There are no patients. And at that time, you are very, very ready to spend as much time with any patient who is coming. Slowly, as the number of patients increase, your time that you are spending on that patients keep decreasing. When the number starts keep rising, it decreases further. The problem with us in the clinicians is that we have been so programmed not to share, or let us say not to delegate whatever we can, eventually to give naturally not only the best to the patient, also they are ruining their own life. So there is no life, I would say, work-life balance. I've seen people right from 8 a.m. till about 12 o'clock in the midnight, and even then they are spending very little time with a patient. Now, another problem of the community is that the more a doctor is famous, more patients he is getting, less time he is spending. They are giving him kinds of abuses, but they are going to him. Now, that's the kind of a crowd mentality or whatever. I think a lot of that needs to change. But I think, first of all, doctors need to learn to do a work-life balance, understand that we sometimes compare, like in the morning, Dr. Sujit Chatterjee was talking about comparison between lawyers and doctors. Well, you see that at the outset, they are being compared with devils. We are compared with gods. And, that's the kind of a trade-off that you have to take. It is better that you make your children lawyers to help like I did. But as long as you are a doctor, I think we have to stick to what I have bargained for. Even amongst the doctors, you see, I became a pediatrician. I may be ruining, yeah, why did I not become a cardiologist? Because my equal spending of time, I was not getting that kind of money that a cardiologist was getting. So I think that in life, you are stuck with the decisions that you make. You should make the best of those decisions. And you must create a kind of a work-life balance. Give the best to your patients, sleep nicely, and have a good life.
This was very, very insightful and little heavy also, because I was just thinking, sir, अभी ये सब जो लोग हैं, कुछ डॉक्टर हैं, कुछ एडमिनिस्ट्रेटर्स हैं, अभी अपने हॉस्पिटल में वापस जाएंगे, और जैसे इन्होंने डॉक्टरों को देखा, they'll say work life deficiency syndrome, balance syndrome. No. So point well taken. And I think some of this, as you said, not programmed to do those things. I think that cannot happen now at this time. We can just push this. This is something, you do at medical college level. But तब तक क्या करें? Now ये programmed है नहीं, balance है नहीं. Now the next question is coming to Dr. Shilpa first and then Dr. Kunal. Dr. Shilpa, you as the COO, how would you deal with an associate, who despite you having the best patient safety initiative engagement programs defined, they don't do it? So how would you deal with it? Who are resistant to this change? You will talk about the other professionals or the doctors, and Dr. Kunal talks the other one. We have two, the consultants and the others. So you talk about one, he talks about one. As leadership, how would you deal with it?
Yeah. So I'll just share one incident with you all. So one patient, a very frail aged lady with severe stenosis and a kind of inoperable case, had already a history of CABG and all. She approaches one very senior cardiologist, very well known. And so basically, first, it was clearly informed to her that the prognosis is not that great and it is an inoperable case again. Second visit, third visit, the cardiologist is so renowned that it happens, that the history taking and other mundane jobs are done by the normally typically assistant. And Ajkal WhatsApp is available. So people demand that if I need to communicate with the doctor in emergency hours, whom should and how should I communicate with? So normally in such scenarios, the assistant's number is typically given. And it so happens, one fine day, we receive a very long email with the grievances that so-and-so cardiologist we had been approaching and we were not well informed about the disease progress and prognosis. and we were not empathetically engaged or listened to. And then when I questioned, basically, when I had gone and investigated the whole scenario, prognosis was never going to get changed. The kind of fate and the disease process was never going to get altered. What basically was a crux and the important factor of the whole thing was communication, or rather the poor communication. So when we talk basically about engagement, it is a very classical example. When we learned all our medical practice, we are always told what are the do's. More important is like don'ts. So it is the same example. We are never taught in our curriculum or in our what is the communications role, or how do we engage patients more, or how do we avoid litigations. So it was a very classic example. They felt that they were actually rudely behaved with, they were not empathetically treated, they were not allowed to ask their questions, and they were not allowed to be visited by the doctors, because it was more than the doctor, it was always the assistant who was in picture. Now, irrespective of the correct course of treatment, irrespective of the predicted outcome, which was also accepted to some level by the relatives, still the court, the case had gone to the litigation level. The very reason of this was only the communication. And this is not the only exceptional thing. It is a worldwide scenario when we listen and when we hear. Nowadays, the litigations had gone 110 times more as compared to past decade. What sir was saying exactly, that the doctors, as the practice increases, they tend to spend less amount of time, but very few people understand that with every minute spent less than the required, we are actually increasing the risk of litigations. So this is one particular part. So basically nowadays it is more than me. These are the threat of litigation also is playing an important part. But yes, in our organization, I ensure again and again that communication plays important role. So in ICU, we typically, like unlike other ICUs, we have given 3 visiting hours to patient relatives. They have to come and see the patient in the morning if they want to. That 10 minutes only, where the counseling is not done. Afternoon time is a fixed time for counseling, and I ensure I randomly check that the counseling sheets are there, signed by the patient relatives. Third, most important is like whenever there is any critical clinical event has taken place, MDM is one particular thing which we religiously follow. MDM is a multidisciplinary meeting. So any patient has any doubts or any grievances or any concerns, pure clinical concerns, we ensure all the stakeholders are met with the patient's family in one forum. So sometimes it doesn't happen that only cardiologist has come and counseled, only nephrologist has come and counseled, because patient requires to understand, or the relatives require to understand the whole comprehensive scenario. They don't like to understand, okay, kidney ka ye impact hai, heart ka ye hai, liver ka ye hai. They need to understand as a person what is the collective prognosis and collective disease progress. So that is what we ensure that it is done. MDMs are religiously conducted. And I also keep a track of the clinicians who are defaulters. So I ensure that we talk to them, we ensure that their presence is required, and they do that. So I think these are the very clinically important points.
In the end, I was waiting to hear. मैं तो यही पूछ रहा था, जो नहीं follow करता उनका होता क्या है? In the end, the last 3 seconds she actually said it, but किया कुछ होता है. And क्योंकि शाहरुख खान का पिक्चर नहीं है तो कुछ कुछ होता है नहीं है. Something happens. And okay, Dr. Kunal. So this is about the consultants who are willfully default or don't follow protocols. How would you deal with them? Or how would you ensure that they fall in line?
So at my unit, we have a process wherein we used to feel that a lot of times when a patient used to come with a certain query, like he would go to the nurse, the most easiest accessible. So for any query, okay, I wanted to know about some billing query. I wanted to know about when the doctor is going to come. मेरा ये blood sample भेजा, उसका report आया. I needed assistance to go to the washroom. No one came. Everything falls upon the nurse. And any patient room in the hospital, one can dial 247. It would go to a particular counter or a particular mobile, which would be with the on-duty officer. They would talk about their query. That is the person who would address that query irrespective of the department, and they would liaison with everyone across the hospital for that. Now, in case the patient would not be able to reach out to them, then a message would go to their team automatically that such a such patient is calling upon you, and they would reach out. Again, in the morning, it would be the responsibility of the team to meet all the admitted patients and even do a recce in the OPD and meet a few patients to understand if they need any assistance or they are facing any problem. A lot of the non-compliances would be picked up from there, that who's not been helpful, who's not been compliant. In every afternoon we have a meeting of the operations head, the medical head, the nursing head, along with the billing head and certain other people who would meet, and they would discuss that, okay, these were the issues raised. Things that would not get resolved would be brought to my desk for intervention, and that is how it would function.
Great. Audience, you're still there. We can go on till evening. But, my people on the side, right hand side, are telling me that between this lovely audience and that wonderful, sumptuous lunch is this panel sitting here. So we can go on and on. But I think before I end, I just wanted one question to the audience. We have talked so much about engagement, engagement, engagement. इसको नापते कैसे हैं? And अभी नहीं, clue ऐसा है कि one of that indicator, you had a discussion this morning only. So if I have to ask you, what are some of the indicators? What is that one indicator by which you can actually measure patient engagement, whether it is working or not? And the clue is you had a session in the morning. What will be the answer? There's a surprise gift prize for someone. Joy also doesn't know. Prem, not Salman Khan, but Prem, right? Patient reported. और इसका भाई कौन है? From, और अभी और आने वाले. Anything, I think, do you think this discussion added value? What we can sum up from all of this is patient engagement is everybody's responsibility. Sometimes it's a mindset that needs to be changed. Sometimes it's a cultural change, but we will do it. Thank you. Thank you to all the panelists.
Thank you, Dr. Clive. Thank you, panelists. Very interesting session, and I know the audience is definitely awake, even if it's a pre-lunch session. Dr. Clive, I just request you to just give a memento to the panelists. Yes. First, Dr. Kunal. The book also. Thank you. Next, Dr. Shilpa. Dr. Sushila. And Dr. Agarwal.
भाई सर इज सेइंग कि नहीं मजा आ रहा है नहीं मजा put it back, huh?
And I request Dr. Avinash Supaya, Director Clinical Governance, to present a memento to Dr. Clive. Thank you. Panelists, moderator, I request one group photo, please.
आ जाइए मतलब आप सब खाना खा के आ गए मार्केट में खबर है ऐसे आप बेरोजगार करने के लिए गया है मार्केट में खबर है कि आप टेस्टिंग करने गए थे वो बराबर है
Thank you, panelists. Thank you, audience. We can break for lunch and we'll meet about 2:20. We'll start the next session.
मैं वापस एंगेजमेंट पे नहीं आ सकता हूँ मैं वापस बिठाना पड़ेगा और बड़ा नाइस था आपकी भाई भाई कैसे हो सकता है और जिला वगैरह वो लंच ब्रेक वाला कर दो
अभी सुनो
पैर पीछे करना है लैंप आ गया जेवण नाही ना माहिती सांगा मी जेवण आहे माझं त्याचं झालं दुपारनं संध्याकाळी येणार 5-6 वाजता 5:30 नंतर हा मी जेवून घेतो हा बरोबर थँक्यू थँक्यू हा तीन लोग मुझे सामने चाहिए ये दोनों कॉर्नर में करके मैडम ने बोला तीनों चले बस हाँ ये है ना इधर ही इधर ओनली बाहर अंदर अच्छा लगता है ना
No, you don't need to be hospitalized immediately. चलो बेटा घर चलते हैं।
पापा, डॉक्टर अंकल, आप 20 साल से पापा का ट्रीटमेंट कर रहे हैं। आप यहीं पे कुछ ट्रीटमेंट दे दीजिए ना।
बेटा ट्रीट तो कर रहा हूँ, लेकिन अब इनका ट्रीटमेंट क्लिनिक में पॉसिबल नहीं। हॉस्पिटल में एडमिट करना बहुत जरूरी है।
Hello, check, check. Hello, check. Hello, check, check. Check. Hello, 1, 2, 3. Hello, check. Hello, check, check. Check. Hello, check. रहेगा। Check. Hello.
You needs to be hospitalized immediately. चलो बेटा घर चलते हैं।
पापा, डॉक्टर अंकल,
तुम अंदर से 2 4 पानी का बोतल लाके दूध दे दो नहीं लगाना तो अच्छा होगा ये भी रख दो आधी दो रखो से और पानी का बोतल अभी नहीं 2 रखो बाकी उधर ही होगा अभी भी चाहिए लगाते हैं दबा दो और दबा दो हाँ हाँ वो देना पड़ेगा हाँ वेरी गुड यूज उधर उनको ना
वो बोलते इतने हम नहीं गए मैं पण तो किती बोलला माहिती आहे
देवदास जी कैसे हैं
बस बढ़िया सर
फिर से ये सेट हटाना पड़ेगा whatever you want you are here only na tell them what you want we will do immediately we will do इधर का इधर है नहीं जाने वाला उधर ही करना उसका नंबर देना तुम लोग तुम जाना मत बेटा कहीं इधर दूसरा बंदा और कौन है
एक चांगलं मल्टीपल मग काय लावायचं त्यांना नाही तुमचे काय लागलं कुठले आम्ही काल त्यांची वाढ ही स्क्रीन पण नव्हती चेक करा पण काय माहिती यांना सेपरेट पॉवर पाहिजे म्हणून मी याला राहुलला बोलले इंजिनिअरिंग वाल्याला बोलवतो आपण कशाला जबाबदारी पण तोपर्यंत लावून झालं दो लोग आए थे उन्होंने हमको सब बोला हाँ कुछ नहीं प्रॉब्लम होगा चलेंगे अरे ते हे वाले हे आणलं ना ते बोलले दोघी इंजिनिअरिंगचे पाहिजे होते ना हाँ प्रवीण बोलते हाँ व्यवस्थित आहे तू बरं आहे लावून नाही लावून नाही ते खाणं फार 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 नाही ठेवतोय
बेटा महेंद्र needs to be hospitalized immediately. चलो बेटा घर चलते हैं।
पापा
बेटा महेंद्र needs to be hospitalized immediately. चलो बेटा घर चलते हैं।
पापा डॉक्टर अंकल आप 20 साल से पापा का ट्रीटमेंट कर रहे हैं, आप यहीं पे कुछ ट्रीटमेंट दे दीजिए ना।
बेटा ट्रीट तो कर रहा हूँ, लेकिन अब इनका ट्रीटमेंट क्लिनिक में पॉसिबल नहीं है। इन्हें हॉस्पिटल में एडमिट करना बहुत जरूरी है। महेश भाई हॉस्पिटल से क्या प्रॉब्लम है? डॉक्टर हॉस्पिटल से डर लगता है।
आजकल हॉस्पिटल्स के बारे में कैसी कैसी बातें सुनने को मिलती है।
देखो बेटा तुम एक काम करो, महेश भाई को हिंदुजा हॉस्पिटल ले जाओ। दे हैव द बेस्ट ऑफ डॉक्टर्स केयर एंड बेस्ट ऑफ मेडिकल इंफ्रास्ट्रक्चर इन द कंट्री। महेश भाई चिंता मत करो, जरूरत पड़ने पर मैं भी अपनी फैमिली को हिंदुजा हॉस्पिटल ही लेके जाता हूँ। वहां के डॉक्टर्स वही करते हैं जो पेशेंट्स के लिए सही है। अब तो ठीक है ना महेश भाई? बेटा महेंद्र needs to be hospitalized immediately. चलो बेटा घर चलते हैं।
पापा डॉक्टर अंकल आप 20 साल से पापा का ट्रीटमेंट कर रहे हैं, आप यहीं पे कुछ ट्रीटमेंट दे दीजिए ना।
बेटा ट्रीट तो कर रहा हूँ, लेकिन अब इनका ट्रीटमेंट क्लिनिक में पॉसिबल नहीं है। इन्हें हॉस्पिटल में एडमिट करना बहुत जरूरी है। महेश भाई, हॉस्पिटल से क्या प्रॉब्लम है? डॉक्टर हॉस्पिटल से डर लगता है।
आजकल हॉस्पिटल्स के बारे में कैसी कैसी बातें सुनने को मिलती है।
देखो बेटा, तुम एक काम करो, महेश भाई को हिंदुजा हॉस्पिटल ले जाओ। दे हैव द बेस्ट ऑफ डॉक्टर्स केयर एंड बेस्ट ऑफ मेडिकल इंफ्रास्ट्रक्चर इन द कंट्री। महेश भाई चिंता मत करो, जरूरत पड़ने पर मैं भी अपनी फैमिली को हिंदुजा हॉस्पिटल ही लेके जाता हूँ। वहाँ के डॉक्टर्स वही करते हैं जो पेशेंट्स के लिए सही है। अब तो ठीक है ना? बेटा, my boy needs to be hospitalized immediately. चलो बेटा, घर चलते हैं।
पापा, डॉक्टर अंकल, आप 20 साल से पापा का ट्रीटमेंट कर रहे हैं। आप यहीं पे कुछ ट्रीटमेंट दे दीजिए ना।
बेटा ट्रीट तो कर रहा हूँ, लेकिन अब इनका ट्रीटमेंट क्लिनिक में पॉसिबल नहीं है। इन्हें हॉस्पिटल में एडमिट करना बहुत जरूरी है। महेश भाई, हॉस्पिटल से क्या प्रॉब्लम है? डॉक्टर हॉस्पिटल से डर लगता है।
आजकल हॉस्पिटल्स के बारे में कैसी कैसी बातें सुनने को मिलती है।
देखो बेटा, तुम एक काम करो, महेश भाई को हिंदुजा हॉस्पिटल ले जाओ। दे हैव द बेस्ट ऑफ डॉक्टर्स केयर एंड बेस्ट ऑफ
हे संजीव। अश्विन, हाय। कैसा है यार? मैं एकदम ठीक हूँ यार, लेकिन तू यहाँ कैसे? तूने तो नहीं हॉस्पिटल ज्वाइन कर ली थी। डोंट टेल मी तूने वहां से छोड़ के फिर से यहाँ ज्वाइन। अरे नहीं नहीं यार, उसकी बात नहीं है। आई जस्ट केम हियर टू गेट डैड एडमिटेड। क्या हो गया अंकल को? यार कैंसर डिटेक्ट हुआ है। बट देन व्हाई नॉट योर न्यू हॉस्पिटल? अब हाँ, मतलब मैं काम दूसरे हॉस्पिटल में करता हूँ, बट डैड के जैसे कॉम्प्लेक्स केस के लिए मुझे सिर्फ हिंदुजा हॉस्पिटल पे ही भरोसा है।
Good afternoon, everyone. We'll start our post-lunch session. I hope you all enjoyed our lunch. Yes. All right. To start off, we'll have the auspicious lamp lighting ceremony. For the lamp lighting, I call upon our CEO, Mr. Gautam Khanna, Dr. Vijay Agarwal, President Caho, Mr. George Chakravarti, our CEO. I also request the Caho office bearers, Dr. Sushila, Dr. Aparna Jairam, Dr. Suvin Shetty, Nishant Jaiswal. Please join. Dr. Chakravarti, sorry. Thank you. For all our programs that we conduct with Caho, we always have the Caho anthem which we play. Rahul? Caho anthem.
Horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
And in step by step, we will try
To mark ahead together, a bright and shining future in patient safety and quality healthcare. We are AHO Caho, your healthcare companion, standing by your side. Joining hands for building a vision, shaping a culture for patient safety.
setting up to forward. Strong.
We never pride on our sleeves, protecting like a breeze, screen people enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation. Have a goal, safety and quality healthcare. We are AHO Caho, your healthcare companion, standing right by your side.
Thank you. Next, I call upon Dr. Sushila Kaude, Maharashtra State Chairperson, to give a presentation.
Thank you once again. So on behalf of Caho, family, I am giving some brief about the Caho Con. As you know, 8th edition of the Caho Con is will be going to conduct in the state of Kolkata, West Bengal. It is actually Caho Con is nothing but internationally recognized conclave supported by esteemed entities such as International Society of Quality, Asian Society of Quality, and Quality Council of India. So Caho Con is nothing but a gathering of elite healthcare leaders, professionals, researchers, educators united in their goal to advance healthcare quality and delivery it is nothing but a quality festival of India. So this year, theme of the CAHOCON is making healthcare efficient, effective, economical, and equitable. So we have a two part of CAHOCON. CAHOCON for the hospital industries and CAHO LabCon is for the diagnostic professionals, which will be going to conduct on 4th, 5th, and 6th of April. So in the CAHOCON, we have a pre-conference on 5th of April, which will be having different important need-based topics, which going to covered in the pre-conference in city of Kolkata. So in CAHOCON, I would like to register you in the group wherein you will get a benefit of group discount. If 5 to 10 delegates are going to register for this CAHOCON, there will be 10% discount on the registration fees. And if it is more than 10 delegates, there will be 20% discount on the registrations. So definitely this event will be very exciting. Along with the sessions and various knowledgeful lectures, there will be some competition awards. So there are few competitions which we are going to held in the CAHOCON. So I am requesting all of your participation and applications for various awards. First award is about this paper presentation. So this paper presentation competition award will be for different categories: clinical, nursing, general, and support services. So kindly apply for this award if you have a very good paper. Then next award for CAHOCON is for best research publication in quality. If you have any best publications in national and international journal, please do apply for this award. Then we have a next award like best clinical audits. As you know, clinical audits, since first, I would say, standard of NABH, we are doing various audits in the field of nursing, in the field of clinical. Kindly apply for this best clinical audit award. Definitely it will be a confidence building session for you. Then first National and Patient Advisory Council award will be new award we have introduced this year. If you have a patient advisory council in your hospital, this is forum to present yourself in the form of award. Then next award is for the Young Quality Achiever. Every year from the country, CAHO is recognizing eminent quality leaders below age of 45. So Young Quality Award is for the below 45, and above 45, if you have outstanding work in the field of quality in your individual level, please do apply for the Quality Champion Awards also. So these are the link given here with to get the further information. So again, apart from this competitive award at hospital level, at institutional level, we have introduced some additional award this year, which is on environmental sustainability award for the hospital. If you have very good green initiatives present in your hospital, please apply for this award and recognize yourself in the international forum. Then Fire and Life Safety Excellence Award for the hospital. Again, this is new award we have introduced this year in the CAHOCON Kolkata. So please do apply for this award. So again, CAHOCON 2024 will be in Kolkata on 5th, 6th, and 7th of April. These are the link for registration and for the various competitive awards at individual level as well as for the organizational level. So, my dear friends, we are eagerly waiting to meet you in Kolkata. Thank you. Now Yes, thank you, sir. So now I request my respected Agrawal sir to give his remark and comment. Thank you, sir.
So, ladies and gentlemen, what I would like to say is that everybody who has registered for this particular event today is entitled for a 20% discount, no matter whether it is less than 5, 10 or whatever. Individually, everybody will be entitled for a 20% discount for all those people who are registered for this conference. So all those people who are interested in attending, maybe that they can give their names and email to phone number, email and name to the person at the front desk or something. Our people will get in touch with you and enroll you. So thank you very much, and we look forward to meeting you in Kolkata. And it is also applicable to the LabCon, and LabCon has a pre-conference on 4th of April also. So 4th and 5th is for the people who are in the diagnostic center area, and the 5th and 6th and 7th for the institutional or the Caho Con. And there are people who would like to attend all of them. So please be there from 4th, 5th, 6th, 7th. Thank you very much.
Thank you, Dr. Vijay. Next, I'd like to call Dr. Vijay, Caho President, on the dais. Mr. Gautam Khanna, our CEO. Mr. Joy Chakravarti, our CEO, and West Zone Head. I request Dr. Vijay Agarwal to say a few words.
So, good afternoon, friends, and dear friend Gautam Khanna ji and Joy. Today is again another red letter day for Caho, where we are going to make Hinduja Hospital as a center for quality promotion. Now, I'm here to talk to you about what is it? What is this Center for Quality Promotion? So friends, our organization, we started in the year 2013. In fact, in the second national conclave of NABH, the idea of this organization coming up was to bring the accredited hospitals together on a platform to help them their continuous quality journey improvement. So we have, in fact, completed 10 years of our existence. But very soon we realized that just merely promoting accreditation is really not going to help us in promoting patient safety. And that's where the whole vision of Caho kept on enlarging. And today we have 3 vertical wings that we call as the Caho institutions, the diagnostic centers, and the quality professionals. So slowly and gradually, this organization has become a melting pot for almost everybody whosoever is interested in promoting patient safety and quality. Our journey's first milestone started with a question that we had to become relevant to the healthcare institutions. We started with just about 6 or 7 hospitals who were my active members. Today, if I include all the hospitals alone, more than 400 hospitals are our active members. More than 2,000 people are our active individual members. About 100 or so diagnostic centers are our members. So the first thing that we realized that the accreditation bodies, especially NABH for us, have an army of people whom they call as assessors. And they come to the hospitals, they find out what the problems are, they will tell you what has not gone right. But we realized that there are no kind of people whom I can call as quality implementers. So we started a program it started in collaboration with the Quality Council of India. And that was a basic program to align with the entry-level standards and an advanced program to align with the advanced level of the NABH standards. That is the certified professionals for quality implementation, basic and advanced. Now we started these programs became extremely, I would say, successful. There is no mandate was no mandate on anybody to attend these programs. But we started having a lot of requests for these programs, both for basic program and an advanced program. In those programs, I also made an observation. Just like we are saying that the hospitals, the day you get the accreditation is the beginning of your quality journey. Same thing I started selling the quality people, the professional, certified professionals, was this is the beginning of your becoming a quality implementer. This is not the end of your becoming a quality implementer. For the first time in these programs, if we had 100 people participating, 1/3 of them were doctors. 1/3 of them have been nurses, and 1/3 of them were administrators and other field people. So for the first time, it was truly a kind of a melting pot. And then what we realized that I'm telling them that you need to continue to evolve yourself. So we started having number of webinars so that they can attend these webinars and enrich themselves. We started calling a number of, I will say, experts from the country, outside the country. You will be glad to know that there is an organization, ISQA. Now, ISQA is the body which does the accreditation of the accreditation bodies like NABH, Joint Commission, Australian Commission. And in association with ISQA, Caho started an international webinar series on the issue of patient safety. And now it is more than 3 years that we have been holding these programs on every first Tuesday of the month at 5 p.m. Now, more than 25 countries people are attending this program on every first Tuesday. Caho has started to make its impact in international arenas like in ISQA and ESQA. Slowly, we realized that we have a larger mandate. Mandate is to reach out to every segment of the hospital. So we started creating various forums like the Engineers Forum. We are now having the forum for the rehabilitation workers and so on. We were looking at every opportunity as to how do we spread this whole concepts of patient safety and quality that we have been nurturing. And that's where, in fact, one of our friends from Bangalore, Dr. Samina Zamidar, we had interaction more than 6-7 years back. She's had started something in her hospital, like she was inviting people from nearby other hospitals to give them a kind of a training on best ophthalmology practices. And that's where we started. We said, I think that's a fantastic idea. Let's make people, let's recognize hospitals as centers for quality promotion. So the whole concept of center quality promotion, it came, the first hospital was the Kalyani Kidney Center in Erode. And right from a small hospital like Kalyani Kidney Center to CMC Vellore to Ganga Hospital in Coimbatore to Bombay Hospital in Bombay, many, many hospitals have become our centers for quality promotion. And this will be our 34th hospital. The whole concept of this was that this hospital, any hospital can become a center for quality promotion, should be already an accredited or a certified hospital. They should have people who are our certified quality professionals in sufficient numbers. And they should be ready to promote patient safety and quality outside their own hospital by inviting nearby small hospitals, going into their various departments. Each of these hospitals mostly have been doing excellent work within their organization. But the change that Caho has been trying to bring is that please break your silos, get out, and let us try to reach out to all the people around small hospitals if we want to make a change in the healthcare delivery ecosystem. We have to rebuild the trust that the profession has, I think, lost, or at least it has eroded between the community and us. And I think all of us have to be determined to rebuild that trust. And I think this Center for Quality Promotion is one such activity which will go a long way. And I am very excited that this beginning of somebody like Hinduja Hospital now becoming a center for quality promotion will inspire many more hospitals in Mumbai and in Maharashtra. And here we believe that more the people are there, it is becoming a one large family. And probably I'm letting the cat out of the bag. I'm going to request Joy Chakravarti and this thing to start. In fact, we'll make him chair this group of the Centers for Quality Promotion to bring about a structured approach to our approach so that we can take maximum use of this particular initiative. So Ladies and gentlemen, thank you very much.
I call upon Mr. Joy Chakravarti to say a few words.
Thank you, Dr. Agarwal and Caho. So now I'm standing here as a part of Caho, as a regional chair, as well as the CEO of Hinduja Hospital. But it is a gratitude from our side, from Hinduja Hospital side to Caho for giving this recognition today. Dr. Agarwal has mentioned about 34th hospital, but in this region, this is the second hospital. I heard about this and you are thinking about or contemplating on this for probably last 2.5 years. But I personally thought that we should give a pause and really need to showcase some of the real quality activities, endeavor, and our strength. So I'll talk a little bit about the history in terms of the quality journey of this hospital, and those who are from non-Hinduja, you should be aware about some of the steps what were taken by our predecessors. We are the first hospital in 96 who has gone for ISO from amongst the hospitals in this country, and that time there was no JCI, no NABH, there was nothing. 10 years later, in 2006, the hospital lab embarked into College of American Pathologists accreditation. And amongst the SAARC countries, this was the first hospital lab who happened to get it. And we are continuing with that even today after many cycles. 2009, we got our hospital NABH. In 2006 onwards, it started, but we took a step and we embarked into in 2008 and 2009 March. We got the first time NABH accreditation, and that was also second in terms of in Mumbai. The first was Hiranandani Hospital, as I mentioned in the morning. And subsequently, we continue to maintain the team, continue to work towards this. And that has become possible with the strong team and commitment towards the quality. I'll talk about some of the people who are present here in this room little later part. But what else we have done after that NABH accreditation is our hospital information security that has undergone ISO, which has not been done in many cases. Again, the hospital, as because we have our internal kitchen and we have not outsourced, we felt that we need to ensure quality. So like any five-star hotel, the hospital has got into that, and in 2011, we got HACCP accreditation for the food safety. Subsequently, whether it is green hospital, green operating room, all these journeys were taken. The hospital pharmacy have gone for the pharmacy accreditation. Subsequently, we have also gone and taken some of the quality initiatives like Lean Six Sigma. I forgot to mention the Six Sigma initiative in this hospital started way back in 2006. Maybe after that there was little lull, and subsequently in 2016 again we took it up and we started getting into it. We have done several quality circle projects where we have got people from the junior cadres to come and give solution for the problems what has been identified by the patients. I may forget one or two, pardon me for that, but our commitment continue to remain on all this. And as recent as 2 weeks back, probably we are the first hospital in Bombay. We have gone for NABH digital accreditation inspection, and we have got the inspection is over. We are going to close the NCs, and as you know, in any case, you have to get some of the NCs. Apart from that, NABL in the lab and many other accreditation has been taken up in this hospital. I think I didn't mention about 5S. The hospital has embarked into 5S, and we got a very good score in terms of getting into the 5S platform in just 2-3 years. So all this have become possible, and there is a strong team, as I have mentioned before. They have worked, and now I want to call some of them, and I want to recognize their endeavor, for which we are going to get this Center for Quality Promotion, the kind of certification. So Dr. Preeti, Assistant Director, Quality Accreditation, Clinical Accreditation. Then I will call, this is not in terms of the hierarchy, the hardcore quality team. I'm going to call Jinsi. She is as an executive in the quality team. Arindam is sitting at the back. He leads our, 5S, Six Sigma, all these initiatives, business excellence. I think you can come in the front. Yeah. So then we have Dr. Deepak, one of the backbones, I must say, in multiple initiatives from pharmacy. He is a clinical pharmacist and contributes immensely in this endeavor. None of these things can be done without the support of, nursing. So we have Dr. Meenu Jain here. She is Assistant Director Nursing. She is an integral part of it. And we have Dr. Sapnil Kharnare, Assistant Director Administration. Bhavisha, Assistant Director IP Services and all. Did I miss out anybody who is getting? So, anyone I have missed out? Okay. So now this is only the phase, but we have a 18, 19 members core team, which is doing these activities throughout the year. So now today what you are getting, Dr. Agarwal has mentioned about certified quality professional. So there was a program. So I think these five, Dr. Preeti, Arindam, Dr. Meenu, Sapnil and Bhavisha, they underwent this 5 days program, and they have been certified, and that has become one of the criteria to get this Center for Quality Promotion. So thank you for all your contribution. And the purpose why I have called 5 of you here, others can recognize and then they can ask help from you. So you can't now run away. You have to commit yourself for this. So with this, I request all of you to, yeah. So as I have told that quality and our hospital vision remains quality healthcare for all, we are going to remain committed. And I'm sure in coming days, we'll continue to do more, and definitely all of you can join us, and all of us, like a symbiotic relationship, create an ecosystem where everybody gets benefited out of each other's help. Thank you very much.
Thank you, Mr. Joy. I now ask the Caho leadership, Dr. Vijay Agarwal, President Caho, to present the recognition for Center for Quality Promotion to our Hinduja Hospital leadership, Mr. Gautam Khanna and Mr. Joy Chakravarti. Caho office bearers, please do join us on stage. Thank you. Mr. Khanna, I now request you to say a few words.
Thank you, Preeti. And firstly, thank you, Dr. Agarwal, all the Caho team for giving us this honor. And as Joy mentioned,
that this quality journey in our hospital has been there for a long, long time. And I'm happy to say that it has now become a part of our lives of many people. And that is probably what I think Dr. Agarwal and team have considered while giving us this honor to be the center for quality promotion. And Dr. Agarwal, I can assure you that the team here is really committed. It is not, it's not only for the audit purposes that the team undertakes quality initiative. It is taken, it is measured, it is reported every month. And the leadership team actually looks at the initiatives and it is, discussed and changed. So I can assure you that this is done. But thank you for the honor and also Joy, Preeti, and the team today who have organized this. Thank you for organizing this, and I am sure many people have learned from the discussion and will probably benefit from discussions with each other. So thank you, and we hope to keep your faith in us. Right. Thank you.
Thank you, Dr. Agarwal, Mr. Joy, Mr. Khanna. Next, I call upon Swapnil to take on the next panel.
Good evening, ladies and gentlemen. We all know with the rise of this smart patients across the globe, our hospital also now needs to become smarter. Our patients are expecting now smarter solutions for leading them into a seamless process and systems during their care delivery. So what is this smart hospital? What exactly symbolizes this smart hospital? Is it remote monitoring? Is it AI? Is it predictive analytics? Is it energy efficiency and sustainability? So there's so much of learning, unlearning, and relearning that's on the platter today for the next session. The next session, panel discussion, is on smart hospitals, the future of healthcare. And now I request the panel to come on the dais. So I'll request our moderator for the session, Dr. Suvin Shetty, to please come on the stage. Mr. Gautam Khanna. Dr. Rajkumar Patil. Dr. Aparna Jairam. And Mr. Rahil Shah. Dr. Suvin Shetty, our moderator for the session, is the head of lab medicine, Dr. L.H. Hiranandani Hospital, Powai, and also the vice chairman, Caho Quality Professionals. I request Dr. Suvin to take this forward from here.
Yeah, thanks, Swapnil. I'll introduce in very brief my panelists, the team that is there. We have our, next to me is Mr. Gautam Khanna. He's the host for the day, actually. So he's the Chief Executive Officer for PD Hinduja Hospital and Medical Research Center. I have Dr. Rajkumar Patil, sir, who's the Director of Medical Services, Bombay Hospital, as well as the Chairperson for the Central Zone of Caho. We have Dr. Aparna Jairam. She is the Secretary, Caho Diagnostic Division, as well as proprietor for a chain of laboratories called Asavli, Dr. Aparna's Path Labs. And we have Mr. Rahil Shah, who's the Director of NM Medical Center. And it's a center which has a multiple chain of labs, as well as a diagnostic setup. So, well, the topic for the afternoon, in fact, possibly this is the last session for the day, and we'll have we'll be breaking off after concluding the session after this. So bear with us. I will not take much of your time. I'm sure you'll be enriched by some of the thought process from the four healthcare leaders that we have on the dais today. I've set a few questions for them. And before that, the topic for the session was smart hospitals. Smart hospitals, in fact, if you go through the various literature, the smart hospital definition, if you want to go on to particular concept or particular thought, you'd like to see what exactly it means, what is the definition. So there were, in fact, in the literature, not much is mentioned as a definition, though lots of conceptual thoughts are given to that. And over a period of time, there has been evolution of the old thought of having a smart hospital or smart healthcare. It started off as a digital concept. The some couple of decades back, it was thought that if you digitize the medical records, it is some sort of a intelligent kind of a way of dealing with the in a healthcare profession. From that digital, we have moved on to something called as smart hospitals. What does smart hospital mean? What is different between digital and smart is only the fact that apart from being digitized, the information being digitized, we are also talking about smart devices or smart technology, which is incorporated so as to make the ultimate goal of improving the process of patient treatment. The final goal is the improving the patient treatment. So ultimate goal is that, and what we use is that various technologies to improve on that. So with that thought process, I would like to move on to the first question to Gautam sir. Smart hospitals. As I was talking, there is an evolution. The concept of smart hospital is possibly piecemeal in various way. Can we say that we have reached that stage where we may have smart hospitals in near future, or right now we are having? Because you may have various modules in the hospital, in say X hospital having certain aspect, Y hospital having certain other more aspect. Can we but qualify ourselves to have a smart hospital in place?
So thank you, Dr. Suvan, for asking me this question. But the frank answer is that I don't think any hospital in the country today is smart. In that, from the digital point of view, I'm smart in other ways. But so it is not about implementation of software. It is not about having lots of computers. It's not about having that. In my view, smart is what I think 5 years later, 3 years later, or 10 years later, I don't know what time frame, will be when, firstly, when we will have all the information in your IT servers and to be stored, to be available to the decision makers, whether it is a clinician for clinical decision making, or whether it is the administrative staff or research staff or whatever, to be available for decision making, and you can make decisions in real time. You can monitor patients in person or remotely, and you can deliver digital healthcare services irrespective of the location. And then also maybe incorporate a little bit of predictive analytics there and say that this is what it is going to be. So can I give the treatment now? So if you think of the whole continuum, that will probably be a smart hospital. And that smart hospital, I think it will need a lot of investment in terms of IT. Plus, the bigger investment will be in terms of mindset of people and changing the processes, changing the way people do things. So I think we are a little far away from smart hospitals.
In fact, sir, just to add to an anecdote to what you're referring to, some few years back, 2009, if I'm not mistaken, I was representing the hospital for a Asian Society of Quality. I presented some small, really possibly silly paper there. But I was what touched me during that particular event conclave was a lot of big delegates from Taiwan, quite a few delegates from Korea happened to be part of that conclave, and they were presenting a lot of hospital data. Obviously, on inquiry and looking at their presentation, most of their data at that particular point in time was digitized. So they had already got their EHR and EMRs in place. All the presentation was elaborate. It was wonderful to see their presentation vis-a-vis some of our Indian presentations. But obviously, the mute point was they had digitized information and data at hand, and they could use that to present their research work in such a conference. Moving on to Rajkumar, sir. What would be your considered opinion? I mean, Gautam sir was very frank in putting up across his opinion on smart hospitals, whether they are there or not there. So, but what is your considered opinion? Why we probably lack, if at all we are lacking, going towards the smart hospitals?
Thank you, Dr. Suveen, for this question. At the outset, I would like to thank Mr. Joy Chakravarti for inviting me here, Caho for giving me this opportunity. Of course, I am sharing the dais with Mr. Gautam Khanna and Dr. Aparna and Dr. Rahil. It's a great opportunity to be speaking here. And I very much agree with what Mr. Gautam Khanna has said, that we are far from smart hospitals. But, the positive side of it is that we have started talking about smart hospitals. Maybe 5 years down the line, the Caho and NABH may certify that certain hospitals are smart hospitals with, having some criteria laid down, explicit criteria, because just now the digital standards have been released, and a lot of digital infrastructure is required. We need to rebuild our digital infrastructure to comply with those digital standards. And now we are talking about smart hospitals. Smart would be, as per the definition given by the Ministry of Health and Family Welfare, anything which enhances the patient safety, improves the quality, and improves the outcome, and of course reduces the cost. So for 4 criteria they have given. And SMART is for, S stands for specific, M stands for measurable, A stands for action oriented, R stands for real time, and T stands for time bound. So smart hospitals, that is. So what does the this one definition imply? That we want the hospitals to be, paperless, then the chart should, we should not have any charts, that is chartless, paperless, chartless, and then totally digitized, we want the hospitals. So we, we can embark on this journey, but we are still far from being smart. We must be in the process of, I can say, in the evolution. Some are ahead, some are still, learning how to become smart. So that is the actually realistic picture of today. So I think I have answered you.
Yeah, thanks, sir. Thanks. In fact, giving that idea to Caho, there's some, when I was doing some research, there's something called as digital maturity staging. You can actually use that staging to find out where the hospital stands in terms of digital maturity. Stage 0 to stage 7. 7 being paperless, and stage 0 means without much input into that.
Yes.
Thank you, sir. In fact, moving on to, before I move on to Dr. Appan, I'll go on to the Rail. The ladies will take the end. So, Rail, smart labs. Let's move to lab side now. Is it time to break the traditional mold of how clinical labs operate? I mean, we know how it operates, isn't it? So, is it time to do that, or is the evolution towards smart technology possible or plausible? Or is it already there in clinical labs as such?
Thank you, Suveen. Good afternoon, everyone. It's a pleasure to be here, and thank you for inviting me. I would argue that in laboratories, this movement towards smart adoption is actually at a little more advanced stage than it would be, let's say, at a pan-hospital stage. With the level of automation that has now come into play in both hardware and software in today's modern lab, the traditional processes in the age-old laboratories are undergoing a rapid shift. Whether we look at, accessioning the sample, receiving the samples in the lab, loading them onto machines, transporting them across the lab, centrifuging them, storing them, releasing results, running repeats, all of these steps can now be fully automated with no touch or no human involvement. And really all it takes is a willingness to engage with vendors to build appropriate hardware and software config in your lab and having space to implement them. what that does when you automate a lot of these tasks that were previously performed manually by technicians and doctors, it frees up their time to really focus on value adding activities. They can spend more time on abnormal results. They can spend much more time discussing interesting cases with the referring clinician. They can invest in training and education for the internal stakeholders in the lab. They can introduce new assays into the lab. They can invest in soft skills training, something which is very important in our healthcare environment in which we operate today. More time can be spent on upskilling in the soft skills and interaction with doctors and clients. And they can take on some financial responsibilities like inventory control. All of this is only possible because technology is enabling them to free up their time on these value adding activities. The adoption of this technology also allows us, Dr. Rajkumar spoke about paperless, but in our lab today, we are completely paperless. So in the laboratory, it's a little bit easier to adopt that mantra. It's very efficient, but it's also environmentally responsible. And I would argue that labs that don't get onto this bandwagon today, that the time is right, cost is just about getting to a manageable level. If the traditional labs don't adapt this into their practice, at some point they're going to be saddled with unmanageable costs. We are always in an inflationary cost environment with patient prices not increasing. If anything, they're going down. So there will be significant cost inefficiencies. They will struggle to control turnaround time and maintain consistency across the board for quality and turnaround. And they will struggle to scale beyond a certain level. You will eventually hit a ceiling beyond which the lab cannot handle more samples, even if the analyzers are capable of running more samples.
Rahul, isn't your marine line setup a total lab automated, isn't it?
That's correct.
Yeah.
But, there are varying levels of automation that a lab can adopt.
Yeah.
And even starting small and then scaling up allows you to bring in tremendous additional efficiency in the lab.
Absolutely. Congrats to that.
Thank
in the first place. Yeah. Moving on to Dr. Aparna. Rahul touched upon few pointers, where towards automation. Can you possibly give some specific examples of technological features that can be used in lab automation to improve processes as such?
I think I second all the panelists who have thanked everybody. So accept my thanks also. And I want to say that I completely agree with what he said. In fact, one of my setups where we did NABH for the lab, we did a complete paperless thing, but that was one spectrum. But giving you an example, we inaugurated one of our setups in Malegaon, a small city, comparatively very famous for onions, most of us know. So we acquired a setup which is around 95 walk-in
In
patients.
fact, Aparna, sorry to interrupt you. I want to qualify here. Compared to Ryle has a fully matured, setup in a metropolitan, whereas Aparna actually has centers in various tier 2, tier 3 towns, so the reality would be something very different from what we possibly are talking about here.
Thank you for getting that on table. Because on the other side of the spectrum, where I have been like Rahil, managing 18 years into a big corporate lab, and now I am in Malegaon, where I have never traveled before, and I acquire and I put my board and I cut the ribbon, and before doing that, when you are doing the due diligences, Suvin, even a basic thing like a software, is I'll not call it, it's a delicacy to get a good software, because cost, as I said, is a big constraint. And simple things like glyco-HB, a patient coming, okay, this is my glyco-HB, acha, what is your past one? So even basic things, I mean, my staff finds it very, very good that when I introduce this new software, which has got an algorithm of what was the past 3 readings of the patients. So for you all, or we all sitting here, it looks like given, but most of the part of our city or our country rather, where we are starting our labs, I think the automation can start with a basic thing like automated digital receipts. Even today, believe me, wherever we have around 37 setups, where WhatsApp is still done manually. Can you believe it? It's very difficult, but even that automation would be a welcome automation. And as he said, it will optimize the manpower, it will optimize, the time, the turnaround time, everything. So even a basic pH sorry for getting too much technical, linking that to an LI system can free up so much of your pressure and stress. So I think it can start with basic software.
Thanks, Dr. Aparna. Moving on to next set of questions, over to Gautam, sir. I'm sure Hinduja has quite a few technical inputs that they have put up. There are smart devices. I can see some of them where, in fact, when we enter the complex itself, you could make out. So how do you address issues of technology interoperability and such technical challenges? I'm talking very technical now. How do you, as a leader in the hospital, how do you address those? Because we ourselves see in our own setup, when something new comes up, some new software, there are challenges. There are quite a few stakeholders. How do you address that as a leader, sir?
So one of the things which you mentioned is that the journey in the country, which has started towards digitization and, is that everyone has a new software and everyone wants to tell you that that's the best software for you. And if you take it, magic will happen and the hospital becomes smart. And then you put that and then you find the neighboring software is better. And the third one doesn't work with the first one. So all those things are there. So the easy thing to do. So first I'll tell you in the lighter vein, what's the easy thing to do? Being the CEO, easy thing is call Mahesh and he's the IT director and say, fix it. Okay. So that's the easy thing to do. But I think the challenge is more what we have to do is when you talk about new technology, you have to understand few things. One, is it compatible with what we are doing? Will it be compatible 2 years later, 3 years later, 5 years later? And you may not know, but whatever is the knowledge you have today. Second thing is, if we do this, are there any alternatives which are giving similar solution, but in a different software? So that, you have to scan the horizon. And third thing is, you have to ask, as a leader, you have to ask more and more questions. So the more questions you ask, sometimes even the team, in order to answer the questions, will get more clarity. And they may drop the idea at that level. So even though I don't know, I'm not an IT expert, but if you ask a couple of questions, they will figure out the answers themselves. So that is one thing. But I think the key thing here is to understand that this issue of interoperability will be a problem in the next few years. We will have a few hits and misses. But I can tell you that in our hospital, without giving you the detail, we have now embarked upon a digital transformation journey. Hopefully, in the next 3 to 5 years, we will be a smart hospital, a smarter hospital. And so with the external consultant, Big Four, so that journey has started on what we need to do, what should be the basic software, what should be the bolt-on software, what will be the interoperability, what will go on where. So it's a very big exercise. And I can tell you around 100 people from our hospital are involved in that exercise with the external people. So it's not an easy thing. But the answer to this is to understand that it is an important thing. It's to assign the priority, assign the resources, and let people figure out the answers and come with that.
Thank you, sir. How comfortable is the team to add on devices, sir? If suppose like the device that is there in the ground floor OPD. You, sir.
Oh.
It's your hospital. We saw what.
So I have to tell you, all of us in this room, we love a new gadget, new phone, new AirPods, new anything. Doctors love the new equipment. Everybody loves new gadget. But I think I have told this many times in other forums internally that I'm a very old economy guy. I will not change easily. So unless, and I'm conservative in the sense that unless I see the benefit, not do. So I think it is sometimes okay to let people come up with new solutions, because unless you let them come up with new solutions, you won't know whether it's working or not working. And people will make mistakes, but I think the trick is to let people come up with new ideas, and then we'll see how it goes.
Yeah, thanks, sir. Thanks a lot. Rajkumar sir, you come, I mean, all hospitals are different. Mine would be different. If I start giving my examples, I'll also elaborate something very differently. You also come from a hospital which has a very rich history and rich tradition, sir. But challenges would be different, isn't it, sir? So what would be the challenges when you talk about technical ecosystem if you want to implement in your kind of a setup, sir?
Uh, Thank you. That's a great question. In fact, I, as a leader, we have our problems are certain different. You know, uh, there is always a resistance to change. From right from lower staff to the middle level people. But you have to overcome that resistance with the usability of that device and the importance of that device. So all those things, training and more training. We emphasize on those trainings, and also we are also getting an external agency with whom we are working closely for this digital transformation in our hospital as well. And we have just begun. In fact, they may be a little ahead. We may be just following them. But we have also had an
Working on
external
that.
agency. We are working with them. So, but there, as a leader, I asked some dumb questions. In fact, to evaluate the software, because always I ask some practical questions, and they have to come out with practical solutions. So that's how we are, going ahead. We have to overcome those challenges. That is the need of the hour.
Thank you, sir. Thanks a lot. Rahil, to you, if we actually move on to the brass tacks in technical technology, if you talk about data analytics, if you talk about AI, ML, those artificial intelligence or machine learning, if we use that, are there any potential challenges that you envisage or think of? Or are there any ethical consideration if we talk about these technology in our healthcare database as such? Can you elaborate? I mean, can you just talk
Yeah,
on
sure. So every organization today, whether in healthcare or outside, has to be data driven. So there is no escaping from the fact that data analytics are going to be a larger and larger part of what we do. A lot of the vendors we work with now have analytics software that they provide that allow us very easily to identify uh, parameters like reagent efficiency, turnaround times, percentage of auto verification versus manual verification, things like that. So that change has to be adapted by users, right? And eventually the users will see value in it, and it won't be too difficult to drive. My concern with a data analytics driven organization is where all that data is flowing to. So as data is shared and it goes across more and more stakeholders, maintaining the integrity of the data, de-anonymizing the data, or anonymizing the data rather, becomes very critical. So just if one implements a data analytics strategy in the organization, at the same time, there has to be a good engagement with an IT vendor to understand where all that information is going to flow to within and outside the organization and having some control over it. Coming to AI, both in lab and radiology, we have seen AI show some very promising results. We're still in early days. Today, AI is more of a diagnostic tool to assist the pathologist or radiologist in being more accurate or being more efficient in releasing results. It isn't really being given to the end patient. I mean, a lot of times when we use AI in our practice, the patient doesn't know that the radiologist has referred to an AI-driven report as well before issuing the final result. But my concern is the day AI flips and it becomes consumer driven, where consumers can use an AI application to upload, let's say, the past 10 years of medical data and imaging reports and lab results. And then suddenly AI throws up a diagnosis or a prognosis or a health prediction that is conflicting with what their primary care physician is telling them or what the radiologist has told them last year when they went for their MRI or CT scan. That's going to create a lot of challenges. We saw how IBM Watson, despite being very promising and it was touted as a next big thing, didn't. In fact, I think at Hinduja at some point IBM Watson was adopted. Okay, so it was here as an evaluation. I remember discussing with a couple of the oncologists, and it didn't work out because at some point it got to a level where the clinicians felt that AI wasn't able to account for some of the human interaction that allowed them to have a little bit of a gut feel around the diagnosis of the patient, which AI could not capture. Cost was another big barrier. Today, all these solutions in the diagnostic space as well cost a lot of money, and it's difficult to really get an ROI around it. And then, of course, when you use these algorithms, it's important to see where that software is residing. Everything that we're doing today resides on our local servers. That's the condition we have with the vendors. But as this scales and larger vendors come into play, there's going to be a greater and greater push to push everything in the cloud. The moment you do that, again, your data is going out of your organization, and one needs to be very, very clear on how that data is going to be used and where it's going to be stored. So some security concerns there.
Yeah, I agree. I mean, with cloud computing coming in the fore, I mean that's the most convenient if you talk to a technologist. But yeah, the issues about ethical consideration as we are referring to would possibly be slightly more difficult to control on.
Yeah, don't forget the regulatory piece as well. Today, I think India prohibits data from being stored on servers abroad. A lot of these vendors, host their algorithms in cloud where the servers are not within India. So again, there is some a lot of black box or gray zone at the moment from a regulatory standpoint.
Thanks, Rahul, for your input. Aparna, if since you actually run a chain of labs, how do you pursue, if at all, there's a AI tool? Will it help, or will it have different kind of challenges for your kind of a setup?
AI tool today, I think we are using in our labs already. Like if you look at a CBC analyzer, which is a 9-part diff, it's already using AI. Even in the smallest lab. So it's going to be a boon partly. I think to every coin, it has two sides. We had a CME, Suvin, in Dule, and there are only 8 MD paths and almost 112 technical labs, no MD paths. And they were scared to hell. What is going to happen? Are we going to remain or perish? AI was just spoken on Facebook and other places. But I said, boss, you are already using AI. We are not going to perish unless, like all our panelists are talking here, he's talking, unless we really look at, like he says, I think the data security, very important. There are people who are waiting to catch your data. At the same time, you also need to grow. You cannot have a turnaround time of a CBC of 5 hours. People are not going to stand with you. So I think interfacing, the basic things like I told you, a decent software, having an auto email, these are the basic requirements which are also part of AI, which needs to be implemented in 2 and 3 parts of the city of our country. Apart from that, inventory management, as Rahil said, is very, very important, because with AI, if you are able to look at inventory management, sample sortings, lot of our time, what I use in sales and marketing and looking at my PNLs can be better. So I definitely feel that it will be a boon if we are using it with caution. 100%.
Agreed. With the today we are in the age where Gemini AI has flopped, and you are hearing various inputs on those particular aspects. Now coming to various, digressing from what we are discussing, there are various setups internationally, specifically US. I happened to go through the Mayo Clinic setup, and they have a very rich tradition of imbibing the technology and technical from academics as well as the service point of view, into their own practice. Especially radiology took the cake because the head of AI is the radiologist himself. So, and they have been able to not only test the modules, not only validate the modules, create the modules definitely in the first place, and then start validating in their kind of spaces, clinical spaces. I think over a period of time, what has happened is that we are only testing the modules or services that comes to us, the technology that comes to us, and we try to set and test it in our kind of a clinical setting. I don't know whether that will work, or possibly investing in more collaboration say probably with IIT or some other such institution, and creating, looking at the problem areas and build technology and strategies as well as services towards our clinical problems. That possibly would be a solution. Now, going to the last set of questions, I mean, I'll move the other way, sir, this time. I'll ask Rail now. Rail, what's your take about how do you envision this particular issue of smart hospitals? Do you see it working? Do you see it not working? Or you see some things in the horizon? And this question is for all the four panelists. So we prepared with So Rail gets the benefit of being the first answer.
No, so it will definitely. Yeah, but like I said, we are looking at one component of an overall hospital's requirements are far more immense. And I have no doubt that all leading hospitals will eventually get there. What Gautam mentioned sounds amazing, where he's got a consultant on board to drive it. And most importantly, what he said is there are multiple stakeholders from within the organization taking responsibility for it. Otherwise, it just ends up being a report on paper. I would imagine that the future lies very fundamentally, first and foremost, in getting all the different systems within an organization to connect to each other and speak to each other. Even within a small organization like ours, we have HIS, we have PACS, we have middleware software, we have an analytics software. They all come from different vendors, different standards, different formats. The sonologist doing an ultrasound at our center will recommend advice CT urogram for further follow-up, not knowing that the patient is next going into the CT department for a CT urogram, right? So you end up looking really silly. So even solving small things like that, where different systems talk to each other, every person in the, at least within the network, has access to all that the patient is going to undergo and past results of the patients as well. That's a good first step, I think, to take. Second, we can look at building a data lake kind of concept where all these systems can dump their data, and then we have software now available to make sense of data coming from different sources and then putting the output together in a meaningful manner where you can make sense out of it. The third piece is the patient piece, right? So I think just doing all of this will help the consumer to feel so much more connected. We heard from Dr. Aparna and all these examples of things like getting WhatsApp reports, getting trend analysis of previous results. This whole adoption towards smart hospitals is going to make the patient much more empowered, and whichever hospital gets it right first is going to have enduring patient loyalty. So while it's going to be a lot of hard work, a lot of cost, a lot of effort, the rewards will be significant and enduring.
Good points, actually, you have taken up, Rail. Over to you, Aparna. Anything that you...
So I see vision. I'm always optimistic. So I see holding hand of Caho and people like him and these guys to hold my hand into 2 and 3 cities where I identify many more mini Hindujas and mini NMs and mini Bombay hospitals under different name, and converting this journey into smart hospitals, and Vijay Agarwal sir watching from the tower to me. And yes, I think 100% we have to move towards that direction.
See, I think government of India has already moved towards that direction, where they have tried to create they are in the process of creating a digital platform. So for the patients, the doctors, the clinicians, the hospitals themselves, they have already working towards it. It's high time that we also start gearing up ourselves, whether when the platform is ready and when it becomes the need, or possibly it would be, we'll feel forced to do that then. It's better that we reach a stage of some maturity where we possibly will be able to take it up. That's a small take. But yeah, government of India is also going towards that, and possibly that will penetrate across the tier 1s, tier 2s, and tier 3s of the towns in the... Over to you, sir. Rajkumar, sir.
See, Government of India has taken that step, one patient, one record, Abha number, and this one. So that initiative is from the Government of India. But at the hospital level, we have to integrate our own systems within the hospital, the lab system, the MIS, the HIS, then the radiology imaging, all those things, they have to be integrated. And the physicians should be able to, at the click of a button, they should be able to retrieve those records from the patient perspective. And of course, hospitals need to talk to each other also. Because if a person takes a first opinion from Bombay Hospital and wants to come to Hinduja Hospital, they should not duplicate those records. They should be able to, retrieve his records from the this one with the unique identification. So that is what the Government of India initiative is there. And in that process, the hospitals have to gear up. And we are in that process of evolution, I must say. And of course, it's a long journey, actually, what we envisage. And of course, in my opening remarks, I had mentioned that, probably NABH will come out with some evaluation criteria and some standards for smart hospitals. And of course, Caho has that opportunity for training, this one. And then, we will see more and more smart hospitals in the near future.
You feel more maturity will come in and sink
absolutely.
in as soon as we move ahead in years to.
Yeah, but the main problem is about the integration and these softwares, various in bits and pieces. So they have to be integrated. That is the biggest challenge in this digital transformation.
Yeah. Thank you, sir. Thanks. And final words for you, sir.
So I agree with whatever all the other panelists have mentioned. So I just want to add one more thing, that there is effort going on in the country by various foundations, and you heard about the NABH digital standards. This was also, one foundation has helped. They've also initiated work with MUHS to do a course in digital health. So what is happening is what you mentioned in the beginning, the from 0 to 7 scale. What we have to see is that many hospitals in the country will probably be at 0 or 1. And so they first need to know why it is important, then start on what is to be done. So I think some of us here in this room, we already know that we are already making the change. But to tell people that you need to make a change is also important. So that is first thing which is going to happen. So I think it's going to happen maybe few hospitals in the next 3 to 5 years, but over a period of time with what Dr. Patil mentioned about ABHA hopefully will be like UHI instead of UPI. So we will have that, smooth transfer of data. But I just want to add one thing that, for word of caution for all the people who are in the hospital and, in this space, that we need to remember that this digital and AI and everything else is only a tool. It is exactly what a paper and pen is. It is a tool to give the right clinical prescription to the patient. So it has to be only used that, it has to measured against the clinical outcomes, against the efficiency, and not because it is a great looking product. And so this smart hospital should not be forgotten, that it has to be combined with the reason why we are in existence, about the patient, the compassion for the patient, the empathy, and the ability to treat patients properly. So that, along with the digital hospital, will really make it a smart hospital.
Very well said, the last, especially the last line, because any component for any smart hospital will have three components. One is the technology. There's services, and third is the goal. Unfortunately, most of us look into the technology, AI and that virtual reality and things like that. But we forget that the most important component in these three was the goals. The goal, why you actually set out to have a smart device or smart technology in the first place. The technology is the last. Because after goals should be the services that you wish to render, and then you should search for the technology which will help you get to your goal using those services, and that should it be, rather than the sequence other way around. I think with that, I'll if there are any questions to the panelists. Yes, sir.
So just one comment, and also I think from a question point of view, I would probably ask a question on adoption. And Gautam, you mentioned that right now you have engaged with the consulting firm, and Rahil, I know in your case also you are pushing ahead on a lot on technology. But from a common point of view, when you think of smart, hospital, and this discussion has been on global discussion. I think my own experience or my own reflection has been that three reasons why technology or data needs to be adopted. If it improves patient outcomes, if it reduces costs, or third, if it improves healthcare practitioners' workflow, if it makes them more efficient. Those only three reasons why technology and data should come into play. So that's what I have learned. So I'm just sharing with the group. The second part of it is adoption of technology. And there are two key stakeholders on adoption of technology. One is the patient, another is the healthcare practitioner. And your reflections and comment on how that transition is taking place. We've seen UPI getting adopted at a very fast pace. What's your experience that when ABHA or Universal Health ID, etc., would come, what would be the rate of adoption? How things would change? What's your sense about it? That's my question to you.
In fact, I'll start from my end itself.
ahead.
We have some small experience of how we face as a challenges in terms of adopting certain technologies. Let's look at EMR, EHR. We have seen that whether it's OPD, whether it's IPD, whether it's ICU, the adoption has been very difficult to for even a young team to adopt. We would perceive that the younger team would possibly adopt technology very fast, but there is always this resistance, as one of the panelists was referring to. It's very difficult. Possibly culturally, it's becoming difficult for some of the institutes, at least part of them, to adopt it. But there are others who will be part of your team who will adopt it so smoothly, and they'll possibly look at the process efficiency that has already come in their whole process, whether it's OPD or whether it's IPD. But yeah, there are challenges because we find the spectra of team that works with us is not alike. So everyone have their own ways of dealing with that. Anyone can
I think I have seen myself when we were looking at one of the hospitals. Again, I'll give my examples in in the periphery called Ahmednagar, where even a basic thing like, sir, they were asking about when you're admitting. We did the audit of that hospital in the terms of preparation for NABL, and the basic thing like, we think Aadhaar card, Digi Yatra is very common, isn't it? All of us are at the line even in Digi Yatra now. But so I was like, I freaked out when I said, okay, let's look at the sample flow. Registration kidhar hota hai? So there is a huge queue in Ahmednagar. And the basic thing which is given for me, Aadhaar card, it's there in my purse. But वो मिलने से भी शुरुआत में challenges आ रहे हैं. I'm not going against smart hospitals or smart labs, but I think this is the real India, which is yet to be even scratched. So that's why 5 years is very good in Mumbai or Delhi or big cities. I would like to be the process holder of this journey, where when Aadhaar card is asked, the question on the face is as if I'm asking something else. And this is what I have witnessed just 2 weeks back. So it's going to be very, very tough, very tough. But we have to enter the journey. Yeah.
I'll give you an example, and my colleagues here will tell you about the adoption. So firstly, hospitals are by design, very conservative. So we will adopt very, very slowly, because you have to take care of all kinds of things which can go wrong, which will never go wrong. So that is one reason why hospitals will be late adopters. Second thing is the patients. The patient also from SEC-A to different categories will have different rates of adoption. Now, UPI was successful. It existed, but it was not successful till demonetization happened. After that, Majburi mein it was successful. And now, of course, it is successful. So in our case, whether UHI will be successful or not, I cannot say. I'll give you an example from our hospital. And my colleagues, Joy, Mahesh, they know what I'm talking about. 10 years ago, we introduced this online registration, online appointment service. And you can pay, register at home, pay, and then you don't have to come and stand in the queue here. So you save and you go directly to the doctor's room. So intuitively, it's the right thing to be done. But our adoption went up, then went down, and for a long time. And we found out many reasons. So there were a couple of reasons, and those reasons were, maybe I can discuss privately, but very silly reasons why patients were not willing to pay online for the appointments. So there are multiple reasons. Now, of course, it is fixed and everything. We have understood the patient psyche and we've covered that. But I'm saying those challenges will exist. For UHI, it will exist. It will exist from the user point of view. Means I may not want to share my records from Hinduja Hospital to Bombay Hospital. I don't want Dr. Patil to know. I want to test his knowledge whether he has diagnosed me properly. So, all those things patients will check. So,
Thank you. The point I wanted to make was that while we talk about technology, the adoption challenge. You're
a big thing.
You're seeing with a 65-year-old patient.
Yeah.
And you expect them to be tech
Oh,
savvy.
no, he's not going to use it. Yeah. Definitely. Yeah. He's going to ask his son, daughter something. See.
There is a question.
Good afternoon, everyone. Again, this is not working. So, am I loud enough?
Yes,
Yeah,
you are.
Yeah. So, my question first is to you, Gautam. Just to understand, since you're leading the entire smart hospital journey from the front, right? I mean, you being Hinduja, how much are you thinking about interoperability? Because recently I was chatting with somebody in the US who's a senior, with a large healthcare system there. And I was like, what do you think about India now? And, we are going on the digital journey. But what do you think would be the problem for us in the years to come? And the first thing that came out of his mind was, what are you guys doing for interoperability? So, as you're leading the journey from the front, how much are you thinking about interoperability? And yeah, please go ahead.
You're talking about between me and Bombay Hospital. So that I don't have to worry. Government of India is worrying about it.
Yeah.
So that is not monkey on me. It's on government's back. So they are developing the exchange. So eventually through the healthcare exchange, my data will go to the exchange and go to him. And so that is not my problem. My problem will be that within the hospital, I fix and ensure that each system talks to each other. So that I think we are now on a journey already.
Oh, perfect. And ma'am, to you, Dr. Aparna, as Caho, again, since you advise the hospitals to be standardized in terms of their processes, how much are you stressing in terms of that the patient experience through different healthcare systems remains the same?
In fact, that's the purpose of harmonizing and like today, what you saw, Center for Quality Promotion. That's the purpose, not only in the hospital, everything involved in our chain of healthcare. And it means I represent the lab section, but I think that's the vision of what Caho stands for. Right from the nursing excellence to waste disposal to cyber security to everything, the language is patient safety, efficiency, and communication through each department or even interdepartmental will be through training, retraining, and that's what we are doing around the year. Yeah.
Thank you.
Thanks for all the questions. And I think I can feel the restlessness now, you can sense it. As soon as the sense went, we are probably concluding there was some sense. So, okay, let me conclude. Thank you, Gautam Khanna, sir. Thank you, Rajkumar, sir. Aparna, madam, and Rail. Thanks a lot. It was wonderful interacting with you and for your wonderful inputs. I'm sure we go enriched with those inputs and helps us understand the concept of smart hospitals. Over to you, Swapnil.
Thank you, Suvin. I will request Suhin to please come ahead and hand over the placard to Mr. Gautam Khanna. I think it was a very interesting session. So a round of applause to banta hai, please. Dr. Rajkumar Patil. Let us hear for Dr. Rajkumar Patil, please. Dr. Aparna Jairam. Mr. Rahil Shah. Some of that section is not clapping for some reason. Now I request Mr. Joy Chakrabarti to please come and hand over the token to Suveen Shetty. Wonderfully moderated session, Suhin. Thank you so much. I'll request all the panelists to please come ahead and we'll have a group photo. Bags. Thank you, panelists, for a very informative session. Okay, the round of applause can continue, please. Now I will hand over the next session to Ms. Bhavisha.
Ladies and gentlemen, as we come to the end of this wonderful one-day regional conclave, our heartfelt gratitude to the two collaborators of this event, Dr. Vijay Agarwal, Dr. Lalu Joseph, who could not make for today's session, and the management team of Caho. Thank you so much. Mr. Gautam Khanna, our CEO, Mr. Joy Chakrabarti, our CEO, and the management team at Hinduja Hospital. To both the teams for collaborating and putting up a day of great learning, deliberations, and interaction. Thank you so much. Our heartfelt thanks to our sponsors, Pfizer and Sun Pharma, for their unwavering support. A big round of applause for the sponsors. No event can happen without the sponsorship. Immensely grateful to all the panelists for sharing insights that are beyond AI, the moderators for setting up relevant context and making the discussion so powerful. And to our wonderful delegates, all of you, a big round of applause for all of you who gave overwhelming response to this conclave. In fact, at the end, we could not confirm a few registrations because the response was so good. And also you contributed to this discussion by asking some intriguing questions. So thank you so much. Last but not the least, putting up a conclave of this magnitude requires very careful planning and execution. We thank our CEO, Mr. Joy Chakrabarti, for his constant guidance and the ever enthusiastic organizing team standing all here. You have seen them all for their relentless efforts. Your feedback is very important. So please look behind your these cards and there is a feedback QR code. Please use it. We are going paperless. One more initiative. So please do give your feedback. And also before you leave for the day, please do enjoy the last tea coffee served outside. Last for today, yes. And do collect your participation certificates from the registration counters where you had the registration in the morning. Thank you so much and have a great evening. Thank you so much.